audio is perfect. So, okay.
Welcome to Pure Endoscopic Neurosurgery Summit. I'm Dr. Komatsu from Fujita Health University Bantane Hospital, Nagoya, Japan. It is a great honor for me to be president of this seminar. As we know, endoscopic neurosurgery provides excellent visibility and minimally invasive surgery. It is gaining acceptance and popularity as an important modality in neurosurgery in the past few decades. In this seminar, 30 experts of endoscopic neurosurgery gather online from all over the world, and they will present state-of-the-art endoscopic neurosurgery in their field. This is a very rare opportunity that famous endoscopic neurosurgeons gather in one seminar, and I think this is a very exciting meeting for everyone. The presentations include ventricular surgery, endonasal skull-base surgery, cylinder surgery, keyhole surgery, and spine surgery. Online discussion will be held at the end of each session. I think all pure endoscopic surgery is based on precise anatomical knowledge and meticulous surgical strategy. Also, surgical devices and instruments are essential factors for endoscopy. I believe each speaker will present important concepts and how they conduct successful surgery. I hope this seminar will be valuable and fruitful for all attendants. Finally, I greatly appreciate Professor Yoko Kato for her support to this seminar. Thank you.
Welcome friends. It is my great pleasure to welcome you to this Pure Endoscopic Neurosurgery WEB Summit organized by the WFNS Foundation, Asian Congress of Neurosurgeons and the Minimally Invasive Neurosurgery Society under the patronage of Dr. Yoko Kato, and I am very happy to declare the scientific program open. You can see from the whole program that we have a lot of luminaries from Asia, also from Africa, from South and North America, and Europe as well, who are going to contribute to this program in their chosen subject of their specialty. And I'm sure you will have a very enriching and enjoyable experience over the next 2 days. I'm particularly happy to see a lot of friends. The pandemic doesn't seem to be ending, and hopefully we may be able to meet some of us at least at the WFNS in Bogota. But currently, I think virtual meeting is our best way, and this gives us another opportunity to meet virtually over the various subjects which we like to discuss. Apart from lectures, I'm sure all of you will join and have a good discussion in the designated times which are available. I would like to thank Professor Yoko Kato for this organization and her patronage to these activities. I think educational activities has become her main motto and life's mission, and she has really brought about a huge kind of a change in the way the education has reached various parts of the world. And I'm sure with this web meeting, we will be reaching all the corners of the world, and with so many interesting talks by esteemed faculty in this field, everybody's neurosurgical knowledge as well as expertise will grow further. I would like to thank all of you for joining this, for the lecturers for their contribution, and those who are listening to us for their presence. And I hope this turns out to be a very enriching experience for all of us. Apart from the participants, the faculty interaction also is extremely important, and I think we all learn from each other at such occasions. So once again, I would like to thank Professor Kato, the organizers, especially Dr. Boone, and our vice presidents, as well as the main person behind this meeting from Japan, Dr. Fuminari Komatsu, and take your leave for now. Enjoy the meeting, and I'm sure we will meet again during various sessions and towards the closing ceremony. Thank you.
So it is my great honor to welcome all of you for this time that we planned the pure endoscopic neurosurgical, especially the focus on the surgery. I and Dr. Deo Fujari is assistant of President Fuminari Komatsu. He used to be the study of the endoscopic procedure at the Vienna University. We are very, very looking forward to have so many eminent guest speakers who are very specialists of the pure endoscopic treatment for the many neurosurgical patients. I think 2 days you will get more information and scaled knowledge about pure endoscopic surgery. All of us, I think. Thank you very much.
Thank you for the invitation, and it is a great honor for me to be here. And today I am going to talk about the proposals for a new style of neurosurgery that combines exoscope and endoscope. I am working on minimum invasive endoscopic neurosurgery for about 20 years. I started this endoscopic keyhole approach since 2007. So initially, I was doing very simple cases like this. But by development of the tools, gradually we are doing complicated cases recently. Yeah. So in 2019, when I moved to Aichi Medical University, we have got 3D VTOM by Stoltz. So we started to use exoscope with this approach. So since then, we are doing almost all the scheduled cases of brain tumor cases with this exoscopic and endoscopic approach. So we can switch the viewpoint of outside and inside the surgical field to obtain an appropriate view. And surgeon and the scopist proceed the surgery together. This is the 3D VTOM. We wear the 3D glasses, and this is the hand controller. We can adjust the focus and zoom with this switch. The advantages of exoscope are, first of all, it is small. It is much smaller than microscope, and there is no big mess above the surgical field. It means good handling And also we can look at the surgical field directory. And second of all, a free visual access. So this allows the comfortable posture for both surgeon and patients. Even horizontal visual access or looking up visual access are available. And as the scopist will control and adjust the position, focus, and zoom, the surgeon can concentrate on the surgery. And one of the most important advantage is exchangeable to an endoscope whenever we want. Because this is the heads-up surgery, we are looking at monitor, even with endoscope or exoscope. Still, there is some disadvantages. Insufficient images with a high magnification, visual access and optical access are slightly different. And because this is the digital image, so sometimes the whiteout will happen, and adjustment of exposure is a little bit complicated. But these problems are resolved by scopist adjustment, or the image problem is resolved by the endoscope. What about endoscopic keyhole surgery? The advantages are from a small entrance, and we can look at the wide viewing angle, and underwater surgery, we call it wet field technique, is available. And the drawbacks are there is a confliction of tools with the endoscope itself. And sometimes the shallow part of the surgical field can be a blind area. So we use curved or flexible tools to avoid a confliction. And also a scopist will control the position to avoid the confliction. And sometimes the exoscope will resolve the shallow part manipulation. The scopist provides a precise adjustment of the endoscope to maintain a good field of view and to avoid a clash of instruments. And the scopist will move the endoscope along with the instruments to prevent tissue damage. And always put the finger on the shaft to make a meticulous movement of the endoscope. These are the curved or flexible tools. And this is the setup of our operation theater. And this is the hand controller. And this is the scope stand. We can put another scope here. And this is Union is a floor standing pneumatic holder. This is the case of epidermoid cyst at CP angle. and the lateral suboccipital approach, keyhole approach, was performed in supine position with the patient's head rotated 90 degrees. First, we do approach with exoscope. After making a 2 centimeter keyhole, the surgeon is looking at the monitor in front of him, and the scopist is control the exoscope. And through the small keyhole, the dissection of tumor is done as much as possible. After some reduction of the tumor and dissection of the tumor, we change the scope to endoscope. To look around the corner, so by endoscope, we can get a much wider visual field, so we can look around the corner. So we are continuing the dissection of the tumor, preserving every structure, normal structure like vessels and nerves. And sometimes we use an angled scope. This is a 30-degree angled scope to look at the internal meatus. And then again, we change to the exoscope and close the wound. Okay, I show you another examples. This is a middle fossa meningioma. In this case, when we do a microsurgery, we always remove the zygomatic arch to make a craniotomy just on the tumor. But in this case, by using an endoscope, we can remove the tumor like this, so we don't need the zygoma cutting. So we could remove the tumor with a small craniotomy. This is the case of torcular meningioma at the confluence of the sinus. So in this case, it is very difficult to manage with microscope, but with endoscope, it is very simple and easy. From a small craniotomy, we can look up by the 30-degree endoscope, and we can control the attachment. This is another case, 83 years parasagittal meningioma. Because this patient is very old, so first we try to try just a reduction of internal decompression of the tumor, sparing the breaching vein, of course, and diploic vein. Actually, this patient has a huge diploic vein, and also the breaching vein just above the tumor. So avoiding them, first we did an internal decompression, but actually the tumor was grew rapidly in 1 year. So we changed the plan. So we planned a total resection of the tumor from frontal side with this craniotomy. This blue circle is represent the major breaching vein, and the approach from frontal side was performed. And we made about 6 by 3 centimeter, 3.5 maybe, craniotomy at the frontal side, because we need longitudinally a relatively long craniotomy to access to the tumor from frontal side. So now tumor dissection is performed by an endoscope. The arachnoid membrane was almost gone, so there was very tight adhesion between the brain and the tumor. So now we change to the, after some amount of internal decompression, we change to the endoscope, and now dissecting the tumor from the brain. So now I'm dissecting the tumor from the most important part of the brain, the motor cortex on the back side of the tumor. So when we insert the endoscope, we can see the surgical field precisely, especially when we get closer, so we can enlarge the image as we want. So now that there is a border between brain and the tumor, there was no arachnoid brain in this case. So now the tumor detachment from the convexity side or the parasagittal area. So almost the tumor was dissected from the brain. So and the tumor remnant on the parasagittal area is removed. In this case, mostly the Simpson 2 grade resection was achieved. Now I'm continuing to resect the tumor at the Fox, but I left the attachment. Okay. So almost tumor is gone, and in the irrigating saline, we are confirming the hemostasis. So only endoscope can do the water field observation, and we close the wound. This is a post-operative image showing almost a total resection of the tumor. This is a case of petroclival meningioma with its extending above, compressing the pons and the midbrain up to ambient cistern, and also it is extending into the Meko cave. So with the suboccipital, lateral suboccipital approach, we did surgery. By using an exoscope, we decompressed the tumor, and by using an endoscope with a wide viewing angle, the detachment and the dissection from the brainstem, and leaving the nerves, third nerve, and this is the PC, and the fourth nerve. We left every cranial nerves, and all the structure is confirmed, and we left a small part of the tumor at the and make okay, but otherwise we remove all the tumor and then the compression is relieved. This is the conclusion. Using exoscope and endoscope, the viewpoint can be switched between outside and inside of a surgical field to obtain an appropriate image. And these are advantages of exoscope. It is small and it has a free visual axis and it is exchangeable to endoscope anytime. On the other hand, the disadvantages are still insufficient image for a highly magnified view and a deep and a narrow area. So it will be resolved by the endoscope, which has the advantages of wide viewing angle from a small entrance and close-up observation and underwater observation. But it has a disadvantage of a clash of instrument with the endoscope. So ingenuity of tools and scopists will resolve the clashing problem. Okay, thank you for your attention.
Good morning, everyone. I'm Dr. Takeuchi from Nagoya University, Aichi, Japan. My university is located in the central part of Japan here, and this is my hospital. This is my CV. I only performed the endoscopic surgery for 10 years. No microscopic views. Today's my topic is endoscopic cylinder surgery for deep-seated lesions. This is today's topics. Firstly, I want to introduce cylinder surgery. Surgical treatment for the deep-seated lesion is still challenging. Surgeons should pay attention not to damage the normal brain during removal procedure. Various kinds of brain retractor was invented, and in this review article, tubular retractor was introduced as the most successful retractor. That is because in usual spatula, the retraction pressure applied to only one direction that can be a cause of brain retraction injury. But in tubular retractor, the retraction pressure distribute evenly, so we can reduce the risks of brain retraction injury. The cylinder surgery was invented by Professor Kelly in 1988. They used a 2 cm diameter cylinder and inserted it with a stereotactic maneuver. And the visualization was performed with a microscope. Professor Kassan reported the endoscopic use in cylinder surgery with successful result. They used the 11.5 mm translucent cylinder. After this report, various kinds of cylinder was developed specifically for the neurosurgical field. However, in recent years, there have been more and more reports of cylinder surgery using exoscope instead of endoscope abroad. That is because there are some disadvantages of endoscopic cylinder surgery. The most important disadvantage is occupying the surgical space by endoscope. That is the cause of interference of the instrument. As for cylinder surgery in Japan, most of the reports of cylinder surgery are using endoscopes. This is largely due to the fact that cylinder surgery in Japan originated from endoscopic hematoma removal surgery. The endoscopic hematoma removal surgery was invented by Dr. Nishihara in 2000. Very sensational reports of hematoma removal using a 6mm cylinder, but it is now widely used in Japan. Since it is difficult to obtain optimal view from the outside with a small diameter cylinder, the use of the endoscope is advantageous. It is thought that the use of endoscopes was easier to generalize because we started with small diameter cylinders compared to other countries. Next, I want to introduce our surgical techniques in cylinder surgery. These are cylinders available in Japan and other countries. We mainly use neuroport and view site, this one or this one. This is how I introduce the cylinder. The position and the angle of the cylinder are very important to reduce the brain damage. Endoscope tip is calibrated by navigation system, and I usually use transparent test-up needle, this one. This test-up needle have a 3mm inner lumen, so we can insert the endoscope, 2.7 endoscope, into this test-up needle, like this. For doing so, we can see the tip of test-up needle with endoscopic visualization, like this. And we can notice the location of the needle with navigation guidance, like this. This is surgical maneuver inside the cylinder. The cylinder is held by assistant, and 2.7 or 4mm endoscope is inserted inside the cylinder. 1 or 2 thin instruments are also inserted very coaxially. And drip line is also inserted inside the cylinder to fill inside the cylinder with water. I call this technique as a wet fill technique. Removal technique inside the cylinder is divided into two: one-hand surgery and two-hand surgery. This is one-hand surgery. The endoscope and the suction monopolar are mainly used. The seize is held by assistant, and main surgeon holds the endoscope and the other instrument. It is possible to change the direction and the operation field dynamically by tilting the seize. So this surgical technique is very useful for hematoma removal surgery and saccable tumor. But we can only use the one instrument, so it's not so good for the hemorrhagic tumor and hard tumor. In two-hand surgery, cylinder is held by assistant like as a one-hand surgery, but the endoscope is held by an endoscope holder, like this one. I usually use a pneumatized endoscope holder. Main surgeon holds a suction tube or bipolar and any other instruments. In this surgery, we can perform the precise dissection, so this surgical technique is useful for eloquent area tumor and hard tumors and hemorrhagic tumors. But the surgical space is very narrow, so it's very difficult. If you use a larger diameter seize, surgical maneuverability improves, but the surgical corridor becomes large. So it depends on the cases. I also introduced the wet field technique. Endoscope gives bright and wider view even underwater. This is inside the brainstem, but we can visualize very small vessels inside the brainstem, like this. And water pressure expands the tumor bed very naturally. Look at this one. This is dry field, and this is wet field. So the surgical field can expand with water pressure. We can observe the entire tumor bed without any additional retraction. It's very useful for a larger diameter tumor. And it is also useful for finding the hemorrhaging point. Like this. We can coagulate the hemorrhaging vessels with pinpoint coagulation. It is very important for eloquent area tumors. I also use specific surgical instruments for cylinder surgery. This is malleable forceps and malleable dissectors and very thin bipolar coagulator and multifunctional suction tubes. Those I invented and used. In cylinder surgery, adequate instrumentation is also important because interference between the surgical instruments and the endoscope easily occur. But rotating movement like this one and opening closing motion of the forceps does not require the shaft movement. So this movement can reduce the interference between the forceps, instruments and endoscopes. Now let's move to the case lessons. First case is a 28-year-old female appeared with headache. She had a left frontal lobe tumor. MRI revealed a well-enhancing mass in her deep left frontal lobe here. This is surgical planning. In this case, tumor was located in the deep left frontal lobe. Therefore, we have to pay attention not to damage the subcortical fibers. We thought cylinder surgery can reduce the size of the surgical corridor and reduce the risks of fiber injury. However, the tumor was well enhancing. That indicated the hemorrhagic tumor. So we chose the 10 mm diameter cylinder for bipolar coagulation. 10 mm cylinder was inserted under navigation guidance. The tumor had a relatively clear border. Therefore, we dissected the tumor from surrounding brain with forceps. After dissection, insert the surgical unit for keeping the surgical plane. Then tumor debulking was performed with suction monopolar coagulator. Generally, glioma can be softened with coagulation. Now, I dissecting the tumor. This is the bottom of the tumor. There are many feeding arteries. We coagulate them with bipolar coagulation. We remove the tumor like this. Now we encounter the left lateral ventricle. All tumor is gone. After the removal, wet field technique was applied to confirm the complete hemostasis and total removal. plasty was performed, and corridor is minimal, less than 10 mm, like this. The next case is 21-year-old female, and she appeared with left hem paralysis and mild aphasia. MRI revealed a cystic mass in her left frontal lobe here, under the motor cortex. In such case, we performed the MRI DTI to detect the cortical fibers. We can see the superior longitudinal fascicles as a green line, and the corticospinal tract as a yellow line. So the tumor was surrounded by very important subcortical fibers. This is surgical planning. In this case, safe surgical route is quite limited. But fortunately, this precentral sulcus is relatively deep, and I thought we can access the tumor through this sulcus, like this. 6 mm diameter cylinder is small enough to insert into sulcus with minimal brain damage. But we have to perform the detection of motor cortex, so 3 cm craniotomy is required. This is surgical video. We performed the 3 cm craniotomy, and direct cortical stimulation was performed to confirm the motor cortex. After that, this is a precentral sulcus. We dissected a little bit. After that, I inserted the translucent test-up needle. This is the bottom of the sulcus. And now we encounter the tumor here. After that, the hematoma component was sucked up, and break the membrane and suck up the hematoma component. After that, I removed the solid compartment. After that, wet field technique was applied. Under this condition, we can see the cavanoma membrane like this. This membrane is floating, so it's very easy to find a residual tumor with wet field technique. The tumor was moved close to tree. After that, use the direct approximation to create easily. And such quality and
ICA, and nowadays I think transorbital approaches can avoid to cross ICA. Let's compare to the transcranial approaches. We performed the transorbital approach for removal of these tumors. I didn't retractions of the temporalis muscles. You can find that the very only defect of the greater sphenoidal wing. The outer surface is almost the same. You can find that only minimal and scars were left. And then let's compare to the endonasal approaches. Transorbital approaches provide direct view and short working depths. There is no need to cross the ICA, and also it can spare the VDN nerve, and it has very less CSF leak compared to the endonasal approaches. But disadvantages of transorbital approach include we still are unfamiliar with the orbital anatomy, and it has possible orbital injury. It's very narrow exposure and very small working volume. So it's very crowded, but we have to overcome these limitations. No pain and no gain. Let's see the anatomical structures. This is a recurrent major superior portions. We have to know the accurate location of the anatomy. And here, yes, this is based on the recurrent major artery and superior fissures. We know the anterior cranial and middle cranial fossa tumors and portions are divided. And finally, we can expose the meningo-orbital band. If needed, we can detach that one. I have experience of 100 cases of transorbital approaches. Most common pathology was meningioma followed by schwannoma cases. Let's see the surgical details. First, positions. Position is dependent on the physician's choice. Flexion or flat positions, we have to know the accurate positions. And also right-sided tumors, the surgeon should be stand on the right side of the patient, but the tumor is left side regions. The surgeon should be stand the left side. Let's talk about soft tissue step. The location of incision is very important. Compared to the infra eyebrow incisions, superior eyelid incisions has less and minimal skin scar. Higher incisions, higher scars we have to keep in mind. It's very important to know external eyelid anatomies. Most important structure is orbital septum, orbital rim, and orbicularis muscles. And after incision of the skin and orbicularis muscles, and then this is the suborbicularis dissections. Then we can expose the periosteum. After incision of the periosteums, this patient has the large cystic middle cranial fossa tumors, such as trigeminal schwannoma. After injection of local anesthesia, I incise the skin over the superior eyelid, then coagulate, and I performed suborbicularis dissections. It's very important to keep and preserve the orbital septum. Then lateral portions we can palpate the orbital rim. After incision of the periosteum, we could expose the lateral orbital rim and extend to the superior orbital rim. Then elevate the periosteum. Usually periosteum is connecting to the periorbital area. I place the sliced sheet. I drill the lateral part from the lateral to the medial part. Next step is bone work. We have to know the superior orbital fissure, inferior orbital fissure is very good, important landmark to open the greater sphenoidal wing, and then we can enter the temporal side or we can enter the frontal side. After removal of the lateral orbital rim, left side is the temporalis muscles, and this is superior orbital fissure. Then I drill the lateral part of the greater sphenoidal wing. Then we remove the temporal side of the bone. And this is the frontal side, and gradually we expose the meningo-orbital band, the periorbital and anterior side of the temporal lobe. Then I performed interdural dissections of the temporal side to expose the lateral membrane of the cavernous sinus. This is here. And then to drill the base part, then using the peel-off techniques, dura propria of the temporal lobe was detached from the lateral membrane of the cavernous sinus. Then we exposed the schwannoma mass. After removal of the bone, we performed transcavernous approaches. Supraorbital fissure and meningoorbital band and periorbital is a very good landmark. And then using the peel-off techniques, the lateral cavernous sinus membranes can be exposed. And then after opening the cavernous sinus, we can expose the trigeminal nerve. This is the tumor removal. Then using the sonopet, I remove the tumor. This is the space within the cavernous sinus. Then I try to detach the middle fossa tumors from the posterior portion of the tumor. Then this is a porous trigeminus. Through the porous trigeminus, and the tumor mass was extended to the posterior fossa. First, I removed the middle cranial fossa lesions. Then, this is a trigeminal lobe, the right side here. Then I try to detach the tumor mass from the trigeminal lobe and preserving the trigeminal lobe. Then remove the tumor. This is the final stages. This is the space within the cavernous sinus. I close the plug with the duragens to close the porous trigeminus, and using the allodermal graft materials, I closed it. Then we place the PDS. Then this is the final step. Postoperatively, whole tumors was removed. This is another case of trigeminal schwannoma mass. Trigeminal schwannoma mass involving middle and posteriorly extending to the posterior cranial fossa tumors, so-called dumbbell-shaped tumors. This is the origin of the tumor, and then you can find the disrupted trigeminal lobule thread. Similarly, I removed the middle fossa tumors within the cavernous sinus after removal of the middle fossa tumors. And this is the trigeminus. This is normal trigeminal nerve. Then I try to remove, not to avoid, not to damage it to the trigeminal nerve. And this is the brainstem. Then final step, using the duragens, I plug the outlet. Then place the megadermal graft or allodermal graft materials. In this case, using taco seals, we close it. Then for skin closure, 6-0 observable suture was done. This is post-op MR imagings and patient photo images on the post-op second day. This is another case of recurrent trigeminal schwannoma. We perform the same procedures, and you can find the B2 pathway, and this is oculomotor nerve, and after removal of the tumor, and then you can find the anterior surface of the brainstem. Using the same technique was applied. Post-op MR images shows gross total resection of the tumor. I experienced 25 cases, trigeminal schwannoma cases, and middle cranial fossa is very best indications, but dumbbell-shaped tumor can be accessed with the transorbital approaches. Another good indication of transorbital approach is meningospinoorbital meningioma. This patient complained of the left side proptosis, no cavernous sinus involvement. I performed the superior eyelid transorbital approaches, placed the celeste sheet to protect the periorbital, drill the lateral part of greater sphenoidal wing. In these cases, the lateral part of the meningioma is very difficult to access. So we take out the lateral of the rim, Then we obtain the wide working space. Then we access the lateral margin of the meningioma mass. Then finally we remove the so almost close totally remove the brain to meningioma mass. After large defect of the tumors, I place the fat graft. Then reposition the lateral of the limb. Post-operatively, all tumors were removed. And sometimes the removal of lateral orbital limb is very useful to obtain the working space. How to reconstruct? The first, I recommend the Duragens, then use the graft fascia or allodermal graft. For the meningioma or intraparenchymal tumors, I prefer the fat graft uses. In such cases, we don't need the lumbar drainage, and also PDS placement may be effective to avoid enophthalmos. And over 100 cases, I experienced some complications. Most common complication is sensory change of the eyelid or cheek, and then I experienced the CSF leak of 3 cases, but all cases were treated with the lumbar drainage. The skin infection of 2 cases, and then there is no orbital injuries, and also 1 case of permanent ptosis and 1 case of enophthalmos. And still, transorbital approaches has difficult because it's unfamiliar to the neurosurgeon and ENT surgeons, and it requires long-time surgeries. Sometimes I experience dermal injuries using or pressure injuries, and then we have to be careful. In conclusions, the endoscopic transorbital approach is an option in the management of skull-based tumors involving the middle cranial fossa areas and cavernous sinus. And then it's very important to selection of indication is very critical for spinoorbital meningioma, middle cranial fossa lesions, and orbital pathology cases. Thank you.
Dear colleagues, I'm very happy to be together with you, and I want to invite you to my talk on key concepts and key techniques for innovation in MIN. And of course, the main question is, what is innovation in MIN? What does it mean? I want to talk with you about the MIN key concept, MIN training environment, and about innovation in MIN. Some topics of my personal career. I started in the army, but I had always the idea and the dream to become a neurosurgeon. And I started this in anatomy, always eager to have an anatomical specimen where I can study all the time the complex anatomy of the brain. So I also studied the best conservation and conservation technique of perishable matter, which is the plastination. These are my 2 main teachers, Professor Yashagil and Professor Benetsky. During my career, I did some publications in books, but I started, as you saw, in the evolution of anatomical working conditions to make them a key concept of MIN. Then I changed to pathological anatomy trans and para-endoscopically, especially in aneurysm cases. But more and more I got interested in the ergonomics in MIN and in neurosurgery, the environment of the working conditions in the OR and in the training setting. In '96, I introduced the trans-endoscopic ultrasound technique, which is a very nice and easy guiding navigation tool of the endoscopes for complex cases and also imaging tool. And actually I'm eager to study the wireless support and ergonomics and the habitat, the surgical habitat. You can read everything I'm talking here in the 2 volumes. They will be completed in the next years. In my experience, I used 5 techniques in combination which are able to fulfill the meaning of MIN. It's the height zoom mouth tract microsurgery, the standard technique by Yashikil, the endoscopy, neuroendoscopy, and equipped with the laser in cases, but very important, neurosonography, and finally sealing techniques is also a key technique in MIN. So this is just a story at the beginning to the question, what is innovation in MIN? They made some kind of innovation because they did this for the first time. But the question is it really innovation? Is it really innovation? Innovation in the sense of MIN? Children are telling him it is not. This is what we are talking about. So if we look to this screenshot of our online education, we see all the problems we are talking about in MIN. And we could ask, if we lean back after surgery, we can ask ourselves, which is the area of approach I really did use for surgery? This question, after a standard approach and asking yourself, which part of this approach did I really use for surgery? This is the birth of MIN. This is the moment when you ask yourself, you will enter the world of MIN. So the next question is, can the really necessary part of surgery planned before it comes to surgery? This is the question Pernetsky always asked, and it leads to the overall topic standard or MIN technique. We also have to talk about ergonomics of the OR setting. This is the Yashikil OR setting, and you see the nurse is in front of him because this is the best ergonomy in instrumentation to the surgeon. And this is the usual, very often seen wrong ergonomics in the surgical habitat. But also there is ergonomic management and a MIN management of the exposure of the surgery. In most cases it is not recommended to shave all the hair. I cannot go into details. So here we have an interesting problems. MIN is not only a question of quantity. The approach I have chosen is not a question of quantity. It is a question of quality. This was a perforation with a screwdriver causing a CSF fistula. The boy was happy not to be perforated of the bulb and ocular bulb, and so he only had this CSF fistula. And one of the most important criterion in MIN is that you have seen the results in your patients. Quantity can be calculated. Quality must be described and imagined. Here we have a typical case to show principles of MIN in ICH surgery. You have to realize the surgical reality innovation. And this means the correlation between craniotomy and corticotomy. In the first case, the correlation is rather bad. In the second case, the correlation is of high quality because thorough planning before surgery made it possible to have a very good correlation between craniotomy and corticotomy. You see in the results that a good planned and good placed microcraniotomy or even borehole can do the job very well. So we have to ask ourselves, in the flow of evolution, is this also a flow of innovation? This has to be asked in each step of innovation during history and during ongoing development. So if we change, for example, from the Yashagil setting to the Pernetsky setting, we enter a complete new world, and we also have a complete new ergonomics. If you compare this with that, you see the difference, the microscope and the exoscope. But innovation concept does also mean we have to evolve the concept. And because the keyhole concept made a lot of misunderstandings in the past, I changed the MIN concept to the MIN key concept, not asking anymore for the whole, but asking for the keys of MIN. They can be conceptual and technical. And ergonomics, by the way, is the most unknown key in MIN. And you see the visible part of MIN, but the keys of MIN are not well presented in mind. So you have to study this. So in the future, we have to look for this change of concept, to look for the keys of MIN. There are organizational keys, so we have need a good future program and a strong society. There are mental keys, very important to look for the needs of the brain of the surgeon, not only of the patient. I will come to this point. And we have technical MIN keys to look for innovation in technique and the environment, the surgical environment and the operative habitat. In this context, we can find three ergonomic paradigms, three fields of ergonomics that we can discern, and there is a spatial ergonomics. That means the operative environment has meaningful orbits, emergent orbits, and the more you are in the center, the more sensitive this emergent orbit is for failures. So the operative environment has a special structure, and you have to keep this in mind. The second paradigm is the procedural ergonomics. There we view on the operative habitat by the chaos theory, and we know that a chaotic system shows exact defined parameters, but its outcome is never predictable. A chaotic system can only be influenced by its peripheral parameters, as you see here. And that means you have to be prepared. Preparation preoperatively is essential. That means the peripheral parameters in this system is the equipment and the design, the technique, the physical fitness of the surgeon, the body, the mental fitness of the surgeon, mind, but of course also things like light, gravitation and noise management and team workflow. All these peripheral parameters can be prepared before it comes to surgery, where many things cannot be changed in any possible way. The final and third paradigm of ergonomics in MIN is the mental ergonomics. In my opinion, the most important ergonomic paradigm. This is derived from neuropsychology of the surgeon. Each procedure on the patient's brain before happens in the surgeon's brain. Surgical effects results from action in the surgeon's brain. Haptic abilities results from recognition by the surgeon's brain. So the brain of the surgeon is the main surgical instrument, and that means finally training in neurosurgery is mental training. So, and the innovative goal regarding ergonomics in the OR is to keep the red and the orange orbit free from ergonomic disturbance. So this is the case we should change. The red area and the orange area, these orbits should be completely free from any technical or otherwise disturbances. This means to have a good ergonomics in the OR habit. If you do so, you can get what I call mental navigation. That means it's a difference of the things you see, you can visualize, and the things you should know in your mental activities. And this is can well be done during the gold standard, the microsurgery according to Yashagil. The new innovation now is the exoscope, and we will have to see if you can do mental navigation with the exoscope. We have to see this and to study this in the future, because it's very important for excellent surgery to come into what we call psychologically a flow. If you come to the flow, you will have the best results. And this is somewhat the optimal ergonomics solution in the future. Is just a model that means non-contact wireless support to the surgeon during surgery, so that he can concentrate completely on what he is doing intracranially and on his mental activities. So coming back to the 5 key techniques, and one of the major issues of MIN is innovation by combination of MIN techniques. This is one of the reasons why the trials and the studies regarding MIN techniques are always failing, because the quality of MIN is given by the combination of MIN techniques, which must be decided by the surgeon in every single case. So in summary, regarding the area of the working field of ICH evacuation, we can already see that we get 2 worlds: the old world of craniectomy, very common, and the new world of MIN. And you see the difference. Min ICH evacuation has far better results. In stitch study, we saw only 26.1 favorable outcome, and in my hands in Min we got 86.0 favorable outcome. Min evacuation is an interdisciplinary team concept, very important to keep in mind. And the indication must be done by neurological status, the biological status, and the social embedding, very important. You can read this all in the 2 first volumes of the series. But this is not enough. We also have to have an evolution of the training environment. Innovation also regards the environment of training. And if you train with the wrong environment, you will not have a good innovation in surgery. So it is important to realize that the neuropsychology of the surgeon. Min technique must be adapted to the brain of the surgeon, not only of the patient, as we know it all together. Training, this is a training setting in my laboratory with a team of Mexico, and we were training 3D endoscopy with head-mounted display, which gives a very good 3D imagination. So we have 3 conclusions and 3 fields of innovation. First is well known by most neurosurgeons, it's technical innovation. But in all new fields of the future neurosurgery, we need new effector systems. Here you see you see Pernetsky just making an endoscopy system out of an exoscope system. So this was the tool of our Japanese colleagues from 1999, one of the best systems we ever had, but it was not a good economic result, and therefore they stopped to sell it. Very, very sorry for that. I hope they develop a new one. The new fields of neurosurgery in future will be Min, as we have heard, but it will be also functional neurosurgery, and it will be biological neurosurgery. And for all these parts and for all these working fields, we need new effector systems. But the second conclusion, we need also have an evolution and innovation in scientific field, in a scientific innovation, which needs history, technology, methodology, philosophy, and science theory. If you can ask the question, if you can answer the question, what is the evidence of evidence, then you have reached scientific innovation. And finally, we have to have a mental innovation also. This is according to already to Da Vinci. We have to get a 4D awareness, and you can learn this from Da Vinci. He could make a mental clip of everything he was seeing and drawing and painting. This is the real Da Vinci Code. And I want finally mention the 2 first volumes of the series, Key Concepts in Min, and you can read everything which I have said in details, and you can study. What we have learned is, to especially the younger colleagues, it's not enough just to have innovation in techniques. There are many things we need innovation for, many fields which we have discussed in this lecture. And you have to keep in mind, not only look on innovation in technical regards, but also innovation in the whole field of microneurosurgery to come to minimal invasive neurosurgery. Thank you all for your attention.
and nice to meet you everyone. I'm Dr. Kishida, Professor Chandrasekhar and Professor Komatsu. Thank you very much for inviting me to your conference. I really appreciate the valuable opportunity. I'm a neurosurgeon of Japanese Red Cross Society. My hospital is located within the middle of Japan, between Osaka and capital city Tokyo. I am specialized in neuroendoscopic surgery such as endoscopic transfemoral surgery, endonasal skull-base surgery, endoscopic keyhole surgery, and so on. So I will talk about endoscopic surgery for intracranial tumors and cystic lesions today. Our endoscopic surgeries are broadly categorized into 4 types. Flexible endoscopic surgery is performed on intraventricular lesions, and surgery using a tubular retractor is for intraventricular or intraparenchymal lesions. Endoscopic keyhole surgery is useful for extraaxial lesion or skull-base lesions, and endonasal surgery is, performed for paracellar and skull-base lesions. Today, I will make a presentation about endoscopic transtubular retractor surgery. Although the idea of using a tubular retractor for neurological surgery has been proposed from 100 years ago, this surgical method is not so popular even now in the world, I guess. But actually, this type of surgery is very familiar to Japanese neurosurgeons. We operate an intraparenchymal or intraventricular hemorrhage using a small transparent tubular retractor when the patient meets the surgical criteria. In this surgery, single burr hole is made in the patient's forehead, and a small tubular retractor, 6 mm in diameter, is inserted into the hematoma. Then we evacuate the hematoma and stop bleeding by monopolar suction coagulator. And after removal of hematoma, we confirm hemostasis by irrigation. Pull out the tubular retractor and finish. All of procedures can be finished within 1 hour. That's very simple and safe method. So that's provided by Japanese National Health Insurance. I also started endoscopic hematoma evacuation at 2004 and progressively expand the surgical indication to cystic lesions and tumor cases. More than 200 cases have ever operated in this 15 years. Transparent tubular retractors are roughly separated into 2 groups, small and large. Small tubular retractors are products of Japanese companies. It is 6 to 9 mm in inside diameter. Large one named Bucite is an American product, which lumen is oval-shaped and over 12 mm in diameter. Maximum size of tubular retractor we use is 70 mm in diameter. 21 or 28 mm Bucite is too large, too invasive for human brain, I think. We categorize the transtubular retractor surgery into 2 types: one-hand surgery and two-hand surgery. One-hand surgery means single instrument surgery using a small tubular retractor by a single burr hole. Mainly suction, forceps, and straight scissor are used. So surgical style is similar to endoscopic hematoma evacuation. And another is two-hand surgery. This large tubular retractor named Bucite allows us to do microsurgical technique with both hands. For example, control hemorrhage using suction by left hand and coagulate the B cell using bipolar coagulator by right hand. So one-hand surgery is applied to soft and suckable tumors or cyst fenestration. Two-hand surgery is good at handling of surgical instruments and allow us to do more aggressive resection of the tumors. Preparation of surgical instrument is very important. Bipolar or monopolar coagulator and ultrasonic aspirator are available and should be prepared for tumor resection. Malleable or curved instruments are very useful to avoid the interaction with an endoscope. These malleable dissector and rotatable forceps are our original product for endoscopic surgery. Now, I'll show you the representative cases of transtubular retractor surgery. First, endoscopic transcortical approach. This is the most popular surgery for us to operate the intraparenchymal or paraventricular lesions. Second is endoscopic transsulcal hyperhiatal approach for thalamus or trigone of the lateral ventricle. And last, endoscopic subtemporal approach for brainstem lesion. First, this is an illustrative case of endoscopic transcortical approach. Large intraventricular tumor suspected of glioma which involves the left thalamus straight vein. In this case, I deem the approach from lower frontal lobe along the bottom of the tumor to be reasonable to prevent avulsion injury of the thalamus straight vein. I planned to do two-hand surgery using 70 mm in diameter view site by a 3 cm craniotomy through 4 cm forehead wrinkle incision. This is an intraoperative video. Forehead wrinkle incision was performed and 70 mm tubular retractor was inserted to the left lateral ventricle. This is the endoscopic view. Compared to microscopic intraventricular surgery, endoscope provides wide viewing angle, close-up image even in deep and narrow space like this. Now I'm looking for the thalamus straight vein involved in the tumor. I detach the bottom of the tumor from caudate head and thalamus. Thalamus straight vein was exposed carefully and preserved. The tumor was divided into 3 pieces and removed piece by piece. Presumably, here is the origin of the tumor. This is final view. Preserved thalamus straight vein is lining here. Postoperatively, tumor resection and patient's condition was good, and we could confirm the preservation of anterior caudate vein and thalamus straight vein here. This type of surgery can be applicable in various lesions. Posterior fossa, fenestration of a cystic lesion, and shallow intraparenchymal tumor, and deep intraparenchymal tumor. In this case, I assumed the tumor has 2 compartments and inserted 2 tubular retractors in each compartment along the long axis. Next one is transsulcal approach at the eloquent cortex. For the lesions located in thalamus or trigon, interhemispheric transcallosal approach or transcortical high parietal approach is chosen. The advantage of interhemispheric transcallosal approach is absence of damage at the surface of cortex. However, surgical field is limited at the medial and contralateral side. Moreover, there is a risk for injury of bilateral cingulate gyrus or bridging veins. On the other hand, motion axis in transcortical high parietal approach is relatively flexible compared to transcallosal approach. But surely, cortical damage in eloquent cortex becomes the biggest problem. Therefore, I am actively engaged on transcervical approach instead of transcortical approach, especially at eloquent area like parietal lobe. To divide the sulci for a long length is a little difficult and complex, so endoscopic surgery is compatible with transcervical approach because it requires less space than microscopic surgery. According to a previous research, long association fibers and axon terminal connect to subcortical nuclei of gyrus rather than the sulcus. And perforating arteries are also rich at the surface of the gyrus compared to the bottom of the sulcus. So transcervical approach is expected to reduce subcortical damage, not just the cortical injury. Basically, I choose the sulcus over 10 mm lateral to midline and medial to intraparietal sulcus to avoid injury of SLF2 and cingulum. The choice of the target sulcus is key factor to prevent functional disorders. This is an illustrative case of transcervical approach for thalamic tumor. Although he is young male, unfortunately, pathological diagnosis based on previous biopsy was IDH wild GBM. In the prone position, 3.5 cm craniotomy was done. The target sulcus was opened and a 12 mm view site was inserted from the bottom of the sulcus. This is called the plexus and the roof of the thalamus. After coagulation of surface of thalamus, I started suction removal of the tumor. We are able to use bipolar coagulator and scissors in 12 mm view site. Tumor was soft and suckable in this case. Sometimes major bleeding occurred, but hemostatic procedures were performed in the same manner as microscopic surgery. Underwater observation is useful to confirm anatomical landmarks such as posterior horn or calca abis. Here is body of left fornix. I confirmed the location by navigation system and removed the tumor. After resection of the tumor, the cavity and the ventricle were washed enough. Transparent tubular retractor was pulled out, and the ventricle wall plasty was done to prevent subdural hygroma. There is no damage to surrounding cortex and veins. surgical corridor is small. Arachnoidoplasty was also performed. Pre- and postoperative MRI. Local tumor control has been achieved over 15 months. Last case is brainstem lesion. He is a small boy who complained gait disturbance. We suspected pilocytic astrocytoma in brainstem and started observation in the outpatient clinic once. However, the tumor had gradually grown and I decided to do surgery. In the supine lateral position, his head was rotated to the right. S-shaped skin incision on his temporal base was planned. Actual surgery, after the skin incision, small craniotomy was made on his temporal base. I exposed tendonium cerebelli by subtemporal approach and cut it carefully. We can observe the lateral side of brainstem, SCA, and trochlear nerve. This is oculomotor nerve and trochlear nerve. And now I'm checking the corticospinal tract by intraoperative MEP. Six millimeter small tubular retractor was inserted from safety area. This is an endoscopic view by a tubular retractor. Tumor was soft, less vascularity, and easy to suction. That was very soft tumor. Now I'm doing the underwater surgery by continuous irrigation of saline. Underwater surgery is one of the unique advantages of endoscopic surgery. We can prevent shrinkage of the cavity and keep operative field clean without hemorrhage. Tubular retractor was pulled out. This is final view. Postoperative course was uneventful. Gross total removal of the tumor was achieved, and his symptoms had improved. All told, the advantage of transtubular retractor is to distribute the pressure and reduce damage on surrounding white matter. And the bright, close-up, wide viewing angle images of endoscope are compatible with small and long corridor of a tubular retractor. Of course, the length of corticotomy can be shortened. The largest problem of endoscopic surgery is interference between endoscope and surgical instruments. We have to prepare various instruments and select an adequate size of tubular retractor for each patient. Most of neurosurgeons worry about arterial bleeding and hemostatic procedures. So I will show you an example case of severe bleeding. This is biopsy surgery for intraventricular tumor. Intraoperatively, massive arterial bleeding occurred. Blood overrimmed from the view site like this. This situation is similar to premature rupture of aneurysm in clipping surgery, I think. So I used two large suctions. One is for evacuate hematoma and another is for identification of bleeding point. After identification of bleeding point, hemostasis was done by coagulation and surgical cotton. That's the same procedure as microsurgical technique. Actually, massive arterial hemorrhage can be handled by usual microsurgical technique in 12 or 70 millimeter view site. Conclusion. Endoscopic surgery using a tubular retractor is a useful surgical option with several advantages. We should choose adequate approach route, select enough size of tubular retractor, and prepare various instruments for safe surgery. Thank you very much, everyone. Thank you very much, everyone.
Ladies and gentlemen and dear colleagues, first of all, I want to express my appreciation to the organizing committee for giving me the opportunity to present my lecture in Pure Endoscopic Neurosurgery WEB Summit 2022. My methods to young neurosurgeons based on my experience from the early years of mine. I was there from 1994 to 1995. At the time, the direction was under Professor Penetsky. And at the time, for me, the standard approach for anterocranial fossa and parietal area was this type of frontotemporal craniotomy. However, in minds, the majority of cases were supposed to the small keyhole craniotomy. The questions raised, what is the standard technique? And Professor Penetsky always taught me to reconsider or re-evaluate the standard technique and eliminate the unnecessary part of this standard technique and only leave the essential part of that. So my message is to the young neurosurgeons: be flexible and always re-evaluate the standard technique to make the innovation.
So, as most of you may agree, endoscopic endonesia surgery has made an enormous development in the last decades. However, to enable sophisticated surgical maneuver in the deep and narrow surgical field, present lineup of the surgical instruments is still not sufficient. In this presentation, a steerable forceps, which allows movement of the tip similar to that of a robotic arm, is introduced, and its usefulness in the removal of various skull-based tumors is demonstrated. This video demonstrates the steerable forceps, which is already commercially available in Japan, and it's originally invented by Professor Kawamata from Tokyo Women's Medical College. This tip of the steerable forceps has a grasping function and can be bent into the arbitrary angle, and it can be also rotated by manipulating the dial at the hand grip. We use, in most of the cases, this endoarm system from Olympus, and this the endoscope is attached to the pneumatically driven dedicated holder, and the fixation and the release of the endoscope can be done instantaneously by pressing the button at the hand grip. So even a single surgeon can perform bimanual surgical maneuver seamlessly and in a convenient way. So this is a case of pituitary adenoma with lateral extension into the left cavernous sinus and also prominent suprathoracic tension. The ophthalmological examination demonstrated prominent lateral hemianopsia on the right eye. This is intraoperative video of the case. The thala floor dura is incised, and now soft tumor is bulging out, which is removed with forceps. And after that, the superior part of the tumor is dissected extracapsularly using this flexible forceps. The flexible forceps is used as a blunt dissector, and now this tumor is grasped and removed piece by piece. After intracellular compartment is removed, the descending diaphragma is pushed back with cottonoid, and the view is directed to the left cavernous sinus with 30-degree endoscope. Here you can see the tumor in the retrocarotid space is approached with curved suction and the flexible forceps, and even in the most lateral part of the tumor can be grasped and dissected with these two instruments. Now the tumor is gradually removed, and also intercavernous compartments removed, and here you can see the course of the internal carotid artery, and the outer wall of the lateral cavernous sinus is exposed. Again, the course of carotid artery is demonstrated, and as you can see, the intercavernous compartment is also gross totally removed. The postoperative MRI demonstrates removal of the tumor, and his visual field deficit recovered almost completely after surgery. The next case is somatotroph adenoma in a 42-year-old man. He was treated with pasireotide, but still his IGF-1 was in excess. The tumor is again invading the left cavernous sinus. The major portion of intracellular compartments already removed. After that, a superior aspect of the tumor is dissected from the surrounding pituitary gland in extracapsular fashion. Here, the flexible forceps enables to retract the tumor into desired direction. The dissection is carried out further, and intracellular compartment is now further removed. After that, the left cavernous sinus is approached. Here, the course of internal carotid artery is indicated, and also the dura ring. The flexible forceps can reach the most lateral part near the dura ring very easily, and even the lateral tumor compartment can be grasped and dissected, and with certainty and safety. So finally, the intracavernous compartment is dissected meticulously and very carefully using this curved section and steerable forceps. Here you can see the defect of the medial wall of the cavernous sinus, and now the steerable forceps has entered the cavernous sinus and removed the last piece of the tumor from the intercavernous compartment. This final view demonstrates the whole course of the intercavernous carotid artery, and total removal of the tumor is confirmed. The post-operative MRI demonstrates total removal of the tumor, and even the growth hormone and IGF-1 level is still high. The nadir of glucose tolerance test reached the creatinine consensus criteria. So next case is a craniopharyngioma in a 35-year-old woman. So next case is a craniopharyngioma in a 35-year-old woman. The tumor has been already exposed. Here you can see a tiny branch of the suprahypophyseal artery, the preservation of which is very important for visual function maintenance. And now the tumor is debulked with a CUSA and dissected from the undersurface of the optic nerve with this steerable forceps. And tumor is further debulked, and now the deepest portion of the tumor is now approached. Here you can see the pituitary stalk. Actually, the tumor has split the pituitary stalk, so it is transinfundibular type tumor. Now, with the steerable forceps, the tumor can be retracted in any direction. Now, tumor is elevated and dissected from the lower part of the pituitary stalk. This is performed very carefully, but using this steerable forceps, this maneuver is very easily and certainly performed. Now the tumor is dissected from the lateral to medial direction. This movement of the steerable forceps is somewhat similar to that of the robotic arm. So now again the tumor is elevated. This dissection is carried out in a circumferential manner. There's still attachment to the hypothalamus. Now the upper part of the tumor is dissected. Here, this is attachment to the hypothalamus. The tumor is retracted downward, and there is a section, so dissection was completed. There's a final view. The tumor is grossly removed. There's a defect of the flow of the third ventricle. The postoperative MRI demonstrates gross total removal of the tumor, and her visual field deficit on the right eye improved in a short time, and she's under desmopressin and levothyroxine treatment, but other pituitary function was kept normal, and she could give birth to a boy. So the next case is a meningioma in a 33-year-old woman attached to the left tuberculum cellar. Here the anterocranial fossa is already exposed. The tubercle, both carotid arteries and both optic canals. Here is the tumor attachment. So the tumor is first debulked with a CUSA and then dissected from the surrounding brain. Here the tumor is retracted from the olfactory nerve. Using the steerable forceps, this tumor can be retracted from the lateral to medial direction. And again, the tumor is debulked and dissected from the acon complex. This debulked and dissection is repeatedly performed. Finally, the deepest portion of the tumor is now elevated. The final view demonstrates the course of the optic nerve. So there's a tiny adherent tumor to the optic nerve, but near total removal has been achieved. The postoperative MRI demonstrates no major mass of the tumor, and her left visual field deficit recovered completely. So in the remaining time, I will show two short videos for chondrosarcoma and chordoma. The first is a recurrent chondrosarcoma in the left posterior clinoid in a 25-year-old female. The tumor exists within the carotid canal, so it has to be opened very carefully. Here the catheter sheath is incised and the tumor within it is exposed. And this is removed with a curved section, and the cavernous sinus being opened, so the cotonitis is plugged into the cavernous sinus. Even such complex maneuver can be performed with a steerable forceps relatively easily. And after that, the tumor is further removed. The postoperative MRI indicates gross total removal of the tumor. The last case is a chordoma in the 49-year-old man. It's not large, but with prominent intradural extension. So this is almost final stage of the surgery. There's a still tiny residual tumor attached to the pons. I tried to remove it with a straight, rigid, conventional instrument, but as you can see, the retraction of the tumor was only possible in the longitudinal direction. So I thought it was not safe enough. So I introduced steerable forceps, and I retracted the tumor in the horizontal plane, and thus the tiny perforating branch could be dissected from the tumor, and finally the complete tumor removal could be achieved. Reconstruction of the skull base defect is another important issue, but it is somewhat cumbersome procedure because it is not always easy to put the flap without any folding to the skull base defect. But with the steerable forceps, the placement of the nociceptor flap can be done relatively easily without any folding, and this now the flap is pressed to the skull base. As you can see, this movement of the steerable forceps is very similar to that of a robotic arm. The post-op MRI indicates gross total removal of the tumor. So this is conclusion. The surgical techniques using steerable instruments were demonstrated. The surgical maneuver performed with the steerable forceps resembled to that of the robotic arm. The endoscopic surgery using the steerable forceps may provide a template for future application of robotics in the neurosurgery. Thank you for your attention.
Ladies and gentlemen, I'm from Department of Neurosurgery, Zhongzhen Hospital, Fudan University, Shanghai, China. Today, my lecture is about endoscopic cerebrocerebellar infratentorial approaches. We are very lucky in the endoscopic time. In our department, we can do all of the most operations use endoscopy. There are three kinds of theta approaches. One is mid-line approaches. Second is peri-medium approaches. Third is far lateral approaches. We use these approaches can do operations such as pineal raging tumor, thalamus tumor, tentorial meningioma, tumors above the cerebellum, meningioma in the atrium of the lateral ventricle, petroclival meningioma, trigeminal schwannoma, and others. We resect the tumor in the pineal region, use mid-line and peri-medial approaches. As we know, the pineal region is at the center of the skull. Around the pineal region, there are many important structures such as ganaxial vein system. Now we show the video of right peri-medial approaches. We first open the caudal germinal cistern to expose and the pineal gland. You can see there are many vessels. There are many kinds of pathology in this region, such as germ cell tumors, pineal cell tumors, glioma, and others, such as meningioma. The patient with these tumors can have hydrocephalus and peri-naudite syndrome, and if the tumor involved of hypothalamus can have endocrine problems. The patient with hydrocephalus, in the past we use draining or VP shunting, but now we use ETV to treatment of the hydrocephalus. In the past, we do these operations, we use sitting position, but now we use a lateral oblique position. It is very safe and comfortable. It is about the midline approaches. It is incision and craniotomy. The patient have do twice operations of VP shunting and gamma knife in another hospital, but he also have hydrocephalus and transfer to our hospital. We use the midline approaches. We cut the bridge vein. Then we open the caudal geminal system of the right side of the placenta cerebellum vein. Then we expose the tumor. You can see the tumor. We dissect the tumor. This is draining vein. We dissect the tumor from the brainstem. The draining vein, cut the draining vein. It is choroidal plexus. We dissect the choroidal plexus. Finally, we dissect the tumor from the brainstem. Then we remove the tumor. You can see the aqueduct and the duct. But no, we like to use perimedial approaches to resect the tumor of the pineal region. You can see this is a large tumor. We from left side, first we open the caudal geminal system and expose the tumor. You can see the draining vein. We first cut the supplying artery. Then we coagulate and cut the draining vein. We dissect the tumor. This is a small artery. This is a tactile artery, a tactile vein. We dissect the tumor. This is the right artery. After we remove the tumor, you can see the pseudoventricle. The patient have the 5 kinds of pathology type. Is the mixed germ cell tumor. Second, we use theta approaches to resect the tumor of the thalamus to 2 kinds of thalamus tumor. One is medial wall of the pseudoventricle. Another is pavina of the cysternal part. We also use the approaches. In the early time, we use midline approaches. This is the case of Glymo. This is another case of the girl. We use the midline approaches after the tumor being removed. The pathology is glioblastoma. But no, we use perimedial approaches. You can see this right side to thalamus tumor. We use left side approaches. Tumor be removed. The pathology is pinocytic astrocytoma. This is another patient. Is a glioblastoma of the tumor be removed. It is other cases is CMS tumor be removed. This is another case. The pathology is diffuse midline glioma. This is this boy is PLANTY. Tumor be removed. You can see the video. We use left side approaches to resect the tumor. First, we cut the bridge vein. There are only one bridge vein. Then we open the caudal germinal cistern and expose the bulging right cinemas. You can see. We cut the cinemas and expose the tumor. Then we use CUSA to resect the tumor. After the tumor be removed, we use surgical fluid to hemostage. Tumor be removed. You see the post-operative MR shows the tumor disappeared. This another case video. Is CMS. We use left side approaches. Is cut the brain vein and open the cistern and expose the pineal gland. We cut the vein and shift the gland and into the third ventricle. You can see the yellow and bulging thalamus of the right side. We cut the thalamus and expose the tumor and dissect the tumor and remove the tumor. Then also use surgical fluid to hemostage. Tumor be removed and the post-operative CT. We also use the CT approach to resect the tentorial mini tumors. There also has three kind of approaches. The first is the midline approaches. Second is perimedial approaches. This patient with the mini tumor above the tentorial, but the tumor surrounding the tumor have serious edema. So we use theta, perimedial, cerebellum, infratentorial, transtentorial approaches to resect the tumor. After the tumor be removed, you can see the pre-operative and post-operative visual field. You can see the same as the pre-operations. This is the mini tumor at the bottom of the tentorial. We use far lateral approaches. You can see this is the tumor. After the tumor be removed, you can see the trochlear lobe and oculomotor lobe. You can see this SPV, the tumor being disappeared. We also remove the tumor above the cerebellum. Use this kind of approaches. This is midline approaches. This is perimedial approaches. This is we use far lateral approaches. Fifth, we use far lateral theta approaches for petroclival meningioma. It is anatomy. You can see many structures such as fifth cranial nerve, SPV, and sixth cranial nerve, seventh and eighth cranial nerve. You can see superior middle tubercle, and this is the case with a small tumor of this side. You can see. One case is a tumor, a mini tumor, involved many kinds of cranial nerves. You can see the tumor. After the tumor being removed, the patient have good result. This is another case is with the mini tumor. You can see the mini tumor very large. You can see the tumor being removed and the patient have good result. This another case is the tumor involved of the middle skull base. You can see. After the tumor being removed, the patient have with third cranial nerve palsy, but he involved 6 months after operation. This is another case. You can see the tumor also involved in middle skull base. The tumor be removed, and the patient with good result. This mini tumor is very new. You can see, but he have trigeminal neurology. So we also resect the tumor use the approaches. You can see this is tumor. This is the fifth cranial nerve. This is SPV, but the SPV is in this part. We cut the SPV and resect the tumor. You can see the BA and VA. This the cranial nerve have preserved after the tumor being removed. This is post-operative MR. You can see the patient have good result. This is another mini tumor. You can see the tumor is very large. Tumor very large. The tumor. You can see the tumor trochlear, cranial nerve, tentorial, SPV. After the tumor being removed, the patient has hemiplegia of right side, but recovered after 6 months later. See, this is video. We use monopolar coagulator and cut the tentorial. Then we use CUSA to debugging of the tumor. After the debugging of the tumor, we dissect the tumor from SCA. You can see, and brainstorm. You continually debugging the tumor. You can see trochlear nerve and brainstorm. It is the fifth cranial nerve. It's SPV after the tumor being free and removed. You can see many structures of this region. The brainstorm, the trochlear nerve, the SPV. It is CPA. You can see tumor being removed. is another video. It's left side. We use CUSA debugging of the tumor. After the tumor being debugging, and we dissect the tumor from surrounding structures. As the tumor removed, you can the stalk. You can see all of the cranial nerve being preserved. You can see this is 6 cranial nerve. You can see the 7 and 8 cranial nerve. 6th part, we use these approaches for trigeminal schwannoma. You can see the anatomy. This is the right side. This is the left side. This patient with large dumbbell trigeminal schwannoma. In the past, with middle score-based approaches or endolithial approaches to resect tumor, but now we use the far lateral theta approaches to resect the tumor. It's during the operations, you can see the tumor. After the tumor be removed, you can see the liver. You can see the SPV. The tumor be removed, and the patient have good result. Finally, a 7th part, we use approaches for brainstem tumor. You can see the brainstem response. This patient with Pons tumor, you can see the tumor. After the tumor be removed, you can see the post-operative CT. The patient have improved. The pathology is glioblastoma. Finally, we also use perimedial theta approaches to resect the tumor, but we must cut the tentorial. You can see. This is a video. A small mini tumor. We cut the tentorial and into the lateral ventricle and dissect the tumor and coagulate and cut the tumor, cut the choroid plexus and remove the tumor. You can see tumor be removed. Now we have a conclusion of endoscopic cerebrospinal infratentorial approach is the lateral surgical corridor for many lesions and deserve for future study. Thank you for your attention and give you a happy new year. Thank you.
Ladies and gentlemen, thank you very much for the invitation to participate in this web meeting. As you can see in my background, I'm currently relocating, so please apologize if I'm not attending the whole of the meeting. My topic is anatomy, radiology, and basic techniques of endoscopic transsphenoidal surgery, with special emphasis on education. So let's start with the approach. And the question is always, do we want the mono or binostril approach? Do we want the middle turbinectomy? Do we need a posterior ethmoidectomy? Do we have to prepare a nasoseptal flap or even raise a rescue flap? What about posterior septostomy? How large should it be? Then how large should we open the sphenoid sinus and the sellar floor? And how do we open the dura? So here you see the mononostril technique. One nostril, two instruments. We actually don't use it because we believe the binostril technique is much more elegant, using 4 hands and 2 surgeons. If we look at the phases of transsphenoidal surgery, we have a nasal phase up to the opening of the sphenoid sinus, and what we want to see there is mucosa and bone. So what we need is a CT with bone window, because we want to anticipate all variations like a septal deviation, a spur, a contrapulosa, sphenoid ostium. What about the sphenoidal phase? It's to the opening of the sellar floor, and there we want to see the bone, the septations, the sphenopalatine artery, mucosa, the carotid artery, and the optic nerves. And during the sellar phase, we want to see the tumor, the carotid arteries, the cavernous sinus, the optic nerves, and the chiasm. So we need soft tissue imaging. So here you see the approach during the nasal phase, that's the trajectory along the angulation of the middle turbinate through to the superior turbinate to the sphenoid ostium. We usually perform a posterior septostomy about this size. We always try to keep part of the perpendicular plate of the ethmoid bone intact because of stability of the nose. And here you can see virtual endoscopy, which is actually provided by some navigation manufacturers already, where you can anticipate the variations in the nose. Here you see septal deviation, septal spur. Very often they are combined, contrapulosa very often combined with septal deviation. And you can also anticipate the sphenoid ostium, which sometimes seems to be closed, but in fact it's only hidden behind the superior turbinate if you look at the CT scan. How to localize it? Well, via the angulation of the middle turbinate, via the superior turbinate, and then you're there. Or you can angulate your endoscope about 45 degrees. Also, we want to see the sphenopalatine artery, because the sphenopalatine artery first is responsible for the delayed epistaxis, and second, because if we raise a nasoseptal flap, a Haddad flap, we want to preserve the vascular pedicle, very important. And then once in the sphenoid sinus, we want to know about the degree of pneumatization. Sellar, presellar type is usually no problem at all, but the conchial type, as we commonly encountered in children or even in ACTH adenomas, can be very cumbersome. So we want to drill with navigation. The sellar floor, as you can see here on this publication from the SADA group, can be prominent, intermediate, or flat. In macroadenomas, again, prominent or flat. And it can be, when it's very, very flat, a conchial type of pneumatization, as I told you. And therefore, we've developed this multimodality image navigation, not only using T1 contrast enhanced MRI, as you can see here, because it shows soft tissue very nicely, but it doesn't show bone at all, with MR angio to depict the carotid arteries, with a regular CT scan to depict the large volume bone, and with a second CT scan, which is actually the same image slice, so the patient doesn't have to be in the CT scan a second time. Same slice, but a different type of windowing, a raycast algorithm. And we've published this actually in 2019 in Journal of Neurosurgery, so if you want to use this recipe, it's in this publication. Here's an example, a 27-year-old female with a Nelson tumor, and I told you ACTH adenomas are prone to hyperostosis, so in this case it was even hyper-reossification. You don't see the bone on T1, of course, but you see the right side, the adenoma remnant. Here you see now this massive bone, and if you superimpose all these pictures, I think then you really have a very safe journey towards your recurrent adenoma. What about the sphenoid sinus configuration patterns? They can be simple, as in the upper row, and they can be complexes in the lower row with multiple and horizontal septations. And here I would like to give you an example. So this is a macroadenoma, non-functioning macroadenoma, and the surgeon did not use navigation for this. Well, fair enough. But he reported on the next day that the cellar floor was very flat and he couldn't remove the adenoma completely. Well, if you look at the left picture, it looks flat, but it looks like if you open the complete cellar floor, you can remove it. But look at the bone windowcity. There was an onodicell, so a posterior ethmoid air cell, that actually, if you don't open it because you think it's already sphenoid plane, you may run into trouble that it's really, really flat and you cannot remove it. So that's why I recommend you use this CT surface rendering. It's very helpful in such cases. Also, you can use virtual endoscopy for the sphenoid sinus septal anatomy anticipation. What about this anatomy in the sphenoid sinus itself? Here's a list of structures that you can see, and here's a recent surgery of ours. You can see the opticocarotid recesses on both sides between optic nerves and carotid protuberances. You see the carotid protuberance even goes down to the petrous part of the carotid. In the midline you see sphenoid plane, tuberculum cellae, the cella itself, and the clival indentation. And of course the sphenoid sinus anatomy is very, very different and depending largely on the pneumatization of the sphenoid sinus. Now let's look a bit on the lateral side of the sphenoid sinus. And you can see here the carotid artery, of course, and I have made an asterisk in blue where the typical point of lesioning the carotid artery from opening the cellar floor is. And it's in the anterior genu, the old C3 segment, the new C4 segment. And on the lateral side you can even see, as in this cadaver specimen, the maxillary nerve. Look at this, there are C4 subsegments of the carotid artery. You see the posterior vertical, posterior genu, horizontal, anterior genu, and anterior vertical part. And what is very nice on this right picture is the inferolateral trunk that goes to the lateral side. And you can imagine now why it can be so dangerous to work in the lateral compartment of the sphenoid sinus, because if you avulse the inferolateral trunk, you get massive arterial bleeding, which may be hard to cope with. So ICA injury is luckily very rare. We had 2 cases only in our microscopic series with pituitary adenomas. I showed you where it is, and it is typically because of scarring in recurrent cases or due to post-radiation scarring. Sometimes there's no osseous border in this C4 segment, yeah, and what you do is tamponade immediately, controlled hypertension and barbiturate loading. We use this crushed muscle overlay technique and image guidance and pack the nose to a CT angio. And then we go to the ICU with the patient sedated, intubated, check the CTA on day 5. And if there a pseudoaneurysm develops, and don't forget this aneurysm has no wall, we can either do endovascular occlusion of the carotid, no stent, no coiling, it doesn't work, here there is no wall, and bypass, or you can do a double flow diverter, which actually keeps the carotid artery patent. But the best thing is to prevent it with MR angio, imaging studies on the navigation, and the intraoperative ultrasound Doppler probe. So this is why we have developed this multimodality navigation already around 20 years ago. You see on the right side how nicely you can see the carotid arteries. And this is the actual recipe how to set the multimodality imaging navigation, now also including T2. What is very important that the carotid artery shifts during surgery. We could see on comparing pre and post-op MR angio that the posterior genu and the horizontal segment shift, not the anterior genu and the anterior vertical segment, because they are fixed at the dural ring. Just keep that in mind. So what about resection? When we're in a cellar, we first do a debulking. Yeah? Then we check for the pseudocapsule. We use the 90-degree curette just underneath the dura and check for a pseudocapsule. And then we first start with paracellar dissection. We immediately go to the paracellar extension and then to the floor and the dorsum. And only finally we remove the suprasellar part. So if the diaphragm descends, okay. If it doesn't, don't pull. Check for adenoma remnants, and usually a non-descent is either due to a small neck or due to remnants. Try to avoid a CSF leak at early stages of surgery, because then the intracranial pressure doesn't push your suprasellar component down. If it's at late stages of surgery, well, fair enough, use a reconstruction algorithm. And always preserve the pituitary gland. Look for the pituitary gland on the preoperative MRI image. In this publication from 2 years ago, you can see our way of optimizing the MR imaging for image guidance. That's also very helpful, I think. And you can see much more parasellar extensions clearly than with regular MRI. By the way, coming to parasellar extension, here is the so-called Knoss grading scale from grade 1 to grade 4, depending on tangents between the carotid arteries. You probably all know this. But what is very important is that there's a difference between the superior and inferior cavernous sinus compartment. Now look at this anatomical specimen. Here the pituitary gland is intact. We are looking to the lateral side. From median you see the carotid artery and the cavernous sinus already. Now we flip the pituitary to the top so that we can see the whole of the medial wall of the cavernous sinus. Now it's again flipped, and you see now the superior and the inferior compartments of the cavernous sinus. Superior and inferior compartments. Yeah. If we look now in the superior compartment, we see very nicely the oculomotor nerve in its sheath. And if we look, the inferior would see abducent and 5-1 nerves. Now, let's look at the high-grade pituitary adenomas, so grade 3A, so extending in the superior cavernous sinus compartment, 3B in the inferior cavernous sinus compartment, and 4 surrounding the carotid artery. So there's a significant difference in invasion and remission between 3A and 3B, and this is why we have actually made this subdivision. And I would like to show a case of a 40-year-old lady with a recurrent invasive non-functioning pituitary adenoma. She actually presented with an intermittent third nerve palsy on the left side, and here you see the picture, and you see very nicely that it's a 3A, so it really enters the superior cavernous sinus compartment. On the right side it's probably grade 2. So here's our planning. Here is the T2 planning. You see the stalk very nicely. You see the invasion into the bone, and you see the extension into the posterior cavernous sinus compartment on the left side. Here's the OR setup. We always use a tube, a nasal tube, to prevent any bleeding. On the endoscope, a port system, and you don't need irrigation shaft with this. You see the adenoma is invasive. It actually grew already through the sellar floor. So we do matching. You can see we always use a suction that is actually continuously navigated, so we always understand where we are. Let me go a bit further in the sake of time. We always check the ICA position with a Doppler probe. Yeah, see that here. And then first we drill the hypostotic bone. So you see navigation is very helpful when the bone is hypostotic or with a conchoidal configuration. And then first we will remove the right and the actually more invasive part of the tumor. Yeah, you see the 90-degree angled curette. And then we go to the left side, yeah, and we remove the left component. And this is actually the side with the parasellar extension. So we take some samples for histology, and now we use the angulated suction to remove that tumor. And very nicely, as you can see, you can remove the tumor here from the intracavernous carotid. So this is the horizontal segment of the carotid artery. Yeah, and it's possible to remove that tumor in a gross total fashion. And you see on the small branches, that's the posterior genuine here, yeah, and you can even see the abducent nerve running inside the cavernous sinus there. Yeah. So let's continue. So we get a really nice resection, as you can see. And to continue, this is the postoperative image. Here's the Haddad flap that we prepared preoperatively, and here you can see a gross total resection and the pituitary expanded again. Left third nerve palsy resolved. Now this is a paper we recently published in 2021 in Journal of Neurosurgery about dumbbell-shaped pituitary adenomas, because we wanted to understand which configuration does the adenoma need to descend, and which adenoma configuration do we anticipate if we need an extended approach. And you see from this publication that if the supradiaphragmal diameter coronal by sagittal divided by the neck diameter coronal by sagittal is larger than 2, the adenoma will not descend, and you should anticipate actually an extended approach. So this was very helpful, and I would like to show you one case, a 42-year-old female with a multilobular dumbbell-shaped non-functioning pituitary adenoma. It was actually an incidental finding, but she had some non-recognized bitemporal visual loss. So you can see here is the adenoma, very nasty looking adenoma, yeah, with no clear borders. Here is the sagittal image. You can see on the side there, even the anterior complex seems to be very adherent. So this is our planning, and this is our OR site. So we go in, we match first the cellar floor. You can see there's some invasiveness. We always use the Doppler probe to check for the position of the carotid artery. Then we do the drilling also on the sphenoid plane, and then first we start to remove the endocellular tumor component. As you see, we're lucky, it's quite soft, but what we also encounter is there's no way that the supradiaphragmal component will descend because of the narrow neck diameter. Yeah, you can see here is the neck, yeah, but it's so narrow, it's definitely a ratio of more than 2. You see already CSF coming, and now we extend our approach transtubercular transplanum. Yeah, so we usually coagulate the intercavernous sinuses and then cut in the midline, as you can see here. So for the sake of time, let's advance a bit. We use usually water jet dissection and angulated suction irrigation. Yeah. And with this, we get a very nice removal of this supracellular tumor component. Yeah, I will advance a bit. We use now the 45-degree lens. And with the 45-degree lens, you get a very nice view of the anterior cerebral arteries, but you also see that there is some adenoma remnant here on the optic chiasm, left optic nerve, that we are going to remove now. And then finally here we have removed it. Final inspection shows no clear adenoma remnant. Here's the ACOM, that's suprachiasmatic, and then infrachiasmatic. You can see very nicely the pituitary stalk. The infundibulum is here, virtually untouched, so she had no pituitary dysfunction. And then at the end, of course, what is very important, we have to do a multi-layer closure. So we usually use fat inside, then we use crushed muscle on top, then we use fascia lata, subdural, and we fixate this construct with bone from the perpendicular plane of the ethmoid, and fixate now with fibrin glue. But this bone, I believe, is very important so that the construct stays actually in place. And over this now comes the Haddad flap. So to summarize, the endoscopic technique has become standard for transnasal pituitary surgery. Multimodality imaging permits an optimal visualization of bone, of soft tissue, of vascular structure, even of the fine paranasal sinus structures very necessary for preoperative planning and intraoperative orientation. It improves orientation for any kind of endoscopic skull-base surgery, and we think that this may add to the safety in case of anatomic variations, in case of recurrent tumors, and especially in case of extended approaches. Thank you very much for your attention, and thank you very much for your invitation.
That was quite an informative session. Dr. Yadav, your comments, and there are some questions in the question box.
Sir, I think it has already been discussed very nicely, especially the important point about the tubular retractor or cylindrical retractor. The point has been made by the two speakers is that if you have a small lesions, avascular lesions or cyst, then or the clot, then you can use very small size the tubular retractor, maybe 6 mm or 10 up to 10 mm. But when you have a large lesion, a vascular lesion, and the solid component, when you require bimanual dissection, then obviously you need to have some space for two instrument manipulation. So the larger tubular retractor is required. I am not very sure about we were taught that and we have seen that if there is a bleeding, then the dry field technique is more helpful, because in wet field, if there is a bleeding, then the whole thing disappears. I mean, it is difficult to visualize. So it is better to use the dry field technique in that case. But some of our speakers have said that the wet field technique, you can see vessels very well. I think it is true when you have very small little ooze or some small little bleeding. So that is what overall everything has been covered so well. Thank you, sir.
Maybe I think Dr. Takeuchi is here with us. Can you hear us? Takeuchi? Dr. Takeuchi,
Yes.
can you make some comment for Professor Yadav?
Sorry. I'm here just now, so I don't hear the question. Sorry.
His comment is just how nice of the tubular surgery, which you applied. So maybe I think Japanese priority.
Yes.
This the tubular surgery. I think you can make some comment.
Yeah, I think we can reduce the size of the tubular retractor. Even we can use a 6 mm diameter cylinder. We can visualize the tumor and the normal brain, and we can dissect the tumor with fine forceps and the bipolar coagulators. But for this kind of surgery, we have to use specific surgical instruments. But and wet field surgery can visualize the tumor bed very naturally and expand the tumor bed. I think that is a very advantageous compared to the microscopic surgery, because only endoscope can visualize tumor bed underwater.
Main question was dry field against wet field in terms of hemostasis.
Yes. Yes. In the I performed some animal study, and when slightly wetty field cannot stop the bleeding. Dry field can stop the bleeding, and if we feel the 5 or 10 centimeter water level, we can stop the bleeding very quickly. So that is very advantageous for the eloquent area tumors.
Yeah, I think to make things little more clear, I want to say that for very small tubular retractor and using at least 2 instruments, it's very difficult. But what you have rightly said, which people need to understand, is that you need to use the angle tip instruments. The linear movement is impossible because you don't have sufficient space. So
Yes.
when you have an angle tip instrument, then you can rotate things rather than having a linear movement. So you are right, the point is well taken.
Yes.
I think we can move ahead. What I am saying is that it is impossible to control bleeding when there is a brisk bleeding. You can see bleeding vessels and all that when there is a small this thing. So
Yes.
right field technique is the best when there is a severe hemorrhage. I'm not talking about a minor ooze. So I think let's move on. Yeah.
Yeah. But if I don't pull the tumor, that bleeding point always in front of the tubes. Of course, we can get the 6 millimeter diameter surgical field, but the hemorrhagic point is always there if we pull out the tumor. So that is not so big problem for us.
Yeah. The other point I want to make in controlling bleeding, which I have described in some of my articles, are that if there's a bleeding in the tubular retractor, I use silicone tube, which is quite inexpensive. So when there's a bleeding, you just push in your tubular retractor, gently push this inside. This causes tamponade effect. It compresses the vessel or the branch from where. So invariably, when there's a bleeding, you just push in the in parenchymal tumor, just push it gently inside, and the bleeding stops. Most of it. So,
yeah.
Thank you.
Thank you.
Sorry, Dr. Kato, you were asking something. You are muted. You'll have to unmute yourself. Yeah.
Okay, so thanks. So he asked Dr. Takeuchi about how to control the bleeding, and also he asked vascular lesion. So Takeuchi, can you reply to him? How you can treat the vascular lesion, such as a small AVM or
I have only a few cases of the vascular lesions, but in such case, the most important thing is place location of the cylinder tip. At first, we insert a small cylinder to coagulate the feeding arteries. Then another cylinder is inserted from the different angle and remove the tumor or vascular lesions. So I sometimes use multi-cylinder surgery for such kind of cases. I only use 6 millimeter or 10 millimeter diameter cylinder, so that is not so big. Big damage to the brain. Like as abdominal endoscopic surgeries, we can insert multiple cylinders for such kind of cases. And in some kind of cases, we perform the embolization before the removal procedure. That is also useful for such kind of cases. Is that clear?
I think so. Thank you very much, Dr. Yadav. Is okay?
Yes, sir. Yes, ma'am. Yes, ma'am. That's fine.
So
excellent, excellent. Yeah. The other, I think there was another question from Professor Dev Pujari himself, that can we use tubular retractor in skull-based surgery? So that is there. I have done some modification. Rather than tubular retractor, I use semicircular retractor. I cut tubular retractor in half.
I will talk about how endoscopy is beneficial for microvascular decompression surgery.
Sachin,
microvascular decompression requires.
Sachin, can you wait a little bit?
I think you cannot. I think
Two elements.
We can discuss later.
Precise identification of neurovascular conflict and appropriate decompression. The endoscope provides panoramic views even in the deep surgical field with minimal invasiveness. Transposition technique is a desirable method for long-term outcomes. In our institute, fully endoscopic microvascular decompression is performed. The patient is placed in park bench position. After making a 3 cm skin incision, a 2 by 1 cm keyhole is created at transverse sigmoid junction. The same keyhole is made for trigeminal neuralgia and hemifacial spasm. The endoscope is fixed at pneumatic endoscope holder, and bimanual technique is performed. Single shot instruments are used. Brain retractor is not used. The decompression procedure is classified into two methods: interposition and transposition. For interposition, the prosthesis is placed between the cranial nerve and the offending artery. In contrast, the transposition, the offending artery is moved away from the cranial nerve and fixed at the dura with fibrillin glue and Teflon felt. Interposition is technically easier, but the recurrent rate is higher than transposition. In contrast, transposition is technically difficult, but the desirable method for long-term outcomes. And next, the anatomy of the endoscopic retrosigmoid approach is shown by cadaver dissection. The endoscope is inserted to the retrosigmoid keyhole, and then the endoscope proceeds the tentorial surface of the cerebellum. Now we can see the trigeminal nerve, SCA, and the superior petrous vein. Also, the third and fourth nerves are visible. The 30-degree endoscope will visualize the course of the trigeminal nerve. Also, the cranial nerves are visible, and behind the trigeminal nerve, the sixth nerves and the basilar artery are visible. The 30-degree endoscope also visualizes the Meckel cave. Surgical cases of the endoscopic microvascular decompression are shown. The first case is the left side trigeminal neuralgia caused by the SCA. In this case, the rostral trunk of the SCA making a small loop and compressing the trigeminal nerve. For this case, simple transposition method is performed. Now the trigeminal nerve is partially visible behind the superior petrosal vein. The trigeminal nerve is compressed by the caudal trunk of the SCA. The SCA is moved away from the trigeminal nerve and fixed at the tentorium with fibrin glue. Complete decompression is achieved. This is a case of the simple transposition. Pre- and post-surgical views are shown. Next case is the right trigeminal neuralgia. The trigeminal nerve is compressed by the deep loop of the SCA. For this case, two-step transposition technique is performed. The trigeminal nerve is compressed by the caudal trunk of the SCA. Here is the neurovascular conflict. And then the cerebromesencephalic of the SCA is identified and pulled out. This segment of the SCA is fixed with oxyl ball. And this is the first step of the transposition. After the loop of the SCA became shallow, the SCA is transposed and fixed at the tentorium with fibrin glue. This is the second step. Finally, secure decompression of the trigeminal nerve by the two-step transposition technique is confirmed. Pre- and post-surgical views by two-step transposition techniques are shown. The next case is also trigeminal neuralgia caused by the SCA. But in this case, the rostral and caudal trunks of the SCA are making a deep loop and compressing the trigeminal nerve. For this case, the compressed transposition is required. This is the video. The trigeminal nerve is compressed by the deep loop of the SCA. Here is the distal part of the SCA. First, the distal part of the SCA is lifted with the sagittal ball, and the loop of the SCA is pulled out. We can see the motor root of the trigeminal nerve, and then the caudal trunk of the SCA is pulled out and fixed at the tentorium. The rostral trunk is also fixed with the same fashion. The offending arteries are disappeared from the view and complete decompression is performed. This is the case of the complex transposition. Pre- and post-surgical views are shown. Secure decompression is achieved. Next is complication management and the endoscopy. One of the possible complications during the endoscopic microvascular decompression is venous bleeding from the superior petrosal vein. Venous bleeding from the superior petrosal vein must be controlled properly even under endoscopy. Here is a video of the management of the venous bleeding from the superior petrosal vein. venous bleeding is started. The irrigation and suction is continued to clear the surgical field. And two surgical balls are used for the management of the venous bleeding. The first surgical ball is placed behind the superior petrosal vein. It works for the scaffold of the second surgical ball, and the second surgical ball is placed in front of the superior petrosal vein. Now the superior petrosal vein is completely covered with the surgical balls. After waiting several minutes, the bleeding is controlled. Hemostasis is achieved. The surgical balls are removed, and the clear surgical field is maintained. Next, variant cases are presented. This case is a trigeminal neuralgia on the right side. Caudal aspect of the trigeminal nerve is compressed by the Icar-Picar common trunk. The video is shown. The trigeminal nerve is compressed by the Icar-Picar common trunk. The arachnoid membrane around the offending artery is opened, and the offending artery is transposed from the space between the 8th and 9th cranial nerves, and then fixed at the petrosal dura with fibrin glue. By this transposition technique, secure decompression is confirmed. The trigeminal nerve is nicely decompressed. Next case is trigeminal neuralgia on the right side. Offending arteries are SCA and Icar-Picar common trunk. For this case, endoscopic microvascular decompression with transposition technique is also performed. Here is the video. The trigeminal nerve is compressed by the SCA and the Icar-Picar common trunk. The decompression procedure started from the decompression of the SCA. The SCA is transposed and fixed at the tentorium with fibrin glue. And then the Icar-Picar common trunk is transposed from the space between the 8th and 9th cranial nerves. And the artery was fixed at the petrosal dura with fibrin glue. Secure decompression is achieved. Pre- and post-surgical views are shown. Trigeminal neuralgia immediately disappeared. Next case is the trigeminal neuralgia caused by the Icar and the vertebral artery. The trigeminal nerve is directly compressed by the Icar and indirectly compressed by the vertebral artery. The video is shown. The trigeminal nerve is compressed by the Icar. Also, vertebral artery is visible behind the Icar. Clear indentation of the trigeminal nerve is visible. Decompression procedure is started from the vertebral artery. The vertebral artery is moved medially and fixed with the fibrin glue. Also, the transposition is reinforced by the Teflon felt. Then the ichor is transposed and fixed at the petrosal dura. Also, the SCA running near the trigeminal nerve is transposed, and this is the final view of the decompression. Even in this case, the trigeminal nerve is decompressed by transposition technique. Endoscopic microvascular decompression allows reliable identification of neurovascular conflict with minimally invasiveness. Endoscopic microvascular decompression with transposition is technically feasible, and using the fibrin glue is a simple and safe method for fixation of transposed arteries. Endoscopic microvascular decompression with transposition is expected to offer excellent long-term outcome. In conclusion, endoscopic microvascular decompression with transposition is expected to offer excellent surgical result. Thank you for your attention.
Good morning, friends. I'm going to talk about the endoscopic lumbar decompression. My talk will be in three parts. One is my short introduction, and then the message for young neurosurgeons, and then the talk itself. So, nothing to declare. I received my neurosurgery training from PGI Chandigarh. I'm working as Director Super Specialty Hospital, Professor and Head in Neurosurgery at Jabalpur. I developed a School of Excellence in Neurosurgery at Government Medical College. Initially, there was no facilities when I joined. Popularized neuroendoscopy in India, published 188 articles, with more than 8,500 citations, and out of them, more than 80 publications are on neuroendoscopy. I'm expert reviewer and referee of more than 40 international journals, editor of popular book entitled Endoscopic Surgery, A Comprehensive Approach, co-editor of Neurology India, conducted 3 clinical trials, CRESS, CRESS2, and BRAIN trial, performed 51 live operative and cadaveric workshop as faculty, trained over 600 neurosurgeons through 20 endoscopy fellowship training program of 1 week at Jabalpur, organized 9 prestigious orations at Jabalpur, describe a new technique to avoid blind area in endoscopic surgery, develop a new tubular brain retractor and semicircular brain retractor, and an inexpensive model for training in endoscopy. I am President-elect of Neurological Society of India, past President of Neuroendoscopy Society of India, and Madhya Pradesh Association of Neuroscience. Recipient of Charak Award, visiting professor at AIMS, Delhi, and received a certificate of appreciation from Dean on Nation's Independence Day. Regarding message to young neurosurgeon, there are difficulties to get a good opportunity for most of the young neurosurgeons. Some of them, they get a good institution and good infrastructures, but majority of them may not get that ideal opportunities. So my advice to them is do whatever is possible. If the facility for simple surgeries are there, you start with that. Do not try and repent to get the ideal things which you want, the high-end surgery. So you start with the simple cases, improve your skill. Gradually, the facilities will be added by the administrator. Improve your skill and progress, rather than waiting for ideal things to happen, which may take very long time. So have patience, respect your seniors, and the other important aspect is that you should identify a subspecialty of your choice and try to develop that subspecialty, which will give you name as early as possible. So how to select that subspecialty? You should take sufficient time and apply your mind and decide which one you want to take. It should be unique, it should be interesting, and should be possible in your local setup. There should be sufficient indications, affordable, and you should be proficient in that subspecialty. And there should be a mentor or a training center where you can improve your skill. The clinical outcome obviously has to be better or comparable to existing method. If the answer is yes, then you further improve your skill, visit the experts and visit the center where it is commonly performed, attend live operative and cadaveric workshop, invite expert guest faculty at your place, watch live surgeries and video, practice on model, and start with simple case and then progress on to the difficult one. You should be able to take help from seniors and other colleagues in the other department. And if you succeed, then you further keep improving your skill, publish and present in the conference. If you don't succeed, then think of choosing another specialty. And this is how I also worked. When I started my career at Jabalpur, there was no separate ward for neurosurgery. There were no residents. There were no trained staff, neuro nurses, no operation theater for neurosurgery, no equipment, and I was the only neurosurgeon for 15 years. And now we have a School of Excellence in Neurosurgery with 135 beds. We have MCH residents and neuroendoscopy fellows. Trained nurses are there. There are 6 operation theaters for neurosurgery, and we also have almost all modern facilities in neurosurgery. And there are 11 qualified neurosurgeons. Coming on to my main topic, that is endoscopic interlaminar management of lumbar disc and LCS. We all know that the lumbar disc is quite common. Majority of them can be managed by conservative means, but surgery is indicated when there are unilateral or bilateral symptoms, single or multiple level, migrated disc, lateral, central, extraforaminal disc or recurrent disc, calcified or fibrous disc, and it can be done at all level, including from L1, L2 to L5, S1. One can also decompress the LCS doing interlaminar approach. The contraindication for simple disc removal or decompression is unstable spine. In that case, you have to fuse also, and if the level of pathology extends 3 or more level, it takes more time, so I operate only up to 2 levels. Regarding the investigations, MRI is the investigation of choice. CT scan also adds to find out the detail about the bony pathology. So in the investigation, you should find out the status of spinous process, whether it is angled, straight, tip broad, or the base may be broad, which may cause difficulty in surgery. The interlaminar window, the lamina, whether it is vertical, horizontal, or oblique, the disc, whether it is prolapse, lateral, central, or foraminal, and whether there is any migration of the disc fragment. The root location, whether it is displaced medially, laterally, or posterior, what is the status of foramen, whether it is reduced in size because of facet hypertrophy, disc bulge, osteophytes, or ligamental hypertrophy. These are some of the examples. You see the spinous process is bulk process is angled. So all these things will not allow tubular retractor to be properly docked. Regarding the disc prolapse, it could be shoulder type, axillary, or the disc may be prolapse, maybe ventral type. If it is ventral type, the root posteriorly, which may make this root to be prone for surgery, for injury. Regarding the procedure, it is done in prone position on radiolucent table, generally under general anesthesia. The localization is done at the level where the pathology is. You can use different type of tubular retractors. Prone position using either bolsters or knee chest position, or you break the table, will allow the abdomen to be free, which will decrease the venous bleeding during surgery. In localization, one can use different localizers or even a spinal needle, but the non-invasive localizers are also available with different movements. So the both arm of the localizer should superimpose with each other, otherwise there will be wrong localization, and they should be about 90 degree to the floor. You should mark the midline as shown here, and mark the level of pathology with C-arm. The skin incision is given about 1 centimeter lateral to the spinous process and should be about 1.5 to 2 centimeter in length. The fascia is also cut in the same direction. The paraspinal muscles can be separated from spinous process, which is done usually in desk endo technique, but you can go through the muscles and gradually dilate the paraspinal muscles. Soft tissue in front of the bone, that is lamina and facet joints, are removed, and then you should resect the bone, that is the superior or inferior lamina and medial part of the facet joint, using burr, trephine, or rongers. This is a short video of a patient having a disc prolapse at L4-5 level. The massive disc at L4-5, bilateral symptoms more on the left side. This is post-operative MRI showing good decompression at L4-5 level. The approach was from left side because the fragment was more on the left side. The superior lamina is being removed using Carrison punch till you find the superior end of ligamentum flavum. And after that, once you find the superior end free as of the ligamentum flavum, you separate the ligamentum flavum from the dura using the right angle dissector and taking help of patties in between the ligamentum flavum and the dura. And after that, you try to separate the disc fragment from the root and the thecal sac. Do not try to retract the root once there is a big fragment already protruding. So disc is already stressed. So if you further retract it, you may produce irreversible damage and the patient may have deficit either or may have persistent paresthesia, decompress the foramen as being done, and in the cavity is irrigated with saline. And then you close. So this, when you have the bilateral symptoms, the tubular retractor can be angled to the opposite side. One should also drill the base of the spinous process. Without drilling the base of the spinous process, it will be very difficult to reach the opposite side. So drill the base of the spinous process, undercut the opposite side lamina, keeping the ligamentum flavum intact, and thereby you reduce the chances of dural tear. Regarding the central disc, how to remove from the ipsilateral side when there are central disc with bilateral symptoms, you decompress on the ipsilateral side, create a cavity in the disc space, and then push the central disc and the opposite side protruding disc in the cavity and take out from the ipsilateral side. The advantage of endoscopic approach is that it allows better visualization. It is a minimally invasive, reduces hospital stay. There is a lower cost, and it allows observer and operative room staff to be more involved. Therefore, it is better for education also. But there are limitations. There is a steep learning curve. There are more complications, especially in the learning curve. There may be more operative time, but especially when you achieve learning curve, then the operative time also decreases and the complications and the results are comparable to microdiscectomy. You might have to convert to open procedure, especially in the beginning of your learning curve. This is one of our case of L4-5 disc with right-sided symptoms, and this is after surgery, good decompression. Another case with two-level compression at L3-4 and L4-5, and after surgery, good decompression of thecal sac, expansion of thecal sac. This is a 3D picture of one of our case with two-level bilateral compression, and you can see that only one side lamina have been removed and the bilateral decompression is possible. Regarding the results, the result of surgery are better than conservative treatment up to 4 years, but it is same as far as conservative treatment goes at 10 years. There are complications. You can have dural tear, pseudomeningocoele, case of leak, persistent paresthesia because you retract the root without taking the disc, meningitis, and the wrong level surgery. The CSF leak after surgery may be seen when large central or extruded disc, and if the disc is migrated inferiorly. We know that towards the inferior lamina, the lower lamina, caudal lamina, the ligamentum flavum is attached at the superior end only. So there may be risk of dural tear there. And when there is a resurgery, in such cases, there is no ligamentum flavum and there is a scar tissue which is adherent to dura and the root. So one should not try to separate dura from the scar, but separate scar from the bone to avoid dural tear. The root injury and paresthesia are another complications, and it is more common when the root is pushed back by the disc, ventrally placed disc. As shown here, if the root is very close to the lamina or ligamentum flavum, it may be caught by the Carrison punch. If you try to retract the already stretched root without removal of the disc, there may be a root injury if there is a thick ligamentum flavum and you try to insunate Carrison punch from the medial side. So the trick is either you should try to remove this ligamentum flavum, which is quite thick from cranial or caudal end and not from the medial end of this. Regarding the incomplete decompression recurrence, one should know that it is not only the disc which is responsible for root compression. There may be multiple components in the form of disc, the spur, or facet may be hypertrophy, or the ligamentum flavum may be hypertrophy. So all components which are responsible for root compression must be decompressed. So to summarize, interlaminar approach is effective and safe in unilateral or bilateral symptoms, single or multiple levels, migrated disc, lateral central extraforaminal disc, recurrent disc, calcified or fibrous disc, and the disc at all levels. The results are good, but there is a learning curve, and the complications may be more, especially in the learning curve. For detail, you can refer to chapter 24 of my book, Endoscopic Surgery Comprehensive. Thank you very much. Thank you.
Hello, Prof. Azmi. Do you wish us to play the video or you want to present live?
Can you place the video?
Yeah, I'm just playing the video.
Okay, thank you. Good evening, everyone. First of all, I would like to take this opportunity to thank Professor Yoko Kato and Professor Chandrasekhar Jopujuri, the Honorary President of this special webinar on Pure Neuroendoscopic Neurosurgery Summit, for the invitation. Today, my talk will be on endoscopic treatment for CSF pathway obstruction. Neuroendoscopy means looking into cavity. In order to use endoscope, we need enough space to allow movement of the endoscope and instrument for certain procedure. The space must be larger than the endoscope, and also we need some distance from the tips of the endoscope to the target lesion to allow safe maneuver of the instrument without causing any neurological injury along its trajectory. There are various potential spaces in the brain, including free-form space in the ventricle. The pathological obstruction along CSF pathway in the brain will gradually result in expansion of this free-form space and creating hydrocephalus, making it favorable as a medium for surgery. Endoscope can be used for both diagnostic and therapeutic purpose, especially in treating CSF pathway obstruction. Based on radiological feature, CSF pathway obstruction can also be divided into 5 different categories, which are monoventricular hydrocephalus, biventricular hydrocephalus, triventricular hydrocephalus, tetraventricular hydrocephalus, as well as multiloculated hydrocephalus. I find that this radiological description is very useful to predict the site of obstruction, to determine the commonest cause, and also to guide the treatment approach. Endoscopic neurosurgical procedure can also be divided into 3 different types. And today's presentation, I will focus on endoscopic neurosurgery, of which the procedure is entirely done through the endoscopic working channel. Now we go to a case illustration. Monoventricular hydrocephalus refers to a condition on the CT scan or MRI showing that unilateral dilatation of the lateral ventricle. Therefore, the site of obstruction is predicted to be at the ipsilateral foramen or Monro. There are various causes which include post-inflammatory adhesion and tumor. This is example of 1-year-old girl who had hydrocephalus secondary to meningitis. She underwent a right ventricular peritoneal shunt and presented to the hospital with symptoms of obstructive hydrocephalus and altered sensorium. CT scan shows unilateral ventriculomegaly. As the endoscope is inserted into the frontal horn of the lateral ventricle, we found that the foramen or Monro is obliterated by adhesion, and there is also evidence of previous infection and slough. In view of the foramen or Monro is a little bit friable in the presence of this infective material, so we decided to do endoscopic lavage first to replace the contaminated CSF within the lateral ventricle. You can see the correct processes are clear, and this is followed by endoscopic septum pellucidotomy at 2 different places. So once the lavage is completed and the CSF is much clearer, then we make a combined penetration using the tip of bipolar and further enlarge with purgative catheter. And as we enter into the contralateral ventricle, you can see that the shunt tip of the shunt catheter is nicely sitting there. Endoscopic penetration was made at 2 different places to ensure the patency of the stoma in case of healing process occur. The next case involved a 3-year-old girl, known case of leaking myelomeningocele at birth with hydrocephalus. She underwent a right ventricular peritoneal shunt, but subsequently presented with obstructive hydrocephalus and altered sensorium. CT scan shows left lateral ventriculomegaly with the tip of shunt in situ. Intraoperatively, you can see both foramen Monro is visualized, and as we turn the endoscope obliquely, we start to see the covered by the release the adhesion from the tip of shunt. Subsequently, with the endoscopic grasper, we pull it and position it freely within the frontal horn of the lateral ventricle, and the child recovered very well after surgery. Biventricular hydrocephalus, the typical site of obstruction are usually at the bilateral foramen or Monro, and the commonest causes include third ventricular tumor, colloid cyst, and post-inflammatory adhesion. So this is 43-year-old lady who presented with intermittent headache and obstructive hydrocephalus. MRI showing typical characteristic of colloid cyst. It is important to recognize that colloid cysts are usually covered by correct plexus from both sides of the third ventricle. In order to avoid uncontrolled hemorrhage, I usually prefer to coagulate the correct plexus first. Then I try to separate it and expose part of the cyst wall. This is followed by controlled penetration of the colloid cyst to the size just fit enough for the aspiration catheter to be inserted. I routinely use infant feeding catheter size 8, and I cut the tip of the catheter slant with pointed end along the blue tack. The size of penetration is carefully selected to ensure the cyst wall can be grabbed and hold using endoscope forceps after aspiration. I choose to use the infant feeding catheter because it is firm yet flexible. It is transparent that allow me to see the content of the aspirate, and the presence of blue tack can guide me to the depth of the catheter as we move along. Once the cyst is collapsed, usually there will be a nice plane created with controlled pulling of the cyst wall out of the third ventricle. I usually inspect the pedicle as it's usually stuck with coroplexus from the contralateral side, and which is need to be coagulated and cut prior to retrieval of the cyst wall. And finally, we put back the scope for inspection to ensure that there is not much injury, especially to the foramen Monroe. And it is quite important to make sure that after the surgery, the CSF and the floor of third ventricle need to be clear from any debris as well, especially the collect content, because it can cause obstruction to the aqueduct of Sylvius. In my experience, most of the cases, the cyst can be easily removed. I think almost more than 90% without any much problem. This is another case of 8-year-old boy who also presented with obstructive hydrocephalus and endoscopic excision of the colloid cyst being done using a similar technique, strip shaving pre-coronal borehole at the lateral canter of the eye, and the tumor also completely removed. Sometimes the colloid cyst can be very firm and it's quite difficult to decompress using aspiration catheter. So in this case, I have to do endoscopic septum pellucidotomy and try to push it through the stoma using angle monopolar diatomy so that I can eventually retrieve it from the ipsilateral foramen of Monroe. Now we move to triventricular hydrocephalus, and the site of obstruction is typically at the aqueduct of Sylvius. Among the commonest causes include pinna region tumor, tectal plate tumor, primary and secondary aqueduct stenosis. In triventricular hydrocephalus, the fourth ventricle is normal in size, but two lateral ventricle and the third ventricle are grossly dilated. This is a 7-month-old baby who presented with triventricular hydrocephalus. MRI revealed she had primary aqueduct stenosis. This is a very good indication for endoscopic third ventriculostomy. As you can see, the foramen Monroe are grossly dilated. So the site of the stoma for ETV, usually I put in the middle of imaginary triangle connecting the infundibulary recess and two mammillary body. So I routinely use tip of the bipolar first to palpate the floor of the third ventricle, and then try to penetrate it. This is followed by balloon dilatation using Fogarty catheter. Once the stoma is created, the prepontine cistern is inspected, and it is very important to make sure that the second membrane also penetrated. Otherwise, the ETV may not be functioning well after the surgery. There are various ways to penetrate the floor of the third ventricle. They can use a tip of bipolar, tip of monopolar, Fogarty catheter, or specially designed ventriculostomy forceps. And there are various indications, and the success rate for ETV depend very much on the type of the causes, which can be divided either high, intermediate, and success rate. Now we move to pinna region tumor. The preoperative MRI, especially the sagittal view, is very important. I use the interthalamic mass as the reference point, especially if the tumor encroaching to this interthalamic mass. The typical pre-coronal borehole is adequate for us to do simultaneous ETV and biopsy. But sometimes for more posteriorly located tumor in the pinna region, so you need more frontal borehole. So I make a modification choosing the midway between these 2 points with oblong-shaped borehole. The use of image-guided surgery can be very useful, which can help for you to determine the best trajectory for ETV and biopsy. As at the same time, you can mount the navigation system to the endoscope so that you have a better orientation about the position of the scope and throughout the surgery. I usually perform the ETV first, followed by biopsy, and revisit back the stoma at the end of the surgery to make sure that there is no blood clot or operative debris. This is very important to ensure the stoma is patterned after surgery. The ETB is performed using a standard fashion. This is followed by biopsy. I usually rotate the endoscope about 90 degrees clockwise to reach to the target, and usually multiple biopsy, about at least 3 to 5 specimens will be sent for histological biopsy. For large tumor encroaching beyond the interthalamic mass, the biopsy usually can be done much easier. For more posteriorly located tumor, I usually use the tip of the bipolar to coagulate the correct vessels first, and followed by stretching the foramen or Monroe a little bit along this area using the tip of the endoscope in order to reach to the area behind the interthalamic mass, like this. This is an example of pinoblastoma in 6-year-old girl who presented with headache, fever, poor oral intake for 1 week. Simultaneous ETB and biopsy done. We send a frozen section because it is done during office hour and the pathologists are available. The HP came back pinoblastoma. She underwent radiotherapy and chemotherapy. And this is how she looks like 3 weeks after surgery. The wound healed well and hidden nicely underneath the hair. Follow-up MRI about 6 months later. As you can see, the tumor shrink. And on sagittal view, the aqueduct even reopened. An example of pinoblastoma in 5-year-old girl who presented with obstructive hydrocephalus in another center. Emergency ventriculoperitoneal shunt was done, followed by stereotactic biopsy. But unfortunately, the shunt infected and histology was inconclusive, and she was referred for further treatment. As you can see, there's a large pineal region tumor with drop metastasis at the cell suprasellar area. So as we enter with the endoscope, we found that the CSF is contaminated by previous hemorrhage, and there are a lot of membrane in between, especially around the foramen or Monroe and the third ventricle. So we have to do lavage first to clear all the CSF content, and subsequently we do adhesiolysis to release all this membrane. And once we have cleared the floor of the third ventricle and we have identified the landmark for the ETB, then we perform endoscopic third ventriculostomy. Once we are able to visualize the floor of the ventricle very well, we perform the endoscopic third ventriculostomy using a Fogarty catheter and slowly enlarge the stoma. But unfortunately, we also found that the tumor infiltrates into the prepontine cistern. So we take final inspection before we close to make sure that there is no post-operative hemorrhage or debris within the floor of the third ventricle. And we inspect back the stoma. You can see part of the tumor still covering it, but the prepontine cistern are a little bit clear. So post-operatively, we decided to put an EVD. Unfortunately, the patient was drainage dependent. About a couple of days later, she underwent ventriculoperitoneal shunt. This is immediate post-op CT scan. This is 18 months after post-chemotherapy and radiotherapy. On the MRI, sagittal view shows that the tumor responding well to treatment. This is another view. This is sagittal view of MRI about 18 months after chemotherapy and radiation therapy. As you can see, the tumor responded well to treatment. And this is another view of post-operative MRI. For tetraventricular hydrocephalus, the typical site of obstruction involves the outlet of the fourth ventricle at both foramen of Pushka and Megendi. Among the causes include post-inflammatory adhesion or tumor. So this is a unique case of a prepontine cyst in a 3-year-old boy who presented with obstructive hydrocephalus. The cyst extends from the floor of the third ventricle down to the level of C3. So we entered through the typical pre-coronal burr or ETB. As we go through the foramen or Monroe, we find the dome of the cyst. Multiple fenestration was done using tip of bipolar and followed by partial cyst wall excision. And this is very important step to make sure that the communication is established between the ventricle into the cyst and subsequently from the cyst to the cistern through cystocystonostomy As you can see here, second perforation was done at the lowermost part of the cyst. This is a summary of the procedure, and the patient recovered well after surgery. Sometimes the CSF partial obstruction can be caused by infection, for example, pyogenic ventriculitis. This is a 6-month baby who developed hydrocephalus secondary to prematurity intraventricular hemorrhage at the VP shunt, but it was infected by Staphylococcus aureus and further complicated by pyogenic ventriculitis. Typical MRI appearance of ependymal enhancement, ventricular debris within dependent area, hydrocephalus, and supported by clinical diagnosis and blood result. We enter the ventricle from the right side. We use infant feeding catheter to aspirate the content first to make sure that all these infective debris are aspirated well. We do not initiate the irrigation, because if you initiate the irrigation at the beginning of the surgery, so all this infective material will start to scatter away and we will obstruct your operative view. So once we have cleared most of it, then we start our irrigation. Now you can start to see the interthalamic mass. And the focus of this surgery is to remove as much as the infective debris. Now we're looking at the aqueduct of Sylvius, where it is previously obliterated by this purulent material. So by doing endoscopic lavage, you can clear the CSF, you can immediately remove this infective debris. You can also prevent from further complication from addition secondary to this severe infection. For pyogenic ventriculitis, we prefer bilateral transfrontal approach instead of unilateral approach, because based on our initial experience, we could not remove successfully a hidden pocket of pus where the endoscope could not see and could not reach safely. Now we move to the last part, which is multiloculated hydrocephalus. Compartmentalized hydrocephalus usually occur as a result of healing process by multiple adhesion and membrane formation following severe infection or hemorrhage. Therefore, they are usually shunt dependent. Traditionally, we use catheter trocar to penetrate at multiple area followed by multiple VP shunt. Endoscopic procedure offer more effective alternative solution by simplifying this complex hydrocephalus, and subsequently it will take over with a single VP shunt. The placement of burr is determined based on the safe and best trajectory in direct line, especially if you use a rigid endoscope, and if possible, to cover the most numbers of compartments through a single burr. And sometimes the use of IGS and endoscopic mounted IGS can be useful as adjunct tools to guide the procedure. The preoperative imaging, in particularly MRI in axial, sagittal, and coronal view is important to help us understand the complexity of the hydrocephalus and guide the planning and treatment strategy. Example, not all compartmentalized hydrocephalus are completely occluded or obliterated. As you can see, there is still communication between the first compartment to the largest compartment deep inside. So we use tip of bipolar to enlarge it. And as we enter to the second compartment, you can see there is another small compartment with a thin membrane. So using a similar technique, we use a bipolar to penetrate at the thinnest part of the septum. So using a bipolar also, we do multiple fenestration to fenestrate into the third compartment. And finally, we went through the septum pellucidum on the medial aspect of the area, completed with the ipsilateral ventricle. Then we turn the endoscope medially, and then we do septum pellucidotomy because there's another trap ventricle on the opposite side. And then subsequently we entered, this is on the opposite side, which are much more clear and not much obstructed. And at the end of the surgery, we do lavage to make sure that the operative debris is cleared and followed by single shunt. Another case of compartmentalized hydrocephalus with blocked VP shunt, you can see the tip of shunt is covered by adhesion. So in this particular case, I decided to come in from the left frontal horn and we get perpendicular access to the tip of shunt. And through enough during surgery, we found that the tip of the shunt is completely covered by the choroid plexus and thick membrane. Another example of compartmentalized hydrocephalus in 2-year-old boy who developed hydrocephalus secondary to meningitis and come to the hospital with repeated episode of suboptimal shunt malfunction. You can see tip of the shunt actually covered by thick membrane and only small 1 or 2 hole is patterned. So that's the reason why the shunt is intermittently blocked. So we went in again with endoscope and we do multiple penetration and communicate the trapped ventricle. Subsequently, the shunt was removed and we replaced with a new one. And the child recovered very well. In summary, neuroendoscopy offers significant advantage that it allows minimal invasive procedure to be done for the treatment of various pathology within CSF pathway through a small incision with minimal tissue traumatization. Good imaging is necessary to guide treatment approach. The safety and the success of this procedure ultimately depend very much on the case selection and the experience of the surgeon. With that, I end my presentation. Thank you very much for your kind attention.
So we through with our second session, and there's a time for 5 minutes for the discussion, and after that there will be a live. All presentation. Dr. Deputy.
Yeah, there is a question in the question box to Dr. Fuminari Komatsu about the fact that do you always need to put the glue on the vessel to, sort of glue it to the tentorium, or do you also believe in other, I think he has shown some other ways of decompression as well, but the specific question is, do you think that should be the mainstay of the treatment?
So I'm sorry, because the Komatsu is now on duty tonight, so he cannot reply. So maybe I can replace from him. So the reason our strategy is just transposition. So the no more insertion of the such kind of the Teflon. I think the most of the case, it's the tent is very close and easy to the transposition and plus some adhesive. I think transposition is very simple, easy, and also very effective. That's our strategy now. Thank you.
Two other questions to Dr. Stefan about the fact that how do you dissect when you see that the dura is thinned out and the tumor is adherent to arachnoid? Is there any sort of tips to do that? And second is to the lateral cerebellar approach, that do you use navigation while cutting the tent?
So the second question is to Dr. Takeuchi or?
To Dr. Wulsberger.
Stefan? Okay.
Are you there, Stefan? I think he is not with us.
Yes.
So the question to the lateral supracerebellar, forget the name of our friend who gave that talk, about cutting the tent and use of navigation, doing that while removing the tumors from the lateral supracerebellar approach.
Someone can reply. So, Dr. Takeuchi.
I mean, it can be useful, but I think you see your anatomy very well. If you want to cut the tentorium, you need to be sure once you have seen the medial edge, and if you have been clear about the venous anatomy, then probably you do not need to use it at that particular time. Though it is a fixed structure and it would not be disturbed by CSF drainage, etc. I'm not sure if Dr. Rish, would you have any comment on this?
On navigation?
Navigation for cutting the tent in the supracerebellar approach.
No, I don't think so. But I would like to give a comment to the endoscopic paper, the last one of Asmin. Is it possible?
Yes, please go ahead.
I'm a little bit surprised that I have not heard anything about ultrasound, because especially in such complex hydrocephalus cases, the ultrasound is a very easy intraoperative imaging. I am rather sure that endoscopy will not make progress if we don't use, if we do not add ultrasound to endoscopy in the future.
Yes, we have intraoperative ultrasound in our center. We also use pre-operatively. Yeah, but I found that majority of the cases we just need preoperative MRI imaging is adequate. We use ultrasound for more open technique like brain tumor, posterior fossa. But for hydrocephalus, I use the classification based on the MRI. It's an enough space, big space, and then it's good enough to go in. We may use ultrasound if the ventricle are small. So there may be advantage, but in the series of cases that I show, it's all big dilated ventricle that you can easily enter to the area. So that's the reason why I don't use ultrasound in the series that I presented. But it is a good tool, I agree.
Yes, I think we need more to teach the youngest the ultrasound, because it's in general, it is a imaging tool and a navigation tool that makes minimal invasive neurosurgery more safe, and it makes it easier. You become much more safe, also psychologically, if you have a good imaging tool intraoperatively. You have your own private neuroradiologist beside you. It's a very good feeling, yes.
There are two other questions to Dr. Azmi. One is about why do you use linear incision rather than a flap? Does it bother you in terms of CSF leak? And secondly, what are your indications of putting EVD after performing a ATV procedure?
Okay, my preference still a linear incision because I can do strip shaving, but underneath I do flap on the pericranium. And then I push to one side, and then I make a borehole. So at the end of procedure, I will cover back the flap. I stitch it. But certain case, I do a flap where number one, if the ventricle are too huge, after surgery, that we don't have space, then we see
they are here at the moment. So there's one other talk, and then it's me. So they are delayed.
Delete. Sorry, there is some background noise.
30 minutes. I know this is for 36. This is 30 minutes talk. No, 36 to 1. So this is 24 minutes talk, and this will be 40 minutes.
Can we continue the discussion? Or we, okay. So if there is not much of brain, for example, a huge hydrocephalus, then I will do flap because I need to stitch the dura when we open. Or if I need to use a big endoscope, for example, LOTA, yeah, the size is 6.8 millimeter, chances of CSF leak is huge, then I will use a flap. So that's the only reason I use flap, but I reserve it. Second question, when I use EVD, if the procedure is straightforward, and I think the reason for surgery is to remove the cause and there is not much of issue, of CSF blockage after surgery or hemorrhage or remaining infective material, then I will not put the EVD. If the surgery complicated, for example, like lavage, there will be a remaining, debris or hemorrhage. There's a chance of the stoma may be blocked, then I put temporary EVD. So in my previous initial experience, I put Omaya, but I found that the Omaya can be a very, most of the surgery you can predict the success is high. Then you put the Omaya, it become a foreign body when it is not necessary. So EVD also selected, and at the same time, you can use the EVD to challenge. For example, one of the case that the pineal region tumor, we found that the stoma is still blocked by the falling tumor, and the ventricle floor are contaminated with the blood clot, infective material. So we put EVD despite we do a good lavage, but true enough, the stoma is not functioning well because of the tumor. So then with the EVD, we can make sure that the patient is okay. Then we convert straight to the shunt. So that's, hope I answer the question, why I put EVD and why I choose linear and flat.
Thanks, Azmi, and all the speakers for this session. I think we are a little behind time, so we start the live session.
Thank you.
Sachin, you can.
Our next speaker, first speaker for the live session is Professor Sarat Chandra, and he's going to talk about endoscopic hysterectomy. So I request Professor to please share your screen and start to talk about that.
So is my screen visible and am I audible?
Yeah.
Yes.
And how much time do I have?
This is our last session, Professor, and we've got total 4 speakers in our live session. So I think Professor Devpujari can decide on that about the time.
I think about 20 to 25 minutes, Sharat, and then I think there is time for discussion at the end.
Perfect, sir. So 25 minutes means it's 5:40.
Yeah.
So by 6:05, I think I should finish, isn't it?
Sure. Yeah.
So I will stick to my time. I'm just making it clear. So good morning, good afternoon, good evening from whichever part of the world you're listening to this. And at the outset, I would like to thank the World Federation of Neurosurgeons, as well as the Asian Congress of Neurosurgeons and the International Society for Minimally Invasive Neurosurgery for organizing this wonderful webinar. And I would be speaking about my journey of how we created a minimally invasive strategy for a maximally invasive procedure like hemispherotomy for drug-resistant epilepsy. So unfortunately, we are in the middle of a tragic war, and we have to remember there are no winners in a war. We have to fight for peace instead. And let us hope that we are able to go back to normal as soon as possible without any more complications. And as surgeons, we only too well understand how complications can build up very rapidly, even before we can understand or even before we can realize it. Now, if you look at the randomized controlled trials for epilepsy, there are 2 trials which are very commonly quoted, one by WEB et al., which was published in NEGM in the year 2000, and then the URSA trial by Pete Engel, again in JAMA. And they have conclusively shown that surgery is definitely much more effective than medical treatment in drug-resistant epilepsy. And we were very fortunate enough to publish this first ever RCT for surgery for drug-resistant epilepsy in children, which has now more than 300 citations in just a period of 2 years, which has clearly demonstrated that doing surgery is not only tenfold more benefit than giving medical therapy in children with drug-resistant epilepsy, but it has also demonstrated that the more you delay for children, the more severely cognitively hit they are, and more intellectually they develop deficits, and more severe becomes the epileptic encephalopathy. So for children, it is very, very important, particularly when they come with very huge substrates like a hemispheric substrates, for which hemispherotomy is required. They have to be done as early as possible. Of course, we have to do it, but again, it has to be done as early as possible. And understanding that hemispherotomy is not a small procedure. It involves either removing whole of half of the brain or disconnecting. It is associated with a significant blood loss, hypothermia, and morbidity, as has been shown in the past. And if you look at the history, the hemispherectomy, which is a physical removal of hemisphere, was given up because most of these patients developed hemosiderosis, which was 100% fatal. And then, of course, in the history, people tried to develop various other procedures like creating a large extradural space or plugging the foramen Monro or doing hemidecortication. But again, these did not seem to reduce the morbidity much. Surgery still involved a large craniotomy, significant blood loss, hypothermia, long hours of surgery. And this is one of the earlier peri-insular hemispherotomy, which I had done more than 15 years ago. So you can see, even though we have preserved most of the cortex, but still it required a large flap. Now that is what actually set me thinking to develop the strategies for minimally invasive procedures for epilepsy. And these are the procedures which we as a team developed from our institute. And over here, I would like to speak more about endoscopic hemispherotomy. Now, this was the first patient who came to us in the April 2002. And this child came in altered sensorium. You can see one of the incisors are missing. He was having 200 to 300 seizures a day. Till that time, we never performed a hemispherotomy. So we had to go in almost in emergency and then do the surgery. I just read from the textbook and we performed the procedure. It was quite a difficult thing because nobody else in India was doing this procedure at that time. And we were so happy to see that this child was fully grown adult without any seizures coming to us in the year 2015. He did have some weakness of the hand, but otherwise he was having a job and he was also thinking of getting married. And soon afterwards, we published the first series of hemispherotomy from India. And that's the time when I started thinking that could we actually create a minimally invasive strategy for such a maximally invasive procedure? And I came across this interesting article by Bahulian and came to realize that, yes, there were people who were thinking of creating this as a minimally invasive surgery. And even though this was a cadaveric study, but it could not be converted into clinical practice. And it's very obvious because when you look at the procedure, making a burr hole and then trying to disconnect through that is almost a clinical impossibility. But definitely the endoscopic hemispherotomy remains a step in evolution in management of this difficult pathology. And when we started thinking about it, it was as difficult as trying to pass camel through the eye of the needle. But when we thought about it, gradually we developed this procedure. So the first thing what we did was I shifted over to an interhemispheric hemispherotomy. So rather than doing a transcortical hemispherotomy, we started doing hemispherotomies through the interhemispheric fissure. And then we started using the endoscope along with microscope, which gave us a good feeling of comfortableness. And then I tried with this minimally invasive sheath, but it never worked out, so I gave it up. So you can see I will not proceed. And then we realized that if you can reduce the size of the opening in the midline and pass a more anterior trajectory, we will be able to do an endoscopic disconnection. And that's where we worked on a few cadavers, not the formalin frozen ones, but on the fresh frozen cadavers. And we found that it was indeed feasible. And that's when we started doing some cases in an atrophy cases. So this is how we give the incision. It's a small 3 into 4 centimeters placed much more anteriorly. Why anteriorly? Because when we place it anteriorly, we create a much more smaller footprint, or because the footprint becomes much more smaller for the target. And it will also avoid the bridging veins. And endoscope will enhance the visualization. And this is where we published the first 6 cases of a preliminary technique in neurosurgery. And then, of course, we published it in epilepsy, where after doing a series of cases, it became accepted as one of the 4 cardinal techniques for doing hemispherotomy. And currently it is accepted world over as one of the techniques for doing hemispherotomy. And this again was published in JNS. So trying to explain to you, when we approach it anteriorly, the entire footprint of the target becomes much more smaller than approaching it from a vertical direction as described by Professor Delalande, and hence we are able to reduce the size of the target footprint. In a later publication, we described the hybrid technique. By hybrid, I don't mean it's a combination of endoscope with microscope, but using a 10 millimeter scope, which goes not up to the target, but stays away from the target so that we can provide a very nice bird's eye view. What is the reason? The reason is when we operate a pituitary, the size of the target is about 4 centimeters. So if there's a 10 times amplification, so that is how we can manage with a 4 millimeter scope. But when we are talking about reason, in order to have a complete view, we need at least scope of 10 millimeters. Switch over to a 10 millimeter scope. Now this scope does not go right up to the target like we do for pituitary. It stays away. It stays away at a certain distance so that we are able to provide a very nice bird's eye view. And then we connected it to this robotic system so that we were able to provide very nice and comfortable ergonomics for the surgeon so that he would be able to do the surgery for long hours. And then, of course, we chose this long bipolars as well as bayoneted suctions with which we were able to work. And having a robotic is definitely an advantage because it provides 6 axes of motion. It's isocentric, free motion, slow and fast, medium options are available.
Somehow network is not good at home. Every 2 minutes is going down.
Is my network okay now?
Huh?
Is my network okay?
Very well, Professor.
Yes, Sharath, we can see and listen to you.
Okay, because somebody was saying that the network is not good.
No, I think there's some background noise, but it's working okay.
Okay. So in 2002, when we started doing both the vertical as well as the peri-insular technique, and then in 2008 till 12, we started the interhemispheric approach, gave us plenty of learning curve to use endoscope. And then finally, we started doing the endoscopic technique about a decade back in 2012. We made the first presentation of endoscopic hemispherotomy in the first epilepsy surgery techniques meeting of the International League Against Epilepsy at Gothenburg in the year 2014. It was very well received and accepted and appreciated. And then till 2020, we published a bunch of papers. And then it came onto the textbooks or its chapters also. We initially, of course, started with an atrophic. So you can see this is the pre-op and this is the post-op. That's the best way to start off with this. And then we proceeded of using this technique for non-atrophic. So this was a patient which I operated in Malaysia. And you can see it's one of the most complex pathologies where the patient has hemimegalencephaly with aplasia of the frontal horn. And we did an endoscopic disconnection, just losing about 40 cc of blood. And that's a patient who was seizure-free. He was having about almost 100 seizures a day. That was really very, very satisfying, even though it was a very, very apprehensive approach. And this is the email we got from Dr. Vairavan saying that the patient is doing excellently well. And then, of course, it came into the textbooks. So this book is forwarded by Professor Ghazi Asargil, and this again written by my dear friend Arthur Cukert, establishing its role as one of the key procedures for hemispherotomy. And then it has been taken up by several other centers. Sandy Lamb from Texas has been doing it very, very aggressively. And of course, various other people from Indonesia as well as from Malaysia. Now, we also demonstrated the role of the temporal stem, where we showed that the temporal stem lies anterior to the hippocampal head, and that needs to be resected, and that could be left behind. And by addressing the temporal stem, we were able to enhance the outcomes from 80 to 90% by doing a repeat surgery. And we published this again in JNS Pediatrics. And this shows how the temporal stem could be left behind. The reason temporal stem may be left behind is not because it's a technical fault or it's a fault of the surgeon, but because of the fact, now this was a patient who had a residual temporal stem having residual seizures awaiting surgery. And this is another patient where there is a residual temporal stem, but he's seizure-free, most probably because this is gliotic. But if at all he requires surgery, the second surgery is going to be very straightforward, where you can just put endoscope here and then disconnect it. So doing a second surgery for temporal stem disconnection is very, very straightforward. And the reason it gets left behind is because one has to go along the curve. So unless you are an expert like Robert Carlos who can curve a ball, it is possible that you could leave the temporal stem, especially in very complex pathologies like hemimegalencephaly. And it should not be considered as a failure of surgery. It should be explained to the patient that there may be a need for us to stage the surgery if the patient continues to have some seizures or there is a residual connection, which is quite well acceptable because we all know that pathologies like hemimegalencephalus are extremely complex. Now, this was a patient who underwent a peri-insular technique. So you can see that in peri-insular technique, as I have shown in the earlier slide, the deepest area is a cingulate gyrus, whereas in the vertical technique, the deepest area is a temporal stem. So over here, you can see this was a hemimegalencephaly. This was operated during Kinde's oration by a very dear colleague of mine. Dr. Dio Pujari knows about it. So the patient came to me, and you can see the cingulate gyrus is left intact. And then we went endoscopically and then disconnected it. And the procedure just took half an hour. The patient is from Nepal, and patient was seizure-free and very happy following the surgery. So it's very important to understand the technical nuances of whichever approach we do. Again, another patient of hemimegalencephaly with facial hypertrophy showing endoscopic disconnection. And the MRI again shows the plane of disconnection, which has been done endoscopically. So this is a procedure, which requires only 3 centimeters incision. And this was an image which came out in neurosurgery, not because I wanted to show the size of the incision, but because it showed the words made in India. So it's, that gives a sense of pride that it has been made in India and now being practiced world over. And in my plenary address in AANS, we concluded with my series showing that endoscopic hemispherotomy is safe, effective, minimally invasive. And by addressing the temporal stem, we can enhance the outcomes from 80 to 90%. And the repeat surgery definitely is simpler. I'm sorry, I think I have to go back. So then we developed another new technique called endoscopic corpus callosotomy. And then there were more papers which led to reliability. And then, of course, I have spoken about the residual temporal stem. And this again shows a non-atrophic hemispherotomy and hemispheric cortical dysplasia, where we can see this beautiful disconnection done endoscopically. And this is the pre-op. And this is the patient which we operated in Malaysia. So I'm sorry, I think the slides for some reason are repeating again. Let me go forward. It's my fault. So basically, this technique has got first a corpus callosotomy, followed by an anterior disconnection, which goes up to the sphenoid ridge. And then we have the middle disconnection, which passes through the body of the lateral ventricle right up to the temporal horn, which is shown by the yellow dotted line. And then finally, step 3, we have this posterior disconnection. And I do have a video, and I can show it to you in that video. So this is an endoscopy in case of an atrophic case. And I will first show an atrophic and then followed by a non-atrophic case so that you're able to appreciate the entire anatomy. So all this is under endoscope because it's highly magnified. You're not seeing the circular ring around it. So the endoscope is held by the robotic device. We go in the interhemispheric fissure. And now we are opening the sylvan, we are opening the cisterns in the interhemispheric fissure. That's a corpus callosum. This is the A2. So the first step we do is division of the corpus callosotum. And we go right from the genu till the splenium. And then again, we go back to the genu. And when we go back, we can see the AC is looping around the genu. And now once the corpus callosotomy is done, we start with the anterior disconnection, which passes from the midline till the lateral portion of the caudate head over here. So this is the caudate head. So from here, it goes right up to the skull base so that it touches the bone of the anterior cranial fossa. And now you can see the olfactory tract in the subarachnoid plane. Now the middle disconnection passes in a parasagittal direction at the end of anterior disconnection, and it goes straight down in order to connect the temporal horn. Now, temporal horn is present right from the sphenoid ridge onwards. So we are now going lateral to the thalamus as well as the choroid fissure. And now we have entered the temporal horn. Now in the temporal horn, we need to suck out the amygdala and the anterior portion of the hippocampus because that is connected medially through the ventral amygdala. And then finally, we do the posterior disconnection, which is a line joining the splenium to the choroid plexus. This is a video to show just the posterior disconnection. So this is a choroid plexus, this is splenium, and this is on the right side. So we just use the bipolar in order to suck out the temporal efferent. So basically in posterior disconnection, we're disconnecting the temporal efferents, which consists of the tail of the caudate nucleus as well as the fornix. And we have to lift the choroid plexus in order to disconnect the portion also under the choroid plexus. Now this is a case of a non-atrophic, not this one. I will show you one more video. Yeah, this one. So is the audio audible, Dr. Devpujari?
No.
The audio is not audible?
No.
Okay. So this patient had a right hemiparesis. So 2 years, she also started having epilepsia partialis continua. Examination showed right-sided hemiparesis with loss of pincer's grasp. Video EEG showed a left paratocentral and left temporal localization. She received methylprednisolone with some transient benefit, and we considered the diagnosis of Rasmussen encephalopathy. And you can see she was on multiple anti-epileptic drugs without any response. Neuropsychologically, she had severe global impairment of all the memories, particularly the verbal and the visual memory. So MRI showed widened sulci on the left side, predominantly involving the perisylvian regions. There is a left lateral ventricular enlargement with hyperintensity in the left extreme capsule on flare sequences. Similar findings was noted on the T1 weighted images. And these changes were progressive, suggestive of Rasmussen encephalopathy. So Syscos showed an activity on the left side, and PET can show a large area, shows a large area of hypometabolism on the left frontal and temporal area. Functional MRI showed good representation of the left hand in the right side, and hence there was a transfer of the function to the opposite side. Speech, language, and memory were bilaterally. So that gave us a confidence that we could go from the left side. So we did a left-sided endoscopic approach. So as you can see, the endoscopic provides an inverse funnel-shaped expanded view. Under general anesthesia, the patient's head is fixed on the Mayfield clamp with slight neck flexion by about 15 to 20 degrees. We provide a 5 centimeters transverse incision, 1 centimeter anterior to the corneal suture. And the incision, as you can see, that it's about 3 into 4 centimeters flat. It is flash with the base towards the midline. Now the endoscope is brought in. This is the most challenging area where we retract the hemisphere, and the endoscope is brought in. And as the first step, we do the corpus callosotomy. So we use fine dissection, sharp dissection in order to expose the corpus callosum. So the corpus callosum can be recognized by its pearly white color, and sometimes it could be challenging to release the cingulate adhesions. So careful dissection releases the cingulate adhesions. In this case, the cingulate adhesions were significant. So now you can see the callosomarginal arteries and the pericallosal arteries. They should be very, very carefully handled and meticulously dissected along the whole length of the genu from anterior to the posterior. Now, using a ball dissector, what one could either go through it or retract both the vessels to one side and then divide the corpus callosum through the abnormal area. I prefer to retract both the vessels to one side and then go through the pathological side. So the difference here is when we do the corpus callosum, we should go through the through the abnormal ventricle. So we should not open in the midline. Now the exposure is continued from the body till the genu, where both the A2s and ACs dip inferiorly. Now at this stage, we can keep a spongistin or gel foam, which can provide atraumatic retraction of both the hemispheres. And now we proceed more posteriorly in order to expose the splenium. Now we start opening the corpus callosum. It should open onto the ipsilateral pathological ventricle. Now, once the corpus callosotomy is over, we start the anterior disconnection. And it's important to start this procedure anterior to the ventricle. It should be extraventricular, because if you go through the ventricle, we can affect the anterior perforated substance and the diencephalon. So as it can be seen, the anterior disconnection is in a coronal plane, goes right up to the anterior cranial fossa. And once the anterior disconnection is complete, we start the middle disconnection, which passes in a parasagittal direction. It's absolutely the same thing what I've shown for the atrophic. Care should be taken to preserve the olfactory tract. So again, we open up the temporal horn, and after that, we have to resect the amygdala and the head of the hippocampus. Now the middle disconnection is carried out posteriorly, lateral to the thalamus, following the temporal choroid plexus, connecting the temporal horn to the atrium. And then finally, this is the foramen of Monro. This is the choroid plexus. This is where we do the posterior disconnection, disconnecting the temporal efferents, which consists of the tail of the caudate nucleus and the fornix. So this is the location of foramen of Monro. This is the thalamus. And this is the location of choroid fissure. So now we go ahead to do the posterior disconnection, which is a very short disconnection, which is basically a splenial disconnection. So the splenium has to be disconnected till we expose the arachnoid completely. So you can see that the arachnoid is exposed over the posterior cistern, quadrigeminal cisterns. And then finally, we also do the fornicial disconnection. So here, I will skip the other examples and finally come to our results. So we have done endoscopic hemispherotomy in more than 50 cases right now. The outcomes in terms of cognitive has been equivalent to that of open, but it has been very good in terms of reducing blood loss as well as a hospital stay. We have had one mortality both in endoscopic as well as in open. The mortality in endoscopic was following discharge. The patient after 9 months died because of pneumonia. These are the complications. Most important complication in a series was fever, which is a central type of fever. But however, you can see that there was a significant less reduction of blood loss as well as the post-operative stay. Now with this, I will end my presentation showing you the latest state of the art, which is a bloodless hemispherotomy, which we call as ROCH, where we have used thermocoagulation in order to produce robotic guided thermocoagulation in order to produce hemispheric disconnection. And this has been now published in Journal of Neurosurgery and is now the surgery for the future. So concluding, the seizure cognitive outcomes for both endoscopic and open techniques have been similar in terms of 80%. We were able to enhance the neuropsychological scores were also similar both for endoscopic and open. The operative visualization is excellent with endoscopic. Post-operative blood loss is less. Post-operative stay is also much less in endoscopic procedure. In a subjective questionnaire, most of the patients were happier with the small size of endoscopic hemispherotomy. By addressing the temporal stem, we were able to enhance our outcomes to 90%. And it is important to understand that not all connections, residual connections, develop seizures. So it is not important. It's important not to jump to conclusions only on basis of MRI. And in complex cases like hemimegalencephaly, one can also consider doing a staged procedure. Now, for functional reorganization is best for age less than 7 years, and that is where we should consider for pediatric hemispherotomies, especially for hemimeg or Rasmussen's. Whereas the post, in fact, can be also done in adult patients. So we've been demonstrating this procedure all around the world. And I thank my epilepsy surgery team as well as our research team and the MEG team. And finally, before I conclude, I invite all of you to this upcoming conference of International Society for Minimally Invasive Surgery to be held in New Delhi from 27th and 28th of August, which we are planning as a physical conference. And I hope we'll be able to meet all of you in this conference. Thank you very much.
Dr. Azmi chairing this session, so I'd request him to call the next speaker because we'll have discussion at the end.
Okay, thank you very much, Professor Jupujari. Very nice presentation by Prof. Sarah Chandra. I think we discuss at the end of the session. Is it okay?
Absolutely.
Okay. Now the next presenter will be Professor Ulrich Tomale from Germany. So he's going to talk about post-hemorrhagic hydrocephalus.
Yes, thank you very much. Thank you very much to Chairman and Dr. Diopujari, as well as the World Federation of Neurological Surgeons and the Asian Congress of Neurological Surgeons for this kind invitation to the wonderful conference. It's my honor to present our experience on post-hemorrhagic hydrocephalus, specifically in neonates, which I will talk about now in my present talk. As we all know, the intraventricular hemorrhage is the cause of hydrocephalus in neonates. And this is basically a germinal matrix hemorrhage due to prematurity or prematurity of this germinal matrix vasculature, which is periventricular. It can happen in grade 1 to grade 4, which is basically the more exaggeration of the bleeding, as you can see here in the schematic drawing. Grade 4 is a lot of blood in the ventricles as well as blood in the parenchyma, while it is restricted to the ventricles in a higher grade of grade 3 and lower grade of grade 2 and 1. It seems to be obvious that actually there's a primary damage to the bleeding itself, because that will cause already, specifically if the parenchyma is involved. But more importantly, the problem is that the blood needs to be resolved. And as far as CSF circulation disturbances will arise, we need to treat hydrocephalus in a very fragile cohort of patients, which can cause complications. As well as the hydrocephalus, which does further parenchymal damage due to the elevation of the ventricles. So this causes neurological delay over time, as well as that we have some more comorbidities. And if we look in our statistics, we see, like it was published here by the London group, that actually post-hemorrhagic hydrocephalus is doing worst in terms of revision-free survival if the patient receives a shunt. And you have patients who received the shunt also from grade 1 in a less extent, but in a higher extent in grade 4 hemorrhages. And you can also see in the neurological outcome, which is here, scoring system, it was significantly worse compared to all other hydrocephalus types. And it was also in specific functionalities like spasticity, epilepsy, speech delay, and schooling abilities, significantly worse than all other hydrocephalus types. of the same age. Endocrine dysfunction have been described as well as the mortality is higher than in all other hydrocephalus types. So we are actually talking about a very devastating disease. And this is due to the factors I already showed you, but it's also due to the fact that we have the hemorrhage in the ventricle, and the process of resolving the degradation products of blood from the ventricle causes molecular changes like inflammation, as well as oxidative stress, glutamate excess toxicity, and those will contribute by themselves to neurological damage or brain injury by itself. So it seems to make a lot of sense to maybe get the blood out in order to stop all these processes on a molecular basis. Here are an overview about the comorbidities which can cause enterocolitis, pulmonary complications, or hematologic complications, or sepsis, and these will also contribute to morbidity. The overall IVH rate has a mortality of 13%, and those who have a post-hemorrhagic hydrocephalus will account for 11%. Here in this study, the hydrocephalus rate of all bleedings in the ventricles in neonates accounted for 7.6% hydrocephalus rate from a meta-analysis from Christian et al. In 2016. What kind of therapeutic measurements we have? In the literature, we have described medical issues, and lumbar punctures, which should normally only be done if there's a communication of CSF spaces between intraventricular and extraventricularly, because then it makes only sense to actually release the CSF from the extraventricular space. The transfontanelle puncture is obsolete, at least in Germany. Only in emergency situation it could be done, because it has been described in the literature to cause a higher rate of infection. So it's maybe more relevant to look at other measures, and the one which are recommended are either reservoirs alone, which can then be punctured, subgaleal shunts, which can increase by a pocket the resorption capacity of CSF outside the calvarium, or external drain, which brings out the blood polluted CSF. If we look at an overview of those different measures, which were published by the British group from Liverpool, you can see actually that EBDs have the problem of higher infectious uncontrollability, as well as it cannot be handled outside the neurosurgical centers. And here it's more recommended to do ventricular access devices, so reservoirs alone, which however does not provide continuous irrigation, drainage, or subgaleal shunts, which at least have a little purpose of this if the pocket is able to resorb some of the CSF. This is the treatment algorithm which is normally used. So only if there's intraventricular hemorrhage, we as neurosurgeons are normally not do anything. Only if hydrocephalus develops, then we come into play, and then we can choose one of those temporizing therapeutical options. And then further symptomatic hydrocephalus might be observed, and then we need drainage continuously, either externally or by puncturing the reservoirs or subgaleal shunts. And then we wait until the body weight is like 2 kilograms, the protein level is lower than 2 grams per liter, and the normal cell count, and then a ventricular peritoneal shunt must be indicated. If we go through the literature and look again at different shunt rates, we will have numbers which are all over the place. And these account to the fact that we are looking maybe at different kind of situations. So if we look at this point, that hydrocephalus is actually not there, and only the IVH, we have only a 9.3% rate of shunt. If we look at this stage, if hydrocephalus already there, that the ventricles are enlarged, then we have a shunt rate of almost 40%. And if we have done as a neurosurgeon something, then we increase the likelihood of having a shunt of above 80%. So this is something which you can keep in mind if some of the numbers are compared between hydrocephalus rates. What are guidelines? Guidelines are very sparse, because
it is not as well documented in the literature. What should we do? And so this British survey showed that it's actually all over the place. Different centers are doing different techniques, and especially they're sometimes doing different techniques in their own center by different surgeons or in different patients. So there's really a lack of guideline, I have to say. What about prospective randomized trials? There was one which is the trial from Linda de Vries, which investigated reservoir placement in early intervention and later intervention, defined by the enlargement of the ventricles. And then they looked at mortality as well as shunt rate. We have to say that the shunt rate is rather low, but if we look at the levels, how the ventricles are actually enlarged, we see that the IVH was treated, but not necessarily the hydrocephalus. So the time point is also in the later intervention group was actually been chosen at a state where maybe no hydrocephalus would have been developed later on. So they tried to puncture not only the hydrocephalus CSF disturbances, but also to get more blood outside. And mortality rate was very similar between the groups. The other randomized prospective study is the DRIFT study. The DRIFT study implemented 2 external ventricular drainages and started an irrigation and outflow through both of these drainages, and then also used hemolytic agents in order to dissolve the blood. This study needed to be stopped because the secondary IVH rate was significantly higher in the treatment group by DRIFT compared to the standard group. But they included 34 and 36 patients, and those patients were followed for 2 years for neurological outcome. And interestingly, they showed that despite the fact that the rebleeding rate was higher, they were able to reduce the rate of severe morbidity and disability in this patient cohort. So there was actually a significant benefit shown after 2 years. And Andrew Whitelaw did all this work to follow those kids for 10 years, which was published just recently. And even in this group, this neurocognitive disability rate showed a beneficial result for the DRIFT group compared to the control group. So it's very interesting data, because basically what he does is to take out the blood of the ventricle in order to diminish the amount of secondary brain damage. So using endoscopic technique was firstly implemented by Sergio Caballero from Brazil, who published an abstract from the 2007 ISPN meeting. And he showed that we were actually able to reduce the amount of shunts to from a higher rate to 54%, but it's only a small cohort of patients. And we started to implement this technique a little bit differently, but on a standard basis since 2010 in our department. The technique basically is called neuroendoscopic lavage for primary hydrocephalus. It's one intervention compared to DRIFT. We have a controlled environment in the operation room to reduce infection rate, to reduce problems with volume balance. That means that we don't have the ICP increase. Access of supratentorial ventricles is similar like in the DRIFT protocol, and we can do everything under visual control. So at the beginning, we see a foggy CSF, which is then cleared under irrigation, and then the clots are approached, and with the outflow channel, we can gently aspirate the clots on one side of the ventricles. Afterwards, we do a septostomy and go over to the other side. And then we do the same on the contralateral ventricle in order to clean this ventricle up, as well as the third ventricle. If we look in our setup in the operation room, you can see here that we have of course, the screen of the endoscopic tower. Then we have the ultrasound in order to guide our endoscope into the ventricular system. Then we use rigid endoscopes, like either the Minop or the Lotta without the outer sheet. And we start irrigation and passive outflow through the tubing. And the irrigation comes by gravity through an lactate-free warmed ringer solution just by gravity through the tubing. And the second surgeon is acting on a syringe if the blood clots are approached in order to gently aspirate them out of the ventricular system. This is a video which you can see the ultrasound here guiding the endoscope into the ventricular system. And then you can see here the aspiration of blood through the outflow channel. Then you can see the irrigation coming in through the inflow channel. And here by aspiration, some clots are already being taken out. And they will be drained into a small little bag. Again, some aspiration to the blood clots, which you can see here. And everything, of course, will be followed on the screen. So this is basically the technique, and you can hear in the schematic drawing that we can access all parts of the lateral ventricle, and we can also access, of course, the third ventricle. We would not access the prepontine cistern or the fourth ventricle. The amount of solution which is used is 1,000 to 3,000 mils, and the OR time is in mean 70 minutes. That was our initial cohort. Maybe we don't reach the maximum anymore of 108 minutes, which was in our learning curve at the very beginning. We have to keep in mind, if we use the endoscope, we are using actually the optic right here, then the working channel, and the irrigation and outflow channels. So if we see on the screen, then our working channel is always above. And the irrigation and outflow channels are at one or the other side, deciding how we do the setup. And we can actually decide and change during the procedure from one side to the other in order to apply it where the clots are more located and where the choroid plexus is actually not located, not to interfere with the choroid plexus too much. The symptomatic hydrocephalus is the indication for surgery. That means, of course, intraventricular hemorrhage, elevated head circumference at about 2 milliliters per day over 1 week, roughly said. Clinical signs, which are, however, not always as easy to be interpreted due to all other problems those patients might have, but bulging fontanelle is a good parameter. Ventricular dilatation with ultrasound indexes way above the 97th percentile, as you can see here, much more than it was shown in the Linda de Vries group. And then the resistance index is showing Doppler flow of the intracranial vessels, which showing a impaired and diastolic flow. Here's an example where we see intraventricular blood at an early stage. We don't see really an elevation of the ventricle, so we watched and wait. Here you can see the Doppler flow, and we would always look here at this phase, that the diastolic phase is not diminished. If the ventricles are blowing up, then we decided at this point actually to start the intervention and to go in to start the neuroendoscopic lavage. Compared to other techniques which are described in the literature, we see that the EBD, the reservoirs, and the ventricular subgaleal shunts, have similar infection rates in terms of the closed system, interestingly a little bit lower in the EBD. The EBD has a higher arrested hydrocephalus rate, and the operative revision rate is way much higher in the EVD, which is the reason why we don't use it, for example, as much anymore. The neuroendoscopic lavage has a lower infection rate in 2 centers, which we studied here in this cohort, 43% of arrested hydrocephalus rate and 5.4% of mortality rate, and the revision rate was 8.6%. So that was quite beneficial. We could see some differences between late intervention, here late intervention and early intervention. Here you can see the ependema quite clean, which is here plugged with hemosiderine. So that might be the reason why our VP shunt group had a little bit later intervention time compared to the non-VP shunt group. And here in 80 patients, we still have a shunt rate of lower than 60% after neuroendoscopic lavage. These was our early publication from 2014 from 19 patients compared to historical cohort. And you can see reduced Shunt rate was significant, as well as infection rate, as well as multiloculated hydrocephalus rate was significantly lower. The threshold again was to place the ventricular peritoneal shunt at the body weight higher than 2 kilograms and the CSF protein level lower than 2 grams per liter with normal cell count. If there was a higher protein load, we would do a new neuroendoscopic lavage just before placing the shunt in one intervention in order to push down the protein level if they have reached all other criteria accordingly. This was the bigger cohort together, published together with Leipzig. We could also see the factor of gestational age, which was relevant for the shunt rate. Shunt rate again lower than 60%. And here you can see that we were not able to get all blood out, but most of the blood, and significantly was the blood reduced in all our patients. However, the portion of blood which is not as easy to get is the one which is stick to the choroid plexus, which is sometimes stick to the parenchyma, or which is hidden all the way down in the temporal horn. So if we compare it again to the study from Kari, we can see that we don't have a continuous drainage, but we have the active blood removal at the very beginning. All other parameters can be handled as, just like ventricular access devices or ventricular subgaleal shunts. Other groups have published data on the same technique. So the Turkish group basically showed the same than ours, reduced infection rate, shunt rate at 60%, and reduced multiloculated hydrocephalus rate. The Spanish group had a learning curve where they did more intervention at the beginning, and they showed that the application of up to 3 lavage in patients increased the infection rate, which seems to be logic. But they also showed that their complication rate, being either infection, CSF leak, or rebleeding, significantly reduced over the learning curve time, and it was very small in the 4th quarter of the study. And also in the 1st quarter, the shunt rate was higher. In all 3 quarters here at the end, the shunt rate was about 60%. The Rome group showed a higher shunt rate of 87%. However, they also had a reduced infection rate and reduced multiloculated hydrocephalus rate. And this was another study from last year published, and they showed 65% shunt rate and an improved neurological outcome after 2 years, looking at the walking ability as well as school attendance. The shunt revision rate, if the shunt was necessary, had a curve in our cohort which was similar to all other patients, so much different to the Great Ormond Street publication which I showed you earlier. So we also have a beneficial effect that the shunts get less complicated because, of course, we have less protein and debris in the ventricles. Our outcome was similar in terms of Bailey's compared to the drift group. And it was a little bit better in terms of gait ability. So our good patient cohort was 78% compared to the drift, which was 61%. But of course, there are 2 different studies, and it's hard to compare them. But this is the idea. Logic regression for a bad outcome was the factors anti-epileptic drugs, comorbidities, as well as atrophy of the structures in the posterior fossa in our cohort. Here you can see some images after at least 1 to 2 years after this intervention. It's very diverse according to the increase of blood, but you also see some normal. We did some volume measurements on those brains, and then compared those volume measurements with the outcome, and they nicely, especially the brain volumes, not the ventricular volumes, but the brain volume were significantly correlating, as well as with the spasticity rate and the neurological Bailey score outcome. The technique was implemented in the newest guidelines for the treatment of pediatric hydrocephalus as a level 3, unclear clinical certainty level, but however is feasible and a safe option to treat post-hemorrhagic hydrocephalus. This was a publication from our last year. We've done a lot of IVH patients now, done a lot of neuroendoscopic lavages, some re-lavages. Most of the re-lavages were done together with shunt implementation afterwards. This is our recommendation. If you want to start this technique, it's maybe better to start with intraventricular infection because it's not, the patients are often older. CSF protein overload, if you want to put a shunt, is also a good thing because you don't have the blood interfering and you still see a lot. And then you can go over with intraventricular hemorrhage in the small babies if you get comfortable with the other indications in which neuroendoscopic lavage is also of benefit. Here we implemented a trophy study because we think that more data is necessary in order to confirm the beneficial effect of such a technique. We have a large amount of centers all over the world who are contributing to this registry, how they treat post-hemorrhagic hydrocephalus in neonates, and the different technique of neuroendoscopic lavage, external ventricular drainages, and ventricular access devices and subgaleal shunts can be implemented, and the patients will be followed for morbidity, complications, and shunt rate, as well as neurological outcome after 5 years. What about other techniques like ETV? Just briefly, ETV have been investigated here in a meta-analysis, and it was shown that actually in small children, age plays a very important role in terms of success, what we all know. So small children do not benefit or have a high failure rate of ETV, and IVH was only a small proportion of this big meta-analysis. Here is only post-hemorrhagic hydrocephalus data taken from the US nationwide inpatient samples, and they showed that the ETV had higher mortality rate and post-hemorrhagic hydrocephalus treatment failures were higher in ETV compared to shunts. Interestingly, over time, people try to do more ETVs while the shunt rate stays to be constant. Here you can see the failure rate of ETV in blue compared to the IBH grade, and here the mortality rate, which is higher in ETV, no matter if it's 2, 3, or 4 grade of IBH. And here the combination of doing choroid plexus coagulation with with ETV in those patients as comparison to neuroendoscopic lavage, and they showed nicely that IVH patients post-hemorrhagic hydrocephalus doing the worst with this technique. So maybe it's not the right thing. Of course, all those techniques have been done at an older age compared to neuroendoscopic lavage, where we intervene much earlier. So in summary, IVH and hydrocephalus leads to significant most exaggerated developmental impairment compared to other hydrocephalus types. Shunt revision rates under regular circumstances are high. Neuroendoscopic is a beneficial technique, especially lavage, in the treatment of post-hemorrhagic hydrocephalus. And lavage is specifically feasible and does effectively decrease intraventricular blood products. It may reduce shunt rates according to the current state of data, as well as shunt revision rates, and might enhance neurodevelopmental potentials. ETV and ETV CPC are additional techniques which may reduce shunt rate at least, but it's not really clear how they will affect neurological outcome as well as complications. Consequent therapy, however, is necessary in any way in order to enhance the long-term outcomes of these very fragile and very devastated patients with a bad outcome. So I think it's very worthwhile to be consequent from the very beginning. Thank you very much. Further investigations, of course, are necessary to define better treatment protocols. And that's it. I would like to thank you for your attendance and again for the kind invitation.
Thank you very much, Prof. Ulrich Tomale, for very comprehensive presentation. We have slight changes. The next speaker will be Professor Bentakaramana, followed by Professor Henry Schroeder. And we also will have additional speaker, Professor Subodh Raja. So we will have 5 speakers for this session. So in view of time, I request that all speakers to stay and we will discuss at the end of the session. And at the same time, I request if you have any question, especially from the participant, to post in the chat box so that we can queue the question accordingly. So thank you very much, Tomale, for the nice presentation. So the next speaker, I request if Professor Bentakaramana, are you ready?
Yeah, I am ready.
Okay, thank you very much.
I just share my screen. Yeah.
So Professor Bentakaramana from India, his topic will be on endoscopic for arachnoid cysts.
Yeah. Can you see my screen, please?
Not yet.
No, not now.
Not yet.
Can you see my screen?
Not yet. We only see your camera.
Okay. But I can see my. I've shared the screen.
Professor, may I suggest your PowerPoint, is it in the pen drive or is it saved on your computer?
This is saved on the desktop, yeah.
Oh, okay.
Normally it opens. I don't know.
Do you have two monitors?
Go and share screen.
Yeah.
And if you have minimized your talk, then just
Yeah.
press on it.
I've done that. Now?
No.
Okay.
Can you see now? No.
No.
Okay, Liu, can you help me? Can you make Professor as one of the co-hosts? So once he has an authority, maybe his, it may improve the sharing.
He's the co-host now. He's already co-host.
He's already co-host, but still he's not able to do. Is there anybody from the support team? Can you help us? Rohit or Prashant?
I will try and rejoin again. Let me see.
Yeah.
Yeah, okay. Screen. Yes. Showing some other.
We can't see your desktop.
Yeah. I can't see my desktop. I don't know what's the problem.
So, Dr. Azmi, so maybe we can have some Q&A during this time.
Yeah.
Yeah.
Maybe. Yeah. Is it okay, Professor?
Yeah,
Has
please go
Dr.
ahead.
Shogar joined?
Please go ahead. Please go ahead.
Okay. I have a question. First, maybe we invite Professor Urish Tomale because he just presented his paper. So I think very well described. You cover the recent development, especially on research, intraventricular hemorrhage. But for the beginners, especially the young neurosurgeon, so do you find that to do endoscopic lavage in intraventricular hemorrhage, is there any appropriate timing? Because the intraventricular hemorrhage, usually they start to organize and the form, the clot will organize. It's very difficult to just do lavage. And sometimes you have to break the pseudo capsule in order for you to clear the clot. What is your indication and any perioperative guideline? Is it the size of the ventricle or the timing after the hemorrhage? The number two, what of endoscope that you use? You need a very big channel endoscope or any rigid endoscope with a small working channel is enough? And number three, do you use fibrotic agent to liquefy the organized clot?
So, okay, for the first question, that's a very important question because it's very important to know that actually the blood clots in the neonate are very soft. So that's very different. I've done some endoscopic approaches in older children, and I saw that the blood clots are very firm and that you would need ultrasonic aspiration in those. That's not the case in neonates. Neonates have, for whatever reason, very soft clots, and you can gently aspirate them by just applying aspiration through the endoscope. So our indication does not really look at the size of the bleeding. If the bleeding is actually bigger, it makes more sense to do the neuroendoscopic lavage. And neuroendoscopic lavage alone as a name does not describe the whole technique. It should be actually named neuroendoscopic lavage plus aspiration of clot, because that's what we are actually doing. And then access the side of the ventricles where it's more clot, because this is better to overview. And we, as I said, the dynamic of hydrocephalus will give the indication for surgery. So that if the hydrocephalus continues to let the head grow and the ventricles are large enough, then we are going in. And then we start with neuroendoscopic lavage. We use the endoscope, which has channels all the way, separate channels all the way to the end of the endoscope, to the tip of the endoscopes. And this is true for the LOTA and for the MINOP. If we use the LOTA, don't use the outer sheet because it makes the endoscope larger. We don't need the outer sheet in this intervention. So you can directly go with the endoscope inside the ventricle. That's what we do with the MINOP. We did more intervention with the MINOP. And then the size of the endoscope is the same. It's about a little bit more than 5 millimeters, so 5.5, I think, something like this. And it seems to be a big diameter compared to what you see in the small babies. But actually, if you compare to the damage which you apply with the endoscope to the damage which is done by the blood, I think it's much less. And the last question was the agents to resolve the blood. No, we don't use any agents. We don't use what you said, hemolytics, and we also don't use antibiotics, which is also a common question, because we just rely on the fact that water does it all, water and aspiration. And this is least complicated for the bleeding, for possible rebleeding rates. And we had very positive experience with this. We don't need any further medication in combination.
Okay, thank you very much. If Professor Ventakaramana, are you ready?
No, not yet. My desktop is somehow not showing. Can you see the screen now?
Not yet.
Ask me?
Yes, please.
Can I make a comment?
Yes, please.
I want to make the comment that the major problem in endoscopy in children is the education situation. We have not enough educated, experienced endoscopists, even in Germany, and not so also in Austria. So we need to have a much bigger education effort to educate the youngers in neuroendoscopy. Pathophysiological, it makes sense to do it very early. If you look to the effects, the different toxic substances start to work. They start after 4 hours, and they have the top after only 2 or 3 days. Then they are on the top of the toxic effect. So that means we have to start very early to avoid the toxic effect, and we have to train the youngers very early.
Maybe I can just shortly comment on the training, because I think it's also a very important point which you raise, and I totally agree. In our German section of neuroendoscopy, we were actually addressing this problem, and we were making a survey how many big centers of neurosurgery have trained endoscopists, and it's much too little, I can say. Much too little. We are offering courses. It's not as easy to offer the courses as we want them to be, because we need the support of the companies. And in Europe, it became more difficult since the new MDR development. But we are working on this as well. But it's a lot of work which has to be put into this. And I totally agree. We need more endoscopists, yes.
Just a last comment. if I want to get the indication for a neuroendoscopy in Germany, I need from 1 week to 1 year to get the indication. If I need the indication in Mexico, I need only 1 hour. Then I have the indication and the possibility to do it. Because endoscopy is cheap, much cheaper as many other techniques.
That is correct. I am really surprised that in spite of offering so many courses all over, why it should still be so. But at least the numbers are picking up. People taking endoscopy courses is very, very high in India and several other countries. Can we ask a question to Dr. Sharat Chandra if we have any, because he wants to leave?
Yes. Okay, I have one question for him. Excellent lecture as always. I really admire your technique, especially the endoscopic hemispherotomy. We used to approach from laterally, functional hemispherotomy, peri-insular, but you come from top. How do you address the mesial component? It's a little bit difficult and challenging for especially the beginners, but corpus callosotomy and disconnection from top is excellent. But what about the lateral disconnection to address the temporal and the mesial component? So do you have any clue or any advice?
Yes, so that's an excellent question, Dr. Azmi. I'm so happy you asked it. So now if you look, the first paper on minimally invasive hemispherotomy, which was published, was a cadaveric article. And when I spoke with Bahulian, I said, why did you not consider an interhemispheric approach? He said, Sharat, when we started devising it, we were working on formalin cadavers. And it was so stiff that we thought we will never be able to do it interhemispheric. Now that is the difference between a cadaver and a live surgery. When you do live surgery, you're going interhemispheric. Initially, it looks very, 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 very challenging. It looks very overwhelming because you open through a very small incision, you open the interhemispheric fissure. But once you go in carefully and you kind of start releasing the CSF, start exposing, cut the corpus callosum, let the CSF out, the whole hemisphere falls like a book. And once it falls like a book, you do the corpus callosotomy, you go inside, and then you have the access to the mesial temporal structures when you do the middle disconnection. Now, in most of the cases, it's quite straightforward to do it, especially in the atrophic cases. So my advice is when you start endoscopic hemispherotomy, start atrophic, start with large openings so that you get oriented to the entire anatomy. And once you have done 10, 15 cases, that is when you should attempt to do it in a non-atrophic case like a hemimegalencephaly. Now saying this, in one of the slides, if you remember, the mesial temporal component happens to be the deepest component of this procedure. Just like the cingulate gyrus, which happens to be the deepest component of the periventricular area of the peri-insular technique. So yes, that is a challenge, and one has to go along the curve. So saying this, in very complex cases like hemimegalencephaly, the patient has to be counseled that there may be a need for us to go a second time if the temporal disconnection could not be completed in the first instance itself. So yes, it could be a challenge, especially in the non-atrophic cases, but in such cases, it should be dealt more like a staging of surgery rather than, failed surgery. But in atrophic cases, most of the cases, it's quite straightforward to deal with temporal because there's a lot of cortical atrophy. So my advice to people is start with atrophic, start with larger craniotomies. Don't feel shy to use both microscope and endoscope. Get used to the anatomy. The more you get used to it, the more addicted you'll feel with it. And right now we do everything using endoscope.
Excellent. I'll just add one more point in my own learning curve, which has helped me is I first started doing corpus callosotomies before I actually started to attempt hemispherotomies. I think midline is not so difficult unless you are dealing with a patient with hemimegalencephaly. So I think that's another thing. You can probably start doing callosotomies first, and then it's a good beginning to learn how to use it and then get into the ventricle later on maybe. So Henry had joined us. Venkat is still facing problems, so we can probably have Henry's talk next.
Yeah, excellent idea. I think in view of time, so we shall proceed to original plan. I would like to invite Professor Henry Schroeder from Germany. He will talk about endoscopic excision of colloid cysts. So Henry.
Yeah, thank you, Asmi, and thank you, Chandra, thank you, Yoko. All organizers I want to thank to invite me to this nice conference. Sorry, I was a little bit late because a tree hit our summer house and I had to go there because the authorities requested that to do. So now I hope this will work and you will see it moving. Last time it was a problem that is it moving or not?
We can see your slide, but not moving yet. Can you put on slideshow?
Yeah, I did. That's the problem I had last time as well. It was not showing this window, which should be there. That is very surprising. One moment. I have to close this and this. And now we start again. It's not showing this slideshow. It's only, maybe here. It's not moving, huh?
Started sharing screen, but not moving.
Yeah, it is surprising. It is not showing it as usual. Usually I have two windows. One is the slideshow and one is the other, and it's not offering it here. So I will close this again, one moment. So now I have to open it and it should be seen by it. No, it's not. Strange. So it's not moving, huh? When I press it now?
Not yet.
No?
No.
Any ideas?
Mr. Schroeder, you can put the slideshow on and then you click your share screen.
Yeah.
Don't share the screen right now. Just make it to a slideshow and then you click the share screen.
Yeah. But then I cannot come to.
Henry, can I suggest you something?
No, I have it. I have it. Yeah, I have to open it first. Now you should see it, right?
Yes.
Yes, perfect.
That's interesting. So I have to open it first now. So I thank you again for the kind invitation. It is a great pleasure to be with you. It would be better to see you in person, but better than nothing, I think. Hopefully I can see you in Bogota. I hope so we can travel. So my talk is about colloid cysts. You know, colloid cysts, and usually a good indication for endoscopic surgery, but colloid cyst surgery might be very difficult. So the appearance of a colloid cyst in the endoscopic image is so variable and the location is variable. Sometimes they're pushing the fornix up, sometimes it's pushing it down. So I think it is very important that we have a very individual approach to all of these colloid cysts. I think that is the main problem. If you take just one method for everything, it will not work very well. So what are indications for colloid cysts? I think we all agree that symptomatic colloid cysts are an indication because, you know, there can be a deterioration of patients. If you have an asymptomatic cyst with signs of CSF pathway obstruction, that means ventricular dilation, I usually recommend surgery. There are some people, they say, no, if the patient is asymptomatic, there's no need, but I do it. When we have asymptomatic cysts without CSF circulation problems, that means normal ventricles, I think that is a good indication for observation, especially in older people. I have many old patients with a black cyst in the G2 weighted image, and they are stable for more than 15 years. So that, I think, is not an indication to make the surgery. But sudden death is truly a problem. Many years ago, I made a literature research, and I wanted to know what is the history of these patients. And I found, especially in kids, the history may be very short. So that's why if I see a child with a colloid cyst, I am very aggressive with surgery to remove it. And we had in Greifswald 2 cases of sudden death. The first one was a 19-year-old girl with a 4-month history of intermittent headaches. And suddenly she presented in coma and came to us, and you see she herniated because of this hydrocephalus. And then the second case was a 30-year-old male. He had a 5-month history of headache. In the morning of that day, he had a car accident, but no injuries, and he requested to go home. He did not want to stay. And 3 hours later, he fainted, had a seizure, headache, vomiting, and then he came fixed dilated to our unit. And you see again, there is a hydrocephalus with herniation. So that's why if you have young patients, if you have hydrocephalus, you should do an aggressive treatment to avoid this. Of course, it can be different. So you see, this is a colloid cyst. There is a ventricles, no dilation. We just observed it. And when he came for control 4 years later, the cyst is gone. So it may happen that the colloid cyst simply ruptures and no surgery is indicated, but I think you cannot advise the patient to wait for a spontaneous rupture. And this is Michael Powell. He is from England. He later was a pituitary surgeon, but he was the first who reported endoscopic treatment of colloid cysts in 1983. So if you look at the literature from the initial experience, you see usually the cyst was opened, was evacuated, and then the capsule was coagulated. And the statement at that time was, by its nature, endoscopy cannot offer complete removal as compared to microsurgical technique, stated by Philip Deck. And also Alan Cohen stated that a total resection of cyst wall is usually not possible. So the question is, can we have an aggressive and total resection with endoscopic technique? Then if you leave some cyst remnant behind, you will get recurrences. There's no question. And there are some meta-analyses comparing microsurgery with endoscopic techniques, and usually you have a higher rate of gross total resection in the microsurgical group. You have less recurrences, but usually you have more complications. So what are the treatment options in colloid cysts? Stereotactic aspiration was initially proposed, but there's a nice paper from Tiet Mathisen from Karolinska, and he showed that there's a high rate of recurrence. So that is not obviously not a good treatment. Shunting is recommended by some people, but also this is not a good idea because you can be you will be shunt dependent. You have over drainage, under drainage, and the cyst may grow and make more problems. So microsurgical resection or endoscopic resection are the only options, in my opinion. This is an example is a 10-year-old child from Cairo. She presented with large cysts, had hydrocephalus. What was done is shunt. Shunt was inserted, and then she presented with over drainage. You see subdural hygroma, and you see the cyst, and you see all ventricles are collapsed. And that is very bad. For microsurgery, it's bad, and for endoscopy, it's even worse. So this should be avoided. In this case, we had only the chance to make a transcallosal approach to remove the shunt and the cyst, and then you see the ventricles came to normal, and she was without any problems. So shunting is not an option. So is a safe endoscopic total cyst resection possible? I think yes, but we should avoid complications. And how can we do that? The first thing is you need a good equipment to do it. Not with all endoscopes you can treat an endoscopic cyst sufficiently. What I use very frequently is the endoscopic trocar because I use it as a retractor. Accurate patient selection is of importance. The entry point must be good by manual technique, sharp dissection. Then hemostasis, we use a small chamber irrigation technique or the dry field technique. All these things are very important. So the equipment, what do you need? You need an endoscope with a large working channel. So we use a lotoscope. It has a working channel of 2.9 millimeters and accepts a thick tube for cyst aspiration. And we have side channels, which allows to have an by manual dissection. And these endoscopic sheets, for me, it's very important, and I will show you why. So I use the endoscopic sheaths in the term, I go back into the sheath with my scope, and then I see it here, and then I go under the fornix and I can elevate it, and then I get access to the cyst very nicely, and I can resect. So that is a very important step. Although Uli does not use it in his pediatric patients, that's okay, but in these cases, I would recommend to use it. A large suction tube is important. So we have a 2.7 millimeter suction tube. It's an endotracheal suction tube for children, Chaillet 8. And then, of course, you need irrigation. We use Ringer's solution, and I prefer to have an endoscope holder. Some people say, no, I have an assistant who can hold the endoscope. If you have an experienced one, it's good. But if you don't have, I think endoscope holder is very nice. It's a pneumatic one. You just press this golden button, then it's very easy to bring it in the correct position. And of course, an HD camera should be used because this have a higher resolution. You see, this is a view into an craniopharyngioma cyst, and you can even see erythrocytes running through the blood vessels. Such a high resolution you can achieve if you have good equipment. Patient selection is of utmost importance. So you have to look, what is the size of the ventricles? Is there an asymmetry of the ventricles? What is the size of the foramen of Monroe? What is the size of the cyst? And what is the appearance of the cyst in the foramen? And of course, the content of colloid cyst is also of utmost importance. And is a cyst located posteriorly or anteriorly? And of course, the relation to fornix and veins is very important. So all these factors have to be taken into account to make this a correct choice for your patient. Head positioning and entry point. So we use the head in a slightly antiflex position. That the entry point is the highest point to avoid excessive egress of CSF. The head is fixed because we always use neuronavigation. And the borehole location is usually very far anteriorly and laterally. Neuronavigation is used in all cases because we would want to just slide over the head of the caudate nucleus. And this is our setup with the endoscopic screen and the navigation screen. So when we started with colloid cysts in the 90s, early 90s, we came from a Kocher borehole, same we use for ETV, but you see we have a tangential view to the cyst. We look to the floor, but not to the roof of the colloid cyst. That is, of course, not a good idea. So we want to have an approach directly into the foramen of Monroe. We want to look to the roof, and that's why we go far laterally and far anteriorly. And we just slide over the head of the caudate nucleus. So the position of the entry point is dependent from the size of the ventricles. If the ventricles are very wide, we go more lateral. If they're not so wide, we come more medially. But it should be just over the head of the caudate nucleus, far from anteriorly. For cosmetic reasons, usually we go behind the hairline. Sometimes we take a wrinkle in a bald head, and then you have a good view to the cyst. The only exception is if you have a cavum and a septum pellucidum, then you can really go on top, because usually in this cyst location, the fornix is pushed downwards and the foramen here is very narrow. If you try to go from this point, you will damage the fornix. So we open here one layer of the septum, and then we are on top of a cyst. You see one fornix here, one fornix there. You just open here the cyst wall, and then you can dissect the cyst. So bimanual technique and sharp dissection, we have a flexible small forceps, which can be introduced via the side channel of the endoscope. It must be flexed because you see here is an angulation. And then the main instrument comes from the main channel, and then you have a kind of bimanual dissection, which I think it's important. You can elevate the cyst, and then you can cut, and you don't have the risk to damage your fornix or the veins. One short example, you see this is a colloid cyst. You take a forceps, you have to mobilize it, but you see there's a pedicle. If you simply pull it out, you can do, but you will have, of course, a lot of hemorrhage, and that is not a good idea in my opinion. So we have to deal with the pedicle. We coagulate the pedicle, and then we take the forceps from the side channel, elevate the cyst, and then we have a good approach to the pedicle. If you don't use a bimanual technique, of course, the cyst will fall down if you leave it. And then it's difficult to get good access. But here you can use two instruments. At first you cut, first you coagulate the pedicle, and then you take scissors. So I usually try to mobilize the cyst and dissect it completely before I remove it. I think pulling, it's not a good option. Sometimes it will work, but usually there is a lot of vessels inside. So hemostasis technique, what were I using? We have a bipolar forceps, and we have this bipolar diathermy probe, which is usually used. And one of our fellows described our technique as a small chamber irrigation technique, because when it starts to bleed, we start with irrigation and we go closer with the scope to the bleeding forceps. And then when we have a glimpse to the bleeding area, we retract the endoscope into the sheath and we create this small chamber. And then we go very close with the margin of the sheath to the bleeding point. And then this small area you can easily clear with irrigation. You know, when you are in the lateral ventricles, you have a hemorrhage, you can irrigate what you want, you will never have a clear view. But this small chamber can be cleared and then you have a good view. One example, you see a colloid cyst. By manual technique, we pull on the cyst and there's a small artery coming from the telechoroidea. To get access to the vessel, I have to use the bimanual technique because I have to pull on the cyst. And then I coagulate. I coagulated 4 times and I thought this must be sufficient. And then I took a scissors, but I cut too far proximally and you see, oops, started immediately the hemorrhage and you don't see very well. So in this case, of course, you start with irrigation to get a better visualization, and then you have to go with the endoscope and try to localize the bleeding point. You see, we have a glimpse of the anatomy, irrigation. I go with the endoscope back in the sheath, so I have the margin of the sheath, and then I go into the third ventricle. You see here, and I push the fornix up because otherwise I get no access to the tela at the roof because here's the artery. But now I have a good visualization. Here's the telechoroidea, there's the artery, and then I can deal with that and I don't need to interrupt the surgery or put a drain or something like that. And then we can continue with the surgery. So this is a very helpful technique. Sometimes we use a dry field technique. What is dry field technique? Dry field technique means we have a lot of hemorrhage. We cannot clear the view. You are completely lost. And after a short time of irrigation, it will not clear. So then we simply remove the CSF completely. And we first described it in our paper of colloid cysts in 2002. And recently, Dr. Oertel from Hamburg put some cases together and published it as well. So this was a misunderstanding between me and my assistant. He should just rotate the scope, but he is pulling on the forceps, and you see what's happening if you make the pull-out technique. It starts to bleed, and you just see the Japanese flag, just red. And of course, there is makes no sense to start with irrigation. So in that case, we use suction tube, remove the bloody CSF. See, it's a lot of blood. You have to be careful that you do not damage the fornix when you aspirate it. But in all of our colloid cyst cases, we just removed the CSF and then the bleeding stopped spontaneously. So in the cases, we couldn't find really the bleeding source. We coagulated a little bit, but the bleeding point stopped by itself. And then, of course, we refill the ventricle to prevent a collapse. And you see, this was after the hemorrhage, all is clear, and we could get a gross total resection, no damage to the fornix. So these techniques are very helpful, in my opinion, for hemostasis. So I want to show you some cases. The young boy with headache, you see this cyst, has a ventricular dilation on the left, is appearing more on the left side. You see here, the right side is very narrow, so we will come from the left. Navigation is used, and see the content. The content seems to be good, because it's not the black signal. Navigation is used. And this is an ideal cyst. You see there is not much choroplexus covering the cyst. It's appearing well in our foramen and the approach seems to be good. So we just take scissors, open the cyst, then we take a suction tube and you see the content is very nice with our big suction. It was just a few seconds, cyst is evacuated. Then some irrigation, you see the cyst is almost surrendering by itself. But of course, it's a little bit attached, but this, of course, is an ideal case. So we coagulate a little bit of the plexus, and then we take the bimanual technique Let's see what is a pedicle. This is from the main channel, it's the main forceps. And then we mobilize the cyst into the lateral ventricle, and you see there is no vascular pedicle, it's just a fibrous pedicle. And of course, you could take scissors now to cut it, or like in this case, we just removed it because there was nothing inside the small pedicle. This, of course, is an ideal case, which is easy. Unfortunately, it's not always that easy. This after surgery, and it's no, I think 8 years or 9 years after surgery, no recurrence. It's another patient, you see the cyst content, it's not black, it's more apparent in the right side. But you see there is a very thick thalamostriate vein going over the cyst and all the area which is to approach. So this can be a problem. Though we go in with the endoscope, you see this is a big thalamostriate vein, as we have seen it on the MRI, and the area we have for dissection is just 2 millimeters, 1.5 millimeters, 2 millimeters, not more. And then, of course, if the cyst content is very firm, that it might be difficult. But here you see we are lucky again. So we take our suction tube and we could evacuate the cyst very easily. You have to be careful that you do not damage the fornix here. And then you have to mobilize the cyst. And it's of utmost importance that you grasp just the cyst wall, not the tela choroidea. If you have just the cyst wall, it can come out very easily. But if you grasp the tela, of course, you will get a lot of hemorrhage. And you see here, this is alteria and plexus, and this is a colloid cyst. So it was not much adherent, and we could mobilize it with a grasping forceps, but you see there's one vessel, still the vascular pedicle. So we take the bimanual technique, we elevate it, so I can coagulate it very easily without touching the fornix. And then we take scissors to cut it, and then we can remove the cyst. I think it's very important that you really take care that you really only grasp the cyst. In another case, you see this cyst is dark in T1 and T2. It's equally apparent left and right ventricles, and of course we come usually from the right side. So we see the cyst. It's also visible in the foramen. First step, coagulation of the choroid plexus covering the cyst, incision of the cyst. So some of the content is soft, but there is a major part which is not suckable, it's not coming out. So we grasp the cyst wall, and to mobilize the cyst into the lateral ventricle, and you see there's a lot of choroid plexus attached. So it's not a good plane. So we try to evacuate more, but the firm content here, it will not come out. So now we have the right plane. You see, this is a thin wall, and this is all choroid plexus. We just have to grasp the thin wall. There's some vessels still in the pedicle of the cyst. First coagulation. Here I use the endoscopic sheath as a retractor. Push the cyst a little bit up to get access here to the blood vessels. Take care that you don't coagulate the thalamostriate vein, just the small ones. And then here you see there's a one vessel which I overlooked, and then it starts to bleed. And then again, I tried to use a small chemorrhagation technique to control it, but I think it was not safe to coagulate in the depths because you don't know where the contralateral fornix is. So I made the decision to make a dry fit technique, and you see it stops. Now I grasp the cyst, and this is all tela. You see, this is a tela, and this is a pedicle. So I refill the ventricles because usually it is collapsing. And then I have access to the pedicle. You see a lot of vessels, coagulation. And now I use the endoscopic sheath to push the cyst up in front of the fornix. So I have a very nice view to the pedicle of the cyst. Because this pedicle was very long. It's not always the case. So it's very individual, of course. In here, it's not fitting through the working channel. It's not fitting through my endoscopic sheath. So I have to remove the whole system, because then I can dilate the cortical puncture channel and the cyst is removed. Then you can use a 45-degree endoscope to look to the contralateral foramen of Monroe. You see this telechoroidea with a lot of blood vessels. So this is one example where the pull-out technique will not work very well. And the question is, should you always aim for gross total resection? This was a patient where I did the surgery in Kuwait with Walid. And you see this huge cyst. The content seems to be soft, but you see the fornix. This is the fornix, very thin, stretched over the cyst. And when we looked at it, that was really so thin. So I had doubts when we make a gross total resection that we destroy the fornix. So we make a wide septostomy. We went into the cyst, we evacuated, and then we made on the contralateral side also a septostomy. So we have a huge communication and an almost near total resection, but at the fornix we left some part. And you see the fornix here, still there. And this was, I think, 2 years after the surgery, and his memory improved dramatically. But then he was lost for follow-up, unfortunately. So, but the thing in this case, it was better to leave the small remnant. Is endoscopic approach always the best choice? This is one patient came to me, second opinion. She underwent endoscopic surgery in another city in Germany, but she could not remove the cyst. And I was wondering why. It's so apparent here in the ventricle, why they could not do it. Then I made a cyst sequence to have better view. And you see, here seems to be the fornix, and this is the cyst. I think, why? Why is it not working? It should be. I explained to her, we tried with an endoscope. If it's not working, we will sorry. When it will not work, we will come with the microsurgical technique. And when you looked in and you see, that was the reason. This is a very thin layer of the fornix covering all of the cyst. So you cannot open it here. Of course, you can do it endoscopically here and then dissect the cyst. But in my opinion, this is better for microsurgery because I can use patties and I can push gently the fornix to the side. So in this case, we switched to microsurgery. We opened the septum here, left the fornix alone, and removed the cyst. Another case came with this huge black cyst. And you see here is the vessel down. So this should be the foramen of Monroe. So I explained to him that will be not a good case for endoscopy. We will look with an endoscope, but probably we will switch because the white ventricles. So we make a transcortical approach. And you see the foramen is almost gone. And of course, you can open it endoscopically here, but in my opinion, these cases are better done microsurgically. So we removed the endoscopic sheath, went in with a tube, and did it under the microscope. You see, this is all cyst. Of course, you can open it here under endoscopic visualization, but I think if you have bimanual technique with patties, push it to the side is better. And here we make an interfornicial approach because you have seen there was a separation of the fornices. So we are in between the fornices, and you see the content of the cyst is very, very firm. And again, you have to find the right layer of the cyst. This is just a small cyst membrane. These are the internal cerebral veins. Here you see this is all talar. All talar can be dissected, and just the thin cyst is removed. This is a pedicle, easily coagulated and cut. And then the cyst is removed. So in my opinion, that is a better case for microsurgery. And it's another case, the last, you see here, white ventricles and very small foramen, but the cyst content seems to be very, very good for aspiration. But I was concerned that it is too small. The foramen is too small. When you look here, initially I thought to make interfornicial, but I think that's not a good idea because there is no separation of the fornices. If you look to the foramen, it's just 1 millimeter, 1 millimeter. So that's why I switched to the tube. So we removed the endoscopic sheath, went in with a tube. And then you have really a nice approach. And now with the forceps, I can dilate the foramen a little bit. We open the cyst and you see the content is very good. So in retrospect, with an endoscope, I think it will also work. But at that time, I felt better to make it microsurgically. So we evacuate the cyst. And then again, you have to grasp the right layer not the tailor, just the thin wall of the colloid cyst. And then you see it comes out easily. And here again, this is a pedicle, and you see microsurgically, you can deal with it very nicely, coagulate it and take it out. But what do you do with this small cyst? That is my question to all the faculty. You see, this is a patient, has a very small, tiny colloid cyst, but also the foramens are very small. And he always explained of pressure feeling in the head and headache. And I would send him home for 2 years. And then he came back and said, everything is deteriorating. So I said, okay, we remove it. But how can you remove it? For the endoscope, I think it's not a good idea, it's too small. So I think the only way to do it is the transcallosal approach. So we make a transcallosal approach. Corpus callosum is identified. Neuronavigation is, of course, very helpful. We open the corpus callosum, then we are in the ventricle. You see the ventricle is very narrow. And you see the foramen is not visible. So there's no chance with an endoscope to do it. So we have to retract it a little bit, go to the we'll go back to the foramen, open the fissure on the side of the thalamus, not on the side of the fornix, because there's more attached. And then we found the cyst and removed it. And finally, we asked the patient, how are you doing? And he said, yes, the pressure feeling is gone, but there's still headache. So, you know, I think it was not a good indication, but he was maybe psychologically involved, and now he is happy. So when we look to our series, we published our first series of endoscopic surgeries in 2018. And in these cases, we had 3 patients with small remnants, and 2 of them had a recurrence. So that's why I think we should aim for gross total resection. We reported our technique in 2020 in the JNS. And in this paper, there were 16 patients. 12 has occlusive hydrocephalus. 1 had memory problems, and 1 was asymptomatic. And we did a gross total resection in most of them, and 1 lady not, because she was over 70 and requested a very safe technique. We had 4 venous hemorrhages, all were endoscopically controlled with the dry field technique. We had 1 patient who presented with memory deficits before and worsened, but I think the worsening is really related to her comorbidity of Alzheimer's disease, because there was no damage to the fornix, there was really nothing. And that follow-up is now 40 months. Gross total resection is 15, and 1 intentionally we left a little bit because this was an old lady, and we had not to change to microsurgery and had no recurrence so far. So my conclusion is that for most colloid cysts, endoscopic technique is safely possible. We can achieve gross total resection similar to microsurgery, but I think it's very important to have a good patient selection. You have to see what is the best, and it's not for all patients. I think endoscopy is not the best option. And I would like to encourage you to become a member of the International Federation of Neuroendoscopy, although we cannot do very much because of this COVID pandemic. We have a course in Naples in July, so you are all invited to join us. And of course, I want to invite you for the World Congress, which is to be held in November 2023 in Singapore. Thank you for attention, and thank you for your kind invitation.
Thank you very much, Henry. Excellent, impressive lecture as usual. So Henry demonstrated a range of cases from small cysts to big cysts, from a soft to a firm content. And he also highlighted certain important points, more front and lateral approach, because sometimes if you come too medial, so in an oblique fashion, you cannot see the roof, the pedicle, and sometimes the cyst can fall into the third ventricle that make things more difficult. So he also do not fix his approach, but tailored to individual need with a varieties of technique. Excellent, Henry. So I think we have time, but we ask from the chat box. If patient with colloid cyst with hydrocephalus comes in unconscious cerebrating, what is your advice? Direct excision or EVD?
So it depends. When he is a very bad state, we just put an EVD and look how he's developing. Then I think you don't need it to make it in the same night. You can do it next morning if he's awake. If you see it was too late, he's not improving, then of course there's no need to make this. Usually if the patient comes in with headache, vomiting, still maybe a little bit drowsy, but still responsive, then I would do endoscopic surgery at that time. And of course it depends, you know, if you have a resident there and your consultant has not much experience with these techniques, they should not try it simply because they are on call at that day. Then you should put an EVD and we can deal with it next day.
Okay, thank you. There is a question from the panelists. Can you post the question?
Yes, Henry, can you hear me?
Yeah, sure. Hello, good to see you.
Hello, how are you? Nice. I hope we can meet physically again.
Yeah, I hope so too.
And we are holding the ISMIN conference in October. I hope you can come to Delhi.
Okay.
So it's an excellent talk, Henry. So I have been managing colloid cysts endoscopically for the past, I think, 15 years. I was at Greifswald and, you know, we had a wonderful time and that's when I started doing it. And more recently, for the past few years, I find that the dry technique is very, very convenient. So you just put a sheath, you empty all the CSF, you hold the cyst with a pedicle and they're cauterized and the whole thing is over in a few minutes. So my question is, when the dry technique is so convenient, why should we still follow the underwater technique?
Yeah, that's a good question, because it looks nicer. And in many cases, it's not necessary. You know, you have shown you some cases. The disadvantage of the dry field technique is that the ventricular wall is tending to collapse, and then the ventricle becomes small. So that is what I don't like, because if there's some water, it keeps it open. You have a more distance between the fornix and the head of the choroid nucleus. That is the advantage if you don't remove the CSF. But of course, it is an option. Many people say you advise also microsurgical technique and you have a good outcome. Why you don't do all cases microsurgically? It's also an argument, you know. That is very difficult to say. In all cases where we did microsurgery, we don't have a better outcome that we say the patient needs to stay longer or so, because when you use this tube, the tube has a diameter of 12 millimeters at the tip, and my endoscope has 6.8. So it's a few millimeters more. Of course, if you look to the post-op MRI, the endoscopic tract is hardly to see. And with a tube, you have a larger tract. But as I said, the results are also very good. That is really a matter of philosophy. So my attention is we go in, if you see it's easy, underwater technique. If I see I have a problem, then I'm more in favor to remove the CSF earlier. Previously, I would try to irrigate, but now when there's a major hemorrhage, I take it out and that's it. I agree with you.
Okay, we have question from Alberto Faletti. He's also the chair person for this session. So Alberto.
Thank you, Azmi. And thank you, Professor Schroeder, for the very nice presentation. I have some questions. So your technique is first to open the cyst and remove the content and then deal with the capsule. This is my first question. Or sometimes if the cyst is small, you try to remove it in one piece. Then I would like to know if you have ever experienced the situation of some colloid content falling down into the third ventricle. So if happened, how did you manage this? And the last question is about neurocognitive tests, if you perform them routinely before and after surgery for these cases.
Yeah. So let's start with the last question. We would like to have psychological tests before, but it's very difficult to get an appointment to have the testing. Sometimes they advise, no, I have no time in 2 months or so. You know, that is a problem. Of course, it would be best to do it before and after. Usually what we do, of course, is when we have in post-op deterioration, the patient said I had a problem, then we send him to verify. And then we make a new examination after 6 months and 1 year. So we don't have for all patients, we have this neurological exam, unfortunately. Regarding the technique, even if the cyst is small and you just pull it out, I felt there is some stretch to the fornix. Just in the last case, I make an evacuation of the cyst, half of it, and then I tried to pull it out, and I had a small damage. It was superficially, but it was a damage to the fornix which should not occur. So I think I would not advise to remove the cyst totally. Some people say you can better deal with it, you coagulate or so, but in my opinion, the cyst is always larger than the foramen. And you know, you can dilate the foramen for 1 millimeter, it's not a big problem, but it comes to 2 or 3, then you will have some damage to the fornix. So that's why I open the cyst, evacuate, and then I bring it out. And what was the second question?
The second was if you have ever had the situation when some colloid content is falling down into the third ventricle, especially in the posterior third ventricle. I'm asking because it happened to me once, so I'm curious.
In the third ventricle, I had it not. I had it in the lateral ventricle. It fall in the lateral ventricle, and then I tried to irrigate to mobilize it, but it was seen on the post-op MRI in the posterior horn. If it goes to the third ventricle, it's not so good because it may obstruct the aqueduct, but I have never experienced it. So I have never put an external ventricular drain, never. I just look with a 45-degree endoscope, I look backwards, try to see the aqueduct, whether is there something, and then I would irrigate. I think the third ventricle is small. If you have some content there, I think if you irrigate, it will mobilize it. It would be my thinking.
Thank you.
Okay. All right, last question from Professor Ventakaramana.
Yeah, Henry, is a very nice talk. Nice to see you again. Is there a situation where you need to enlarge the foramen of Monroe? If so, will you do endoscopically, and how you do that?
Yeah, this is possible when the fornix and the thalamus are a little bit separated from the cyst. If it is very narrow, what I showed you in the case where I made it microsurgically, then I would switch to microsurgery, because I think, and I have seen videos from some guys, they have shown that they opened the foramen endoscopically, but the fornix, in my opinion, did not look very good. So I think it is more traumatic when you make it with an endoscope, because with a microscope, you take a patty, you make incision of the tissue of the talar choroidea, and then you can separate it easily. It's the same when you make a microsurgical approach in that area. So when the situation is anatomically good, that means the cyst has already separated the fornix from the thalamus and just a little bit connective tissue, I would cut it and I would open it. But otherwise, I would switch to microsurgery.
Thank you.
Okay, because of interest of time, we shall proceed to the next presentation. If we have a question and we have time, we will go back for the second round. I think Prof. Ventakaramana, your presentation.
I will try my best to. Some technical issue here. I will.
Okay. Otherwise,
Venkat, if it is not working, you can send your talk and maybe it can be done tomorrow.
1 second. It's just give me one chance. I will. No, I think it's not working. There's some problem. So can I have it tomorrow? Tomorrow sometime in the afternoon or something.
Please send your talk to Dr. Liu and then can schedule it for tomorrow.
Yeah.
Thank you very much. So we shall proceed to the last presenter, Professor Subodh Raja. He will talk about a flexible endoscope in cranial surgery for complex hydrocephalus.
Yeah, a very good evening to everyone. Good day to you. Thank you for the opportunity. Sorry, I could not send my recordings. So I'll try to see if I can share my screen. Is it seen?
Yeah.
Okay. I belong to Hyderabad, India. So my endoscopy experience is around 15 years, inspired by a lot of people, including Professor Schroeder, and these things we have learned from that. So Moving on to rigid endoscopy, then we thought that yes, in India, flexible endoscopy is allowed, which is it's not used much in the European countries because of the regulations. So, but we had the advantage, and we started using flexible in different indications. So, the use of endoscope is various. We know that it has been widening slowly with more and more endoscope you have, and so started using this flexible endoscope for small ventricle in small foramen of Monro. I had the standard scope, which was a bigger diameter. When I tried to manipulate it inside the third ventricle for doing a simple third ventriculostomy. So when the trajectory is not correct, then this is what happens, a pharyngeal contusion. So we started using the flexible endoscope for doing a routine third ventriculostomy. This is the previous routine flexible endoscope which was available. The images and these things have improved over a period of time. And these flexible scopes used to have a monopolar cautery along with it for doing a routine third ventriculostomy. So this is very useful especially in small foramen of Monro or the small ventricle, third ventricle, where you have to do a endoscopic third ventriculostomy. So taking the indications forward, when we had something in the armamentarium, we sometimes use it as a salvage procedure. This is a case of a simple hydrocephalus with a shunt malfunction. One of my other colleague was doing it, and he put a rigid scope into it. So once he went to the rigid scope, he could not see anything. So he had to call me. So I went into side. Then I realized that he has gone to the other side. With the rigid scope, he has gone to the other side ventricle. So from the right side, he has entered the left side through a septum. And this is the foramen of Monro you can see of the from the contralateral side. Readjusting the scope was not helping at all. The septum and the ventricular wall were repeatedly falling up. So it was very difficult to do third ventriculostomy in this case because the shunt malfunction and it was required. This is where we use the flexible scope, and so we can from the contralateral foramen. So this is the new chip-in-tip flexible scope which has a better vision. So we went in from the contralateral foramen. This is a flexible scope. You can see the foramen of Monro, and went into it. And this is the third ventricle floor, the mammillary bodies, and the third ventricle floor. And we did a third ventriculostomy and dilated it with the 2 French Fogarty catheter. The flexible scope has a working channel of 2 French Fogarty catheter. So it helps us when we have something in armamentarium. It helps us in you doing this case. We had usually the foramen of Monro is small, but when sometimes you have to go to the aqueduct and to the third ventricle floor. In a small foramen of Monro, it is very, very challenging. And you want to do an aqueductoplasty or an aqueductal procedure or take a biopsy or want to go into the fourth ventricle through the aqueduct. With the rigid scope with a single burr hole, it's challenging. So we use when you use a rigid scope and try to manipulate your scope too much around the foramen of Monro. So this is the foramen of Monro, and we are trying to see the aqueduct with the rigid scope through a precoronal burr hole. This is the third ventricle floor, and this is what happens. So usually this is a venous bleed, and it will subside with its own time with some irrigation. It's not very massive, but this is what happens. So manipulating the rigid scope too much around the foramen of Monro can lead to pharyngeal damages and the small venous hemorrhages and these things. So rigid endoscope is more popular, but the limitation with the flexible scope is that whatever you operate is not in the line of your vision and your operating thing. But the advantage of a flexible scope, it's maneuverability actually. So the number of advantage between and these things, better image, but flexible has a better steerability, and you can use it through the same burr hole or the same sheath what we use it. And instrumentation is basically the conventional this thing which has got a 130-degree range of movement. The tip has a 130-degree range of movement. It has a biopsy forceps, a ventriculostomy forceps, monopolar cautery, and nowadays we use the laser with it also. The poor image pixel granules which used to be there with the initial conventional flexible scope has been taken care with the advent of the with the advent of this video neuroendoscope, which is much more sleeker. It has a chip and tip camera, and the images are equally very good. So we use it for a number of regions, number of indications, and some of these indications I'll be discussing you. First of all is for posterior fossa arachnoid cyst, we use it routinely. Arachnoid cysts which are located on in and around the fourth ventricle. Different methods have been described to take care of this posterior fossa arachnoid cyst with hydrocephalus. But in certain conditions where we saw that the arachnoid cyst was adjacent to the fourth ventricle, so we thought that it's not necessary to put a second shunt or do a second procedure from the back. How can we do it through the same aqueduct? So numerous papers are available about different procedures and these things. So we use this flexible scope to our advantage in doing this. So to understand the fourth ventricle, so this is a small video on the fourth ventricle anatomy. So this is passing the flexible scope. It's a dilated, it's a redo case actually. The third ventriculostomy is done. This is the aqueduct. Is for the understanding of the PG students. This is the aqueduct. And once you pass the flexible scope into the aqueduct, this is the fourth ventricle we have entered into. There's a choroid plexus. This is the foramen of Magendie here in the center. This is the bone you can see below. You can see the bone here. And this is the foramen of Lashka. You can see here the choroid plexus going here laterally. So these anatomies understanding is easy with the flexible endoscope. And you can see here, and these are the colliculus, the superior and the inferior colliculus. A very good view of the anatomy of the fourth ventricle. So a couple of cases in dilated aqueduct, we went ahead and did this understanding the anatomy. And so we thought that why can't we use it in these type of cases? This is a posterior fossa arachnoid cyst which is bulging into the fourth ventricle, and the child has an obstructive hydrocephalus. This is an 8-month-old child, and he's symptomatic for the past 3 months. So in these cases, we did all these things were done through a standard precoronal burr hole, transforaminal. First, the routine third ventriculostomy is done to take care of the hydrocephalus, routine. Then we put the flexible scope, and you can see the aqueduct. And once you pass this, the good thing about this is all these cysts which are there around the fourth ventricle, they cause a natural fourth ventricle outlet obstruction. So the aqueduct is naturally dilated for you. So you don't have to dilate the aqueduct or do anything for that, aqueductoplasty for that. You have to just pass the 4 millimeter or 4.2 millimeter flexible scope through it and marsupialize the cyst number of times and coagulate it. So you coagulate it number of times and see the cyst is completely collapsed. And for the hydrocephalus, you have done a third ventriculostomy. There's a choroid plexus in the fourth ventricle, and you can coagulate the whole cyst actually. These are the pre-op scans. In the post-op scan, you can see the cyst is collapsed and the ventricles are decreased in size. Initial days, we used to put a reservoir in cases of high pressure hydrocephalus to prevent an early CSF leak, which is kept for 2 months and then it is removed in these cases. All these children are more than for 10 years of follow-up now, and they have been doing absolutely fine without any recurrence. Similar other case, one more case of a posterior fossa arachnoid cyst causing an obstructive hydrocephalus. Same way, through the aqueduct you go, you can see the cyst here. You coagulate the cyst completely and marsupialize it completely at a number of places. There's a post-op scan. The cyst is collapsed and the hydrocephalus is decreased. This is another challenging case of a retrocerebral arachnoid cyst with a very narrow prepontine system. The option was doing a third ventriculostomy, but it was not possible. We tried doing it. And so we did a third ventriculostomy, but the challenging thing was addressing this posterior fossa retrocerebral arachnoid cyst. Not a well-described or a great procedure. I know many people in this panel will not agree to this, but I thought that when natural pathways are open, let me see this. So the aqueduct was dilated. We went into the fourth ventricle. Then we went into the foramen of Magendie here. So with the 2 French Fogarty catheter, we slightly made some way to the foramen of Magendie, and we could easily pass the scope, the new scope, which is slightly a lesser diameter, 3.8 millimeter. We passed it through this, and you can see the cyst here, arachnoid cyst. We coagulated it, marsupialized it at a number of places. You can see here the cyst wall, the pica vessels there. And same way, coagulated initially days we were using the monopolar cautery, but nowadays we have the laser with us, and the laser fibers are easily passed, and they're very good source, a good procedure for these arachnoid cysts. Actually, the laser is very, very useful. You make multiple openings. You see the occipital bone. You can coagulate it at number of places. We make a number of fenestrations and number of openings in that. This is a third ventriculostomy which we had done. You can see the basilar artery, the dorsum celli. So this child had a subdural hygroma because the hydrocephalus was huge and the child had a large head. But if you see the cyst, cyst has collapsed slightly and the hydrocephalus has decreased. This subdural didn't require any other further intervention, and it resolved with a period of time actually. This is another case of a same retrocerebellar arachnoid cyst, but in this case, we could not do a third ventriculostomy because of the narrow prepontine cistern. So we had to take care of the cyst, and we did a shunt along with that after that. So the same method, transaqueductal, transmesental, we go into that, coagulate the cyst at number of places with the monopolar. The cyst is collapsed. And then we, with the flexible scope, we guide a catheter, ventricular catheter, which acts as a stent and a shunt, which has number of fenestrations all along. The shunt is outside. The grasping forceps is through the flexible scope. It holds this thing and it guides it through the foramen of Monro, through the aqueduct, through the mesentery into the cyst. We could have done the shunt from the posterior side also, but I thought that this is better because posteriorly we had this large cyst, we had this issue of pseudomeningocele and CSF leak more often. And this one acted as a stent and the shunt for all the purpose. So we, just like a trapped fourth ventricle we do. So the shunt tip was placed inside the cyst. And there's a post-op X-ray. You can see the shunt, it's connected to a routine ventriculoperitoneal shunt and multiple fenestrations are made all around. This child is also doing well. Similar cases of, this is a case of a trapped fourth ventricle where we have placed a catheter and the shunt is placed across the aqueduct here into the fourth ventricle with a flexible scope. Actually, this is a post-infective trapped fourth ventricle. In these cases also, we have done this. This is another case. There's another case of a child with tubercular meningitis, had a shunt done at childhood at the age of 3 months. Now she is 12 years old, presenting with gait ataxia for last 3 years. When we see the scan, is a trapped fourth ventricle, you can see here, but the supratentorial ventricular system is well collapsed actually. So in this case, what we did was a retrograde aqueductoplasty, a small craniotomy. The foramen of mesentery is opened, and through that we pass the flexible scope retrogradely and open the aqueduct here. The aqueduct is open with the 2 French Fogarty catheter with a flexible scope. You see the whole other thing, the foramen of Luschka and everything is completely plastered in these cases. There's no other opening. So we did a retrograde aqueductoplasty and a small suboccipital craniotomy through the foramen of mesentery. So this is a post-op scan done after 3 months. The child still has symptoms, but she's better on these things. No further procedure has been done. She has shunt in situ and the shunt is functioning well in this case. We require a long-term follow-up in these cases. The other indications we have done is a mesenteroplasty for a large foramen, fourth ventricular outlet obstruction. There's a transaqueductal cyst decompression and same way a shunt placement into that. Same way for trapped fourth ventricles. With a flexible scope, we guide it through and the shunt is placed like this. The other indications, this is a case of a arachnoid cyst which was present across the ventricle, where with a rigid endoscope, we tried to open it up, but after opening it up, we thought that the cyst is extending to the opposite side and there was some amount of hydrocephalus. So we did a opposite side flexible endoscope. So all the cysts which are present in and around the third ventricle or the fourth ventricle, around the fourth ventricle, we can take care of this. But if it is away from the fourth ventricle, it's difficult to do. except in few selected cases where we have done the retrocerebral cyst, but it's not a great indication. The next indication for flexible endoscope is these multiseptate hydrocephalus. If you see this case, I mean, no single rigid endoscope, these are navigation images, no single rigid passage or this thing is going to take care of that. So with the flexible scope, first with the rigid scope first, and then with the flexible scope, we went into the ventricles and tried to, we see the flapping technique of the ventricle wall or the septal wall to know what is there beyond. So in these cases, we made 7 openings all along. First opening, second opening. I'm just coming out from inside out and you can see the third opening. So from one cyst to one septum to other septum with the flexible scope, you can keep on passing your flexible scope. There's a fourth opening. There's a fifth opening. So with a flexible scope, you can maneuver it in cases of these bad multiseptate hydrocephalus. Otherwise, a rigid scope is sufficient and then putting a shunt is sufficient. So after we have done that, then we pass the same along the same pathway. I showed you how to place the shunt with a flexible scope. The grasper is through the scope, the shunt is outside, a longer shunt tube is required. And then we follow the same pathway to guide the shunt tube into the ventricle so that the catheter is placed across number of these open septae across and through and through. So we slowly guide it one by one from one opening to the other opening. Just forwarding it for the interest of time. And once you reach that end, you know that you have crossed all openings, then we leave it there. The maneuverability of the flexible scope becomes less when you have an instrument. So you have to be, you have to know beforehand on that. The next complexity in the hydrocephalus is a difficult third ventricle floor where you have all these types of third ventricle floor. We cannot do a third ventriculostomy routinely in these cases. So in these cases, what with the translaminar terminus, now it is a well described procedure as an alternate area for doing a third ventriculostomy where the floor is not great, or we are not able to find. Wherever possible, we do a redo third ventriculostomy, but when it's not possible, we will die to this. And all these decisions to open up the laminar terminus is not pre-planned, and we took it on table. This procedure was taken up on table. So having a flexible scope was an advantage with it, and we published in way back in 2016 on this. This is the laminar terminalis. And especially in tubercular meningitis and these things where it's a bacillus arachnoiditis and a lot of fibrosis happens. So we do this, and laminar terminalis conventionally we open it during our ACOM aneurysm surgery from outside in, but in these cases we went from inside in. So the flexible scope is passed along this and opened, laminar terminalis open. The endpoint, like in third ventriculostomy, tell that seeing of the visualization of the basilar artery. In these cases, we tell visualization of the cerebral artery complex. Anything it could be. So this is the aqueduct we try to open. This is one case where there's not a great third ventricle floor. So this is the optic chiasma. This is the laminar terminalis. We are opening it up with a small cautery, and you can see into the space we have gone and dilated with a two French Fogarty catheter. This is a very old case, so the visual is not very clear. The conventional flexible scope, but this is a new flexible scope which has a better visualization of these things. This is another case of same laminar terminus. The floor is fully vascularized. We tried to open it in a number of places, but was not happy with the vascularity and the amount of fibrosis which was happening there. We tried doing it. You can see thick fibrous these things on the floor. So in this case, we did the same, the optic chiasma, and opened it the third ventriculostomy, laminar terminalis. There's a post image you can see here, the opening up of the laminar terminalis in this case. It's feasible in selected cases. It's not a primary method. Wherever we cannot do a conventional third ventriculostomy, we can go for this laminar terminalis third ventriculostomy. Other is complex hydrocephalus. Conventionally, if you're taking a third ventricular, posterior third ventricular biopsy, we used to do 2 burr holes. But with this flexible endoscope, we are able to do the biopsy and the third-ventriculostomy through a single burr hole. So this is again conventional routine third-ventriculostomy is done. Initial days, third-ventriculostomy has to do first, but nowadays I take the tumor so that bleeding it doesn't happen after that. So this is the tumor you can see obstructing the aqueduct. So we are taking a biopsy from there. So it's one of the very good uses of a flexible scope is taking biopsy from the posterior third ventricle and doing a third ventriculostomy along with it. This is another case of posterior third ventricle tumor. You can see here the flexible scope is passed, and you can see the tumor now, and you can take a biopsy from that. One of the very attractive indications of doing it. Dr. Schroeder mentioned very nicely about the colloid cyst, but I faced some of these challenging cases of colloid cyst where it was densely adherent to the roof of the, I could not find a pedicle or anything. So in these cases, why do I use a flexible scope? So after routine decompression of the colloid cyst, we use the laser to open it up, cut it into piece. Then the floor was very thick and there was a bleeding. So I use a flexible scope to the residual floor, the roof which is there in the capsule which is there attached to the roof of the this thing. I tried to mobilize it. It was not getting mobilized. So with a flexible scope and laser, I try to fulgurize it or coagulate it. This is a 3 months post-op scan. It may be having something. It's a 3 years. The patient is in follow-up for 3 years. Let us see and see how it works. But there are some challenging cases where we are not able to remove the cyst wall completely. So this flexible scope with the laser, I use it to fulgurate the roof of the cyst, which is the residual cyst wall, which is adherent to it. And what happens is they fall off like scars, actually, scar tissue, burnt out tissue. Then you can easily remove it sometimes also. The other very good indication for a flexible complex hydrocephalus is this choroid plexus hyperplasia with hydrocephalus. This patient already undergone a choroid plexus coagulation, VP shunt. VP shunt led to an ascites because the output was so high. So it required a radical choroid plexus coagulation. So in these cases, we use the laser to do the rigid scope and the laser. First with the rigid scope, whatever we could coagulate, we coagulated it. Is the thulium laser which you use routinely. And to reach to the other parts, this is a flexible scope coming into this thing. We had the front firing. The side firing is also very useful in these cases. And we completely fulgurate the choroid plexus, make it a complete. So these cases, you can see the both sides is choroid plexus completely fulgurated. And so this child did well after that. The ascites decreased. The child still has a shunt, but the ascites decreased and these things, and symptomatically very good. So the flexible, for especially in CPC in complex hydrocephalus, it's very useful for managing this choroid plexus fulguration, these things. So concluding, maneuverability of the flexible scope and around the third ventricle for reaching the target causes minimum collateral damage as compared to a rigid scope, but your hand-eye coordination has to be very good in this. Small ventricle, small foramen of Monro is not a deterrent for use of flexible scope. It's a very, very useful adjunct in places where it's available. And nowadays with the laser which we are having, flexible scope is to ablate further inaccessible location and a difficult area to coagulate. We are using the laser more and more with the flexible scope and the rigid scope. Thank you very much.
Thank you very much, Dr. Raju, for the very nice presentation. Well, I am a strong supporter of flexible endoscopy for ventricular surgery, so I really enjoyed your talk. And I would like to know if there are some questions from the audience, because I have some questions for you. Maybe I can start. Did you start endoscopy, flexible endoscopy, using video endoscope or using a fiber optic scope? This is my first question. And
I'll answer one by one. I may forget the question. The first one thing which was a flexible endoscope. It was not a
So-
video neuroendoscope. Video neuroendoscopes are available now only.
Right. I'm asking because I'm very envy of you, because as you said, in Europe, it's not allowed to use.
Yes.
So I'm using a fiber optic scope. So my question is actually, if you started with the fiber optic scope, how did you feel the passage from fiber optic to video endoscopy? So what did you appreciate the most for which kind of operation? And the second question is about the safety of this surgery. As you know, many people say that flexible endoscopy is not so safe because you have not a proximal control. So they have criticism about the possibility to damage the fornix or even the cerebral aqueduct. So in my experience, it's not like that, but I would like to know your experience about possible damages using a flexible scope.
The video neuroendoscope has a better visualization. That was the most important thing compared to an initial flexible neuroendoscope. The second thing about the damage, I still use the sheath of the rigid endoscope as a guide. Whenever I'm going to the aqueduct, my tip of the rigid scope, the sheath of the scope is parked around the foramen of Monro. Okay.
Oh, okay. Mm-hmm.
So that stabilizes part of your flexible scope. And from there, we go into the third ventricle aqueduct and other places. And if I'm using a standalone flexible scope, then what I do is I place the sheath just above the burr hole. So some part of the flexible scope is remain straight and steadied by the sheath and the stand. And yes, you have to know how much is the movement when you use the joystick of the flexible scope. What is the range of movement? There's a very high chance that you can damage the fornix if you do it blindly. So that small amount of experience, but as you do more and more, you will get the feel of it. But inadvertent damage I never had with this thing.
Thank you. I see Professor Schroeder raised his hand.
Yeah. Hello. Thank you for this nice presentation. I really like also flexible endoscope. When we start with aqueductoplasty, at that time we used it a lot to look around, and it's especially if you want to reach a temporal horn, you cannot get there with a rigid scope from a precoronal borehole. The problem what we have in Germany, and I'm surprised that you can use it in Italy, we cannot get a neuroendoscope with chip-on-the-tick technology because it's not autoclavable. And in Germany, they request that everything which is put to the brain should be autoclavable to destroy the prions for Jakob-Creutzfeldt or mad cow disease. You know, that's a problem. It's very pity. So we could make off-label use of an bronchoscope, but Stotz cannot give us certification. And if there is a problem, we get really trouble. That's really a pity.
Yeah, you are right. Actually, this is a very good point. I am very upset about this because, as you know, there is this problem with autoclave. I still use the flexible fiber optic scope because it does have EU certification because it was given many years ago. So I was lucky enough to be able to buy it before the European regulation got too much strict. Of course, I cannot buy. So we are now in a very strange situation in the European Union about flexible endoscopy. So if you want to buy a new flexible scope with a chip on the tip, like the video endoscope, which is much safer, right? Because you have a better vision, you cannot. Stotz does not sell. But you can still use the very old fiber optic flexible scope because it does have the certification. So it's a very strange situation right now.
The problem is all in my flexible scope, it's now 15 years old. Many fibers are broken. So you have always the black dots and it's very difficult to see anything.
Well, I have been very careful using my flexible scope. Being, you know, as I know about this problem, I take so much attention about my flexible scope. But you are right, there is a big problem of this.
Yeah, the flexible scope is actually, the initial flexible scope is actually a pediatric bronchoscope actually.
Right.
When I started using in 2008, it was a pediatric bronchoscope, which we started using it. But the new chip-on-tip technique and about the autoclaval, we send all these scopes for plasma, actually. We do plasma for all these things. We don't autoclave them. And the plasma is being considered equivalent to autoclaving. So, and they're absolutely safe. All these scopes go for plasma.
Can you please tell this to our hygiene guy?
Yes, please, that would be nice. Also because I don't know if I am right saying that, but I remember that autoclave temperatures don't destroy 100% prions. So this is the reason why instruments for neurosurgery must be autoclaved. But the reason is, I mean, not comprehensible, because autoclave does not destroy 100% prions. So you need higher temperatures. So I don't know who does these kind of regulations in Europe, but I think they must better study the topic, probably.
Yes, obviously. Yeah.
Thank you. Are there any other questions? So, Azmi?
That brings us to the end of the day, I think.
Your audio is muted.
Yeah, okay. I think we have maybe enough time for the all speaker to wrap up. So maybe we'd like to invite, before that, we'd like to invite Professor Chandra Sekar Pujari to give some remarks.
No, I think that brings us to the end of the day. And I would like Dr. Liu or Dr. Sachin to give instructions for tomorrow before we close. Thanks all the speakers for wonderful talks, and I think very nice interaction. I think we have answered most of the questions in the question boxes. So thank you, everybody. Sachin or Liu, if you want to take over for instructions for tomorrow.
Hello, Prof. Thanks to all our speakers. And tomorrow we start the same time, 5 p.m. Japan time. And probably we can have a speaker who wish to test their presentation. You can also join earlier. We can test before the 5 p.m. And we also have another 5 plus 1 now, 6 live session tomorrow before the closing ceremony. Thank you, Professor.
Thank you. So all the panelists, if it is possible for you, please attend tomorrow to make it more interactive. And thanks for your participation and contribution today.
Thank you.
Good night.
Thank you.
Thank you.
Thank you. Have a good day.
Yeah, have a nice evening. Bye-bye.
Thank you. Bye.
Bye.